Good morning, everybody. We're about to start day 7 of Grace Schara's wrongful death trial. Yesterday, we heard from Grace's sister. Grace's sister testified in such a way that the defense asked for a mistrial, said there was no curing what she did, which was give an opinion. Judge basically laughed at them and said, no, I'm denying that. So thankfully, we've got a cool judge. I think today we're going to hear more from doctors and potentially the executive staff from Ascension Hospital. Looks like we normally we've had a pretty good stream in the morning, but right around lunchtime, the stream quality seems to drop. I'm not quite sure what's going on. I will try to stay on it and make sure that it's working as much as I possibly can throughout the day. Unfortunately, the quality of the stream is quite low, and we just kind of have to play it as we go. So we'll be starting here in just a few minutes, and see you guys in the chat. The court had previously started right on time each morning, so I do expect this to start any moment now.
Chief President? Yes, I was. I ended up doing 2 years of it. Our one chief president had to leave, so got extra. Chief president sort of managed the residency or the residents in the group. So we had 40 total. So you work on their scheduling, guiding them, educational pieces. You're the liaison between the residents and then also mentoring the younger ones.
And are you fellowship trained?
I am. I did an additional year at the Mayo Clinic in cross-sectional or body imaging.
And what is, can you tell us what the significance to be fellowship trained?
So when you do a residency, it's very broad base. So you're doing all modalities, for example, neuroimaging, musculoskeletal and body. And then when you do fellowship, you really focus and do a deep dive on that specific part of radiology. So I spent a year doing that.
Then abdominal images?
Abdominal is sort of misnomer, but just because we included the chest as well, chest, abdomen, and pelvis.
All right. Are you board certified?
I am.
And what does that mean?
When you finish your training, you take an advanced exam. It's an oral exam and written, and just to make sure you're competent to go out and practice.
And is there anything else on your CV that you think might be of interest to the jury?
I spent a fair bit of my career working in the pulmonary and lung field, developing programs, doing education to the clinicians, and developing programs around screening for lung cancer and educating physician assistants at university just on anatomy and also radiology.
All right, doctor. I do want to talk about your current practice a little bit. My understanding is that you are in practice with the Midwest Suburban Radiologic Consultants.
Yes.
Tell us about that.
So the group, the reason why there's two names, Suburban Radiology Consultants, what I joined in 2003 as a group of about 35 people and ran that group as a group president for years. Subsequently merged in 2019, I believe it was, with two other groups and created the entity Midwest Radiology. And we have 165 radiologists.
You're from Florida?
I live in Florida, but I'm from the Midwest. I grew up in Western North Dakota.
On a farm, I think it was, right?
Yeah, Yeah, farmer community.
So I'm curious, the name of the group includes Midwest, but you are physically located in Florida. Can you explain that?
Yeah, so in 2021, the winters got a little tough. So I had the opportunity to move to South Florida, where I lived down there before, and I'm able to work remotely through there. So that changed my practice a little bit. I did a lot of work in the hospital and a lot of procedures as a radiologist, and now I just strictly read imaging coming through my computer system.
And in terms of the images that you review, what is the imaging that you review?
A large part of it is hospitals and emergency room, and then a portion of it is also from the imaging centers the patients come through. But I work into the evenings a lot, so I see a lot of the inpatients.
Is your group receiving images from throughout the country?
We are. The vast majority come from the Midwest, so Wisconsin, North Dakota, Minnesota, and let's see, we're constantly growing, but that's the big bulk of it.
In terms of your practice, doctor, can you give us a ballpark estimate as to how many films or CT scans, images that you might review in a given day?
Anywhere from 90 to 140.
And these are images that are sent to you electronically from hospitals and clinics and things like that?
Yes, about 25 different facilities or more.
Doctor, as a part of your practice, have you been reading imaging from patients that have been diagnosed with COVID-19? How about patients that have been diagnosed with ARDS or acute respiratory distress syndrome? So do you consider yourself familiar with I guess we'll call it the typical imaging you might see in a patient with COVID-19? Or I mean, are you able to give us any kind of estimate as to how many images, whether they be X-ray or CT scans, that you for COVID-19 patients or ARD patients since 2020 when the pandemic started?
It's a big number, probably around 5,000.
Doctor, you were retained by my firm to conduct a review of this matter,
I was.
and you are being compensated for your time.
I am.
Can you tell the jury what your rates are?
So for case review, phone conference, I charge $400 an hour.
Okay, and you're being compensated for your time in court today?
I am.
What is your charge for court?
So for the travel and trip, which is 2 days for me, $5,000 because I have to work for me down in my practice.
All right, doctor, you prepared a report in this case.
I did.
Your review, I think, been a little unique. We reviewed you we retained you to,
Yes.
and you conducted what's known as a blind review.
Yes.
Ladies and gentlemen of the jury, the process of a blind review.
So as it pertains to radiology, you review the images without information of the patient's condition, the diagnosis, the outcome, events, and also you don't get the information from the who interpreted the images to begin with. And the goal is the aim is to minimize the bias and create a more objective review.
We sent you a couple of batches of materials. You recall what we first sent you?
Yes, it was a series of images, X-rays, and one CT scan.
And did that first batch of documents contain the radiology reports?
Yes.
Have you any specific instructions as to the radiology reports?
Yes, not to review them until after I reviewed all the images and formulated my opinion.
And you received the first batch of materials from our office. Did you know what the diagnosis was?
No.
Did you know what the outcome was?
No.
The only thing you knew was the name of the patient.
Correct.
And is this a blind review? Is that a common practice in your area, your field of medicine, in terms of legal work?
I can only speak for myself, but it's a major part of what I do. I actually request it. Don't want to have that information, so I can actually do reading an X-ray or CT every day of the week.
So because you're conducting a blind review and doing your own read on these imaging studies, is it possible that at times your read of an image may conflict with the radiologist who actually read it at the time?
Yes.
And can you explain why that might?
Everyone has a different perception of degrees of involvement or how to describe things. Like I can ask anyone in this room to describe that wall, and we're going to get a lot of different views. Radiologists are no different. You know, you describe stuff, you try to use what you were, taught, but there are new variations or nuances around that. The ultimate goal is getting to the diagnosis and describing it correctly.
And at times where your review may conflict with the original radiologist read, are there explanations for that in terms of, for example, purpose of the X-ray?
The focus, yeah. So if they're being asked a question, can you talk about the left shoulder, for example, the focus there, and you're going to describe it and try to answer their question. And then there's always additional things on the periphery of the film which you want to look at and give them an interpretation of, but you're probably, the depth of it is probably not going to be as in detail.
You were subsequently sent Grace Schara's memo.
I was.
Had you formulated your opinions in terms of your read of the images before you reviewed the medical records?
Yes.
And so how did the medical records themselves then assist you in your opinions in this case?
Well, it allowed me to, as I read the medical record, sort of look at the images, and it sort of reinforced what I saw.
It gave you some clinical context?
Yes.
Based on your films and medical records, did you prepare a report?
I did.
Ed, can you, 41. Doctor, can you identify the document for us?
Yes, that is my opinion statement.
Move for admission. Before we continue on, can we agree that all of the opinions you give today will be to a reasonable degree of medical probability in the field of radiology?
Yes.
I want to talk a little bit about lung anatomy, basic lung anatomy. A board here that if you think it'll be of assistance, we can flip it around, and I think there's a pointer stick there with the court's permission. And for the record, this is going to be Exhibit 246. I'll have them identify it, and then you can see it from the backside, right? Okay, just flip it around.
I'll step down. Yeah.
Yeah, this Exhibit 246 is a diagram or board that you assisted us in preparing. And based on your review of it, do you find it to be a fair and accurate depiction of normal rest? Exhibit 246. We kind of feel like a little bit of a game show hostess here, but can you all see that? All right. Doctor, if you want to step down and take your pointer stick, kind of brings me back to my high school science teacher. That's the one.
It's a little shorter.
You can use it.
It's shorter.
Whatever works. Yeah, so if you want to step forward and kind of walk us through basic respiration. Able to hear him? Okay. Sorry to interrupt.
Sorry, everybody. He is not on microphone while standing in the middle of the room. He's just describing lung function, normalized lung function as it would be in any standard patient. What they're doing right now is the defense is setting up foundation for this expert witness who's going to testify to the likelihood of her having COVID-19.
And in terms of, I think the technical term, and maybe I've got it wrong, I'm not an MD, we're talking about perfusion as well here. And what is perfusion?
Impossible.
And I know we've got another exhibit that'll help us with lung anatomy and COVID, but why is perfusion important? All right, doctor, is there anything else over here? All right, don't go anywhere, because I think we have another exhibit. This is going to be 248.
They're basically setting up for the argument that she died of
Doctor,
COVID-19. And that's the question will be on cross to say whether drugs could have caused her issues or not.
Board? Is this a board that you helped assist us in preparing? Do you determine that that is a reasonable and accurate representation of the images that you're about to discuss? Yes. All right, doctor, I move for admission. All right, doctor, the floor is yours. Tell us what we're seeing here. So why did everyone see what? So when you take an X-ray, it's pretty about both. And it's still behind you. So when an X-ray hits dense material, it goes down. That's how it's figured. So the lungs are filled with air, for the most part. And it's here. This is what normal lung should look like. Fluid action. They have to draw a line. Then we're going to look at today more advanced way of looking at the body. It's like doing multiple X-ray body. So multiple. All right, and then you have a couple of slides at the bottom. Yes.
Here. They're very well outlined. And that's the information. Whereas during the time of COVID, when patients better, a lot of times they had that positive, that they would show a whole lot. So they went early on. One admission.
All right, and you want to talk about the anatomy of, all right. Doctor, this, and this is exhibit 248, I believe it is. 47. Is this a diagram that you assisted us in preparing? And as you review the exhibit, is it fair and accurate representation of the effect of COVID on lungs and the anatomy associated with that? Okay, can you tell us what we're seeing here?
And when it breathes in, and because of the virus, the body responds to it. Which is killing that virus, but also everything. So what happens in the during COVID, there's a lot of clinical problems. They are either head cells, but doing that here, that you have a even breathing. Therefore, then get rid of not only the airway, so you have left line coming through it, you go. It's only going to be over, maybe some. It really decreases the amount of oxygen. That's why coughing is trying to bring that up. Now, yeah, how bad it is. It's taking out a lot of it can't function.
Anything else that you feel we need to highlight off of this exhibit? All right, Doctor, you can probably take a seat, and what we're going to do is show a couple of images that you reviewed.
I'm going to try to log in here first. Bear with.
Hold off on that one.
Okay.
We're first going to look at exhibit 231. Are you able to identify this document, Doctor?
This is Grace Schara's chest X-ray on the 6th of October on admission, and this was a PN lateral chest.
And is this one of the images that you relied upon in reaching your opinions in this case?
Yes.
Please describe what, and if you need to use the pointer, please go ahead.
Okay. So now that you know what a normal X-ray looks like, we see here the X-ray. All right. This is the heart border. This is the diaphragm on each side. Okay. Ribs, bones, clavicles. But what we notice is it's not as dark or black as the other, particularly right here. So, and then there's a more subtle area here, which I call patchy. This sort of round, very thin, white. So when we talked about action, those areas Well, so now the X-ray, when it hits it, it stops. And that stop, then the X-ray actually creates that white appearance. Up here, we see a little bit better. The air is more dark. So there's air getting in there. It's here as well, but the X-ray gives us a picture of what we call infiltrates and consolidation.
You mentioned consolidation and infiltrates. Can you first tell us what infiltrates are?
So infiltrate is a semi-generic term, but it's whenever there's doesn't look like it. So when it turns hazy or white, we call that, and that means there's something in there. It can be a lot of things, but in the setting of infection, it's an inflammatory process.
Doctor, as you review this image, is this image consistent with radiological presentation of a patient with COVID upon admission?
Well, experience, I've seen a vast array of presentations with COVID. Many X-rays are negative; they look normal, and that's what CT is. As a matter of fact, that first CT I showed, where it was the geographic areas, even with that degree of infiltrate, sometimes the X-ray doesn't show it that group. It's only until it's more advanced to where everything is sort of, we call it, those airways are sort of filled with mucus and free inflammatory cells to see it.
So when you talk about a CT scan, doctor, if I understand your testimony, it's sometimes, for example, on admission, the X-ray may undersee the degree of infiltrate, consolidation, et cetera?
Absolutely.
And is it then important to have a CT scan done?
It situation. If this person, comes in off the street and say that my family has pneumonia, say, yeah, we have pneumonia. You have pneumonia. But when there's concern, like an X-ray can underestimate things. I call it the tip of the iceberg. You might see a little bit, but there's a lot more behind. And depending on working up a patient, you have to just make that decision. The reason why we started doing more CAT scans during COVID was people were developing blood clots in the lungs. So originally we just did a lot of chest X-rays. And we learned a lot once we started doing CTs. We were blown away by the extensive nature of lung involvement by the inflammatory process.
Okay, is this a radiological presentation of a patient? Is it consistent with a patient who has moderate to severe COVID-19?
Yes, moderate inflammation because of the consolidation and the extent of infiltrates, and in this situation, this was COVID.
All right, doctor, let's talk about CT scans a little bit here. I guess let's start with maybe a tutorial on how a CT scan works in general.
Okay, so an X-ray is you're standing up, the machine shoots photons through you. A CT is no different, but you're laying down and getting 30 to 40 views, and that's how you can see the entire anatomy in detail, because it's and then it goes to a computer and it recreates that picture for you. So when we go through a CT scan, you're going to go through and you're going to see front, back, middle of the lungs versus an X-ray. You're just seeing a projection of it.
And Grace had a CT scan done at the time of admission?
There was one done the day of admission, a little later in the afternoon.
All right. And you reviewed that image? All right. Matt, can you pull up 233, please? I want to be a little specific here, doctor. This is, I guess, what I'll refer to as a step of the CT image?
Yes, it is one slice.
One slice. So the concept of slices.
Okay. The analogy would be, okay, if you turn the loaf over like this and you take each slice, you're going through the body with each slice, and that's what a CT produces. So you scroll through it, you're going to see a series from the top all the way through the diaphragm.
And an image that you relied on relied upon in formulating your opinions in this case?
Yes,
Now, you kind of talked about the different slices with this. Is that something that you're able to demonstrate for us?
I can. Yes.
All right. Why don't you go ahead and get your
Okay.
structural radio software going?
Okay. Yes. So to try to compare apples to apples, I wanted to put Grace's chest X up, and that's on the left side, right here. So we already went through that. And on the right side is the CT, and what I'm going to do is just go to the same area, if you will. I'm just going to window it so we can see the lungs. Okay. So here we have the CT, and this is in the upright position, just like the X-ray would be obtained. And we see the heart in the middle, okay? And then we see the lungs here on each side, right and left. Now, obviously, the heart takes up a lot of space in that we go front and back. You're going to see more and more of the lungs, okay? But this is that, if you look right here, that's abnormal. Anything that you see white, with the exception of the small rounded structures, are going to be blood vessels. So I'm just going to scroll through, and we're going to go start in the back first, okay? So let me get this in windowed each time. And because when you lay down, things sort of gravitate, gravity does it, so all the debris and everything goes into the lung and the back part of the lungs. But if you look at her lungs at that time, and I believe 4:06 p.m. and the x-ray was at 12 or noon. Look at this, is all consolidated lung here. And that honestly occupies half of her right lung in the back part. And on the left side, it sort of comes up and around this way. You can see my, so that's all, it's all socked in. Those are all inflammatory cells. That's debris, mucus. And then I'm gonna move forward here. So we're getting towards the mid lung, but you still have a lot. Healthy, normal lungs should look just like this. See that black area? So even where we see this dense, what I call consolidation, and that little line right there, that's the airway going to it, trying to get oxygen to that sick lung. But even up here, if you look, it just has a hint of, it's gray. That should be black. So even at that point, there's involvement throughout the lungs. And then I'm just going to move to the front part of the lung here. And again, we see more. This would be considered like on the right upper chest, right upper lung right here. And then on the margin, we see a little bit of infiltrate right here. So there's quite a lot of involvement of the lung, and frankly surprising when you look at the x-ray on the left. It'd be hard to believe that that's all in that chest. So I believe a combination of two things. Number one, the iceberg. Two is that there was some advancement in those short 4 hours, the infection getting worse.
As you look at that CT scan, doctor, are you determined from the perspective of a radiologist as to whether there were areas of her lungs that were not functioning at that point?
Yes. So when you have something like the consolidation, it's no different than that picture I showed you where those alveoli or the air sacs are completely full. There's no air getting into that. There's no way that lung can be functional, meaning do what it needs to do and get rid of the CO2 and take up oxygen.
You mentioned that you believe that, like you said, advancement. Would deterioration be a fair word to use here?
Yes.
Within the time between the X-ray and T, would you consider that to be rapid deterioration, moderate deterioration?
I was surprised to see it. I'd say moderate period of time.
So when you say you were surprised, you had reviewed a lot. Had you reviewed images related to COVID patients before you saw these?
Yes.
you're surprised. Is this not, is this atypical of what you were seeing in terms of film studies that you did with other patients?
I wouldn't, the term atypical would be not appropriate. I'd say this is much more advanced. And when I talked about that, I showed the geographic areas on the, that's what we always expect when we see early on, with an X-ray, which shows some, but not a whole lot of findings. And so the reason why is just the advanced areas of dense consolidation of that lung throughout both lungs.
All right. Is there anything else that you want to show us with this?
No.
Okay. Doctor, we're going to go through a series of the images from Grace's medical chart. I want to start with, I think it's the 10-7-21 portable AP chest, speed to the 234. Is this an image that you reviewed and relied upon in reaching your opinions?
Yes.
And move permission of exhibit 234. Any objection? 34 is received. Doctor, can you describe what we're seeing here?
Yes. So I'm going to use the pointer again. So this is a day after, or what time was it? 9 p.m. So about a day shortly after. So we're looking at the chest film again, and we go back to where she had pneumonia on the right side. That rounded. It's getting a little bigger. You see it. Now, the big change though is coming up. And the dentist part is right here. You really progressed in that one day. Progression about those film traits. You recall the CT. What we're not seeing is the areas on the CT that involve all the way up on both chests and posterior chest has been consolidated. But this is how chest X-ray will actually represent the finding of CT. So most importantly, this is where the greatest advantage in that update.
Okay, doctor, thank you. The next image, 35. I believe this is the October 8th, 2020 chest. If I have that right?
Yes.
All right. Tell us what we're seeing here. This is just to kind of follow the timeline. Upon admission, she has an X-ray. Later in the day, a CT. X-ray is done on the 7th, and now we're day 3 into the admission or so.
Again, I believe what we're seeing is just the areas that we see on X-rays are moving further and further up in both lungs. If you put your attention right in this area, this appears to be a little bit more hazy as it's this. So I thought there was progression up as well. And this has not dramatically changed. For the most part, it's quite dense. And then we know there's pneumonia right here where that rounded area consolidation, that's sort of losing its margins because the lung adjacent to it is now becoming inflamed and having that series of consolidation.
And as there's a progression here, doctor, with each progression, is that having an impact on the ability of the lungs to function?
Because
How so?
more and more of that functional lung now is being affected by the fluid in those little air sacs. So you're limiting the ability of making that oxygen transfer through those areas. So you less is healthy and functional.
Hey, doctor, this is the portable AP chest PM 236.
And they're,
Sorry, Mark.
I believe it shows more of the same findings. This is just in the evening. Again, this area probably right now looking dense. As I said, it's involving the lung around it. We still have the lung, and these are just becoming subtly more. And it was the same day, so it's not changed. the upper ones.
230. Doctor, I believe this is the image from the October 11th, 21 portable AP chest. Can you confirm that for me?
Yes, October 11th.
And this is an image that you relied upon in formulating your opinions in the. Okay, doctor, please tell us what we're seeing here.
This is where I feel a lot of things changed. The mission. If you look appearance in detail, of course, the lines become a little bit more, okay, streaky appearance, and we're losing the margins of. So now it's becoming diffuse, posterior, anterior. It's just becoming quite dense all the way up to here on both sides. And the other thing is when we first saw the normal anatomy x-ray, I said you can draw a line around the normal structures, the heart, the diaphragm. Of the diaphragm sort of losing, it's sort of becoming almost blending. Even with the heart border, you sort of have to squint a little bit, that vein is still there. And what that means is it's becoming as dense as those structures, not only in front of it, behind it on the x-ray.
So based on this image, doctor, we believe that at this point in time, seeing here it was affecting Grace's lung capacity?
Without a doubt. This has the pictures. Clinically, they call it respiratory distress, ARDS. We would call it in radiology diffuse alveolar damage. All those little air sacs are being affected by the inflammatory change.
And would it be fair to say that there are increasing portions of lungs that are just simply not functioning at this point?
Yes.
The last image I want to show you, doctor, is from the October 13th, 2021 portable AP chest, exhibit 238. Doctor, this is an image that you reviewed in this case,
Yes.
and it was important to you in formulating your opinions in this. Tell us what we're seeing here.
This is a little different than the previous studies we looked at. This was obtained to define the tube that they placed into Grace's stomach. See the white line down, okay? And that's the tip of it. So when they do that, the focus is not going to be on the chest. They actually changed how they take the x-ray. So we'll be above the center point of the image. So we're sort of all focused in the upper abdomen. Here we see the diaphragm. This is the tip. This is going to be in the stomach. This air bubble here, that's the stomach that has air in it. It's interpreted by the radiologist and to verify that. And then we have additional findings of that. And as I said, that's going to be on the perf research to describe those as well. And to me, what it's showing is more advanced inflammatory changes, consolidation and involvement of the lung. And what I mean by that is, remember the lines I showed you where you could see the diaphragm before? I can't define it here anymore. Here we sort of lose it. This is the rib margin there. It's not the diaphragm, but we're losing it because you see all that white covering it and masking it. That's the inflammation. Our border is completely gone here. And we can see that on the 11th. And we're starting to lose it right here. But now the haze goes all the way up on both sides. Here, see that we call it the top of the lung. So this would be extensive involvement of the lungs.
Review, doctor, first of all, do you believe that this was for diagnostic purposes in terms of her lung condition?
No.
What was your understanding of why this x-ray was taken?
Verify, we call it verified tube placement. Tell the clinician where the tube is because before they use it.
And I think you referenced the radiologist report on this. Matt, that's 230. I know it's a little bit of a curveball, I apologize. Oh, Matt, you hit it out of the park, thanks. You reviewed this document?
I did.
And the radiologist's impressions and review from this image. I want you to take a look at his findings and what he says with regard to the lungs.
So patchy, bilateral, mixed interstitial, and alveolar filtrates unchanged.
We talked a little bit earlier about how sometimes, the different radiologists can read the same X-ray and come to different findings. If I understand what you're saying, you're not necessarily saying that the radiologist read this incorrectly. Is that right?
Because the focus was answering the question for the ordering doctor, where's the feeding tube.
And when you reviewed this image, you were specifically in terms at what it was showing with regard to lungs, not necessarily the NG tube placement. Fair?
Correct. Yeah, I'm focusing.
As we looked at the image from the 11th and the one on the 13th, let me strike that. Was there a progression of Grace's lung condition? It deteriorated further.
Yes.
All right, doctor. I think we're back to the boards here. Is there anything about this board that you wanted to show us before I take it down in connection with what you've talked to us about?
The only final point I'd like to make, this is the personal case I saw. X-ray should be very important.
So we also created a little bit of an overlay, coloring in some things to maybe help us of what we're seeing. And you reviewed the overlay here with the coloring?
Yes.
And it's a fair and accurate representation of what these scans show with the coloring? Okay, want to.
So this normal. This shows CT analysis. What this is just doing
All right, so then the next thing I want to show you, Doctor, one of these boards, it's been marked 249. And did you assist us in preparing this exhibit?
Yes.
And is it a fair and accurate representation of the sequence of some of Schara's chest X-rays?
Yeah, this includes all 6.
Can you walk us, kind of give us the overview and tell us what we're seeing here?
I think the biggest part of this is look to how the changes right point when you sign not identifying margin of the diaphragm in the part borders.
Doctor, based on the imaging that you see here from October 13th, 2021, based on your education, training, and experience, are you able to give us an estimate as to what Grace's lung capacity was on October 13th, 2021?
So as a radiologist, you will continue to say,
And last, Doctor, we prepared a similar overlay to the last one. And And again, you reviewed this.
I did.
And in terms of where the different colorings in, is that a fair and accurate representation of the extent of the infiltrates in Grace Schara's lungs on these various images?
This is what I described each image, how seeding areas, the white areas.
All right, doctor, you can have a seat. Thank you for walking us through all of this. Doctor, based on your education, training, and experience in your review of Grace Schara's radiological studies and medical records, do you have an opinion as to whether Grace Schara's images are consistent with the progression of COVID-19 ARDS? Opinion to a reasonable degree of medical probability in the field of radiology?
I do.
What is that opinion?
There is progress from the 10/6/21 film through the 13th, which on the 13th is severe involvement of both lungs.
Based on your education, training, and experience in your review of Grace Schara's radiological studies and medical records, do you have an opinion as to whether the condition of Grace Schara's lungs improved during her hospitalization?
No, they progressed.
Is that an opinion you hold to a reasonable degree of medical probability in the field of radiology? Education, training, and experience in your review of Grace Schara's radiological studies and medical records, do you have an opinion as to whether the infiltrates and the level of consolidation of infiltrates is diagnostic evidence that Grace developed respiratory failure? Your opinion is yes?
Yes.
And that is that an opinion you hold to a reasonable degree of medical probability in the field of radiology? Doctor, have all of your opinions today been given to a reasonable degree of medical probability in the field of radiology?
Yes.
Examination.
Thank you. Ms. Doc, good morning. My name is Michael Administrator, and I have a few questions for you based upon your testimony today.
Good morning.
Let's start with the fact that you indicated to this jury that you charged $5,000. Is that for both days, for 2 days?
Total.
Total. Yeah, despite the amount, actually, you're on the witness stand.
Yes.
$5,000. Okay. And it's my understanding that you've been doing reviews and testimony since about 2008, I believe.
Yes.
Right?
That's correct.
Yeah. And in that time, do you typically charge for those services, for the review of films, for testimony given in depositions, and for live testimony? That's all of those things
Yes.
are independent charges, right?
Yes.
And how many of those would you estimate you do in a calendar year, for instance?
It's extremely variable. Early years, maybe 2.
Right.
It goes up, I'd say more since 2022, probably maybe about 7 to 8.
7 to 8 case
Reviews. Yeah. Or
per year.
yeah, maybe a little bit more.
Sure. And those funds go directly to you?
Correct.
And of those 7 or 8 per year, wouldn't you say a vast majority of those are on behalf of defendant doctors?
Yes.
Have you ever testified on behalf of a plaintiff?
Yes.
Medical malpractice case?
Yes.
Only was that?
I have currently 3 or 4 cases going on for the defendant. One was actually already dismissed. Not the defendant, or the plaintiff. And so I pretty much just accept all cases. I do my review frequently when I don't know the law group. I don't know if it's defense or plaintiff, but the vast majority of the cases I have done have been
Let's make sure by your opinions in this case, you're not going to offer any opinion to the standard of care of either Dr. Shokar or the nurses in this case.
no.
You're not going to offer this jury any testimony will assist them in determining what we call proximate cause or the cause of grave, correct?
Can you explain that a bit more?
I don't want to get into a legal definition per se. I guess the better way to understand the question is your role in this practice is, or in this exercise, to interpret radiology studies,
Yes.
period.
The films, yes.
You interpret the films.
And also tell, based on my experience,
Tell what?
the severity of the findings.
Right. And you'll agree with me that there's no metric in your area of practice that helps you in terms of severity of the disease process.
It's
Correct. It, to me, during your direct testimony that Mr. Goosey was asking you some questions about your opinions of these films, and I'm focusing specifically on the chest x-rays, AP chest, portable chest, right?
Yeah, and there was 1-2 view on the 6, but that's it.
1-2D.
2 view chest. The others were all portable.
So those are all portable. Ladies and gentlemen of the jury, what you meant by that.
Okay, so when you acquire a chest film, you can either be standing, and the first film we review, the person is standing, and they take the X-ray, and it goes through the backside of you to the film in front. And the portable frequently is done either in the radiology department or in the patient's bed, to where they put the film behind and they take the image from the front.
And I've noticed with regard to these radiology reports that they often are indicating the chest film AP CXR. So the jury will see that if they review any of these radiology reports. And could you explain to the ladies and gentlemen of the jury what a radiologist means when they define a film as AP?
Yes. Okay. So anterior, posterior. So the photon comes anteriorly and goes posteriorly into the film. Whereas a PA, it goes posteriorly from the patient into the film.
From the patient's back
Back.
into the film, which is positioned on the front of the patient or the anterior of the patient, correct?
Yes, sir.
Okay. And so in order to do that in a patient like Grace, talk about a portable chest film, she wasn't taken from her room in the ICU and brought down to the radiology department, correct?
I don't know that for a fact, but that's common practice to do for the patient in the bed.
Correct. So what you do is, based upon my understanding, is a radiology will go to the patient's bed, assuming they can't come down to the department, right?
Yes.
They go to the patient's room, put the film behind the patient, and then shoot the radiation beam through from anterior or front to the back where the film is positioned behind that patient.
That is correct.
Correct. And the fact that it's a portable film creates some potential for artifact. Or maybe that's not the correct term. Some potential for a less than optimal view. Fair enough?
It can be, particularly if the patient does breath in.
Exactly. So the quality of the film is somewhat dependent on the ability of the patient to take an inspiratory, a very deep so that it inflates the alveoli of the lung, correct?
If they can be inflated, yes, sir.
Right, okay. And you seem to, late in the direct examination by Mr. Goosey, he was pointing out obviously the report from Dr. Asbury, who gave us the read on the 1013 film, right? Portable chest,
Abdomen.
on 1013. It's exhibit 230. You've seen that.
The portable abdomen.
That's right, portable abdomen. And you, ladies and gentlemen of the jury, that film was taken in an effort to determine placement of the NG tube, right?
That was, yes, that
That
was.
wasn't actually taken in an effort to determine the extent of the damages to the lungs, correct? I mean, the purpose of taking that film.
Correct.
Correct.
The indication.
Correct. And despite the fact that it's a portable abdomen chest, a portable abdomen X-ray, it does help to show us some of the lung, although that wasn't the intent.
Yes.
And it seemed to me, pointing out that you have a disagreement with Dr. Asbury, Corbin Asbury, based upon his interpretation that was done on 10/13/2021.
A difference in interpretation, I would call it, yes. I focused specifically to look at the lungs and say if the question was, is there a difference between those two chest x-rays as well as far as the infiltrates go? A difference, and I gave my opinion on that.
I get it, sure. You would agree with me, would you not, that the area of medical practice is really quite subjective, is it not?
It's I wouldn't discredit it to that degree. You find the findings and you describe them, and the way of describing it can be a little subjective between radiologists or some subjective, but I wouldn't say that everyone's going to have a different interpretation of the films to say there's nothing going on versus there is, to that extent, if that's what you're asking.
Oh, no, I'm not going that far. I respect the fact that you wouldn't expect a trained board certified radiologist to say nothing's going on and another one to look at the same radiology and image and say, oh yeah, there's a lot going on here. I'm talking about a difference in the severity of the disease process that you see on the imaging.
Yes,
It's certainly open to subjectivity, if you would.
that I'd agree with you. Yes.
Yeah. Oftentimes they say medicine is more of an art than a science, do they not?
Yes.
And this is one area where that's really pointed out.
Yeah, it can be difficult.
Sure. And I noted from your experience at your CV that way back when, 90s, while at Tampa General Hospital in Tampa, Florida, you completed an internship in internal medicine, right?
Yes.
And that's a typical route that many radiologists in your profession take. Fair enough?
My year was the first year it was mandatory.
It was actually mandatory.
Mandatory for radiology. Yes.
Okay. And maybe you could explain why it would be mandatory for a person with your training to go through a full year of internal medicine.
I think it's very important to understand the science around you and the people you're going to work with, the cardiologists, the pulmonologists. So you actually work in those fields for that period of time, and it's very involved. And so you get a better understanding of clinical medicine. Now, radiologists are sometimes, they think you're in a black room and you don't do much with the patient. Well, that varies. I did a lot. I did a lot of injections and I did drains of lungs and pulling out fluid. So I had a bit more clinical involvement, but I think to your point, it's very important for us to walk in their shoes and know the patient's proper.
I mean, if you didn't do that, we could probably have robots do this type of an examination and give an interpretation, right?
Yeah.
And so in your training, in your 1-year residency, for instance, did you rotate through the ICU?
Yes.
So rotate through the ICU as an internal medicine. And before I get ahead of myself, because I don't think we've ever actually defined this for the jury, but what is internal medicine? If you could just briefly describe what that means.
It is rather broad, and you have family practice medicine, but it's almost a holistic approach to the patient. So they focus on a lot of different things, advanced things, where they take care of you. So when you go to see your doctor, that's probably who you're seeing, and they'll manage everything from infections to chronic disease, diabetes, asthma. So they have a very broad spectrum of you that they cover. It's a very tough job, and then you have the specialist when it's something that they can't manage on their own, to those very specialists. That's how you end up with pulmonologists, cardiologists, neurologists, if that makes sense.
Right. Those are all further specialties, and most of those physicians probably did a rotation through internal medicine also, right? Residency in internal medicine, right?
They have to, yes.
Yeah, sure. It's helpful for you to understand the whole body, the whole science medicine of the body. I'm probably not saying that very artfully.
I know what you're saying.
For your benefit. Okay.
Yeah.
So I guess my point is, and you've indicated to us that you did rotate through the ICU. Were you able to appreciate patients that were on certain medications? Treating patients that were on certain medications?
They were all, yeah.
They were all on medications.
Yeah, if you're in the ICU, you're going to be on medication.
Right, right.
But that's just because of
the nature of the beast, so to speak. Yeah. Those are very sick patients.
They are.
They wouldn't be in the ICU if they weren't. And so typically they're going to be a whole host of medications.
Yes.
Correct. And were you ever, your rotation through, or your residency and your rotation, did you ever encounter patients that were on Precedex?
That I couldn't, yeah, I wouldn't remember if I did.
Okay.
Frankly, that's been 20 some years ago.
Right. Okay. Based upon your examination of this case, you obviously became aware at some point, although I know you did a blind read or a blind review, you obviously must have come across some of the medical records which indicated the medications that fair enough?
I did review the medical records, yes.
Right. And so in the medical records, were you able to appreciate that she was on Precedex, lorazepam, and morphine while in the ICU?
I read that, I assume, yeah. I didn't focus on the actual drugs.
Okay.
Yeah, that was very focused. I was doing radiography.
I understand.
Yeah.
Sure. So take it then that you're probably not aware of the package insert that applies to Precedex. This jury has heard testimony, a lot of testimony about those three drugs, and they've also seen the package insert for Precedex. And so it's an issue in this case, and it's an issue that they need to consider. And so my question to you, yeah.
If we could have access to the screen.
Doctor, while we're trying to get that image up on the, I want to be perfectly clear that you've already established for us that you are a radiologist and that your only testimony today is to talk about your interpretation of these chest X-rays that were done and the CT scan. Fair enough?
Yes.
It's been admitted, it's in the court.
Or received.
Or received, sorry. I'm not sure. Hang on a second. Exhibit 37, Your Honor.
So members of the jury, we just had a discussion here at the sidebar. And I think it's clear that this witness has testified that he's not offering any opinions regarding the standard of care, which will be some of the questions that you get asked on the verdict form. And then I am going to allow counsel to ask him questions on medications and the effect of medications. And if he knows, he can answer. And if he doesn't know, he'll tell us that he doesn't know. Okay. So
Thank you.
Good.
So with that sort of warning in mind, here's the question. Are you aware that among adverse effects of Precedex, which that is the first, the first page of the page 13 of the package insert for that drug? Yeah, where the since you are certainly an expert in reviewing films related to the lung, and I thought you outset the chest, you're sort of focused on chest. Fair enough, right? That among the adverse effects that are package insert for Precedex are adult respiratory distress syndrome, or what we've been calling ARDS, apnea, obstruction, bronchospasm, coughing, dyspnea, emphysema, hemoptysis, hypotension, hypoxia, pulmonary congestion, pulmonary edema, respiratory depression, respiratory disorder, respiratory insufficiency, increased sputum. So all of those things are listed in the package insert related to the drug Precedex. Are you familiar with that? No. Okay. Thank you. I don't want to try and get you outside your lane, so to speak.
Yeah,
right? But
I would just say, I think
just-
they listed everything possible known to mankind on that list.
yeah, that is respiratory in nature. Right. So you've just to sort of narrow down the scope of your testimony, and I hope I'm not repeating myself, but I think that you've made it very clear that you're not offering any opinion on the cause of death of Grace Schara, correct?
No, I'm just telling what the X-rays show and the
Right.
severity of it.
Right. And you're not offering any as to Grace's likelihood of survival on any given day, correct?
Correct.
From 6th through October 13th of 2021, isn't it fair to say that Grace's lung condition was getting progressively worse?
Yes.
And by October 13th, you described her as having severe infiltrates and consolidation. That's shown on the radiology imaging, is it not?
Yes.
And you testified that this would certainly explain the patient's respiratory failure, correct?
Yes.
So in just 7 days, from 6th to October 13th, Grace went from what you called mild or moderate infiltrates to severe infiltrates, correct?
For the X-ray.
Right.
And then when the CT was done later that afternoon, it was a lot more advanced. Description.
That's a fairly significant deterioration in her lung in a fairly short period of time, is it not?
It sort of tells you more what the X-ray shows or doesn't show, the extent of these or the inflammation.
You know, I want to talk about CTs for a minute because I don't know that the lay jury have really had a lot of exposure to that thus far in the case. CT stands for computed tomography, correct?
Yes.
And you described that as this process where the patient is put into a scanner and there are beams of radiation shot basically all around the body. It sort of rotates
Spirals.
around the body, right? And therefore gives you a view which is entirely different, if I can use that word, from what we get on a portable chest X-ray, correct?
Yes.
Yeah, and it's a better tool in order to determine a patient's what's going on with the patient's lungs, correct?
It's more sensitive. Yes.
It is much more sensitive. Also much more expensive,
Yes.
right? Do you have any familiarity in your practice what the cost is of a CT scan?
I used to run our group, so yes.
What would that be?
It is extremely broad variation between payers, Medicare, Medicaid, and paying for cash. For example, hospitals in general, I mean, I don't know the specific. It can be anywhere from $1,000 to $3,000.
Right.
For a CAT scan.
Yeah.
Now, what actually gets paid is a lot different, as we know.
Yes, as we know. If the CT scan is much more sensitive and therefore what we would call, I don't know, would you use the term gold standard?
Depending on what you're looking for. For Grace's case, I believe it was done to look for pulmonary.
Right.
And with COVID, we saw an increased jump in the number of people. So I believe that was the reason it was done, if I'm not mistaken.
And that she was admitted to St. Elizabeth's primarily because that facility, that hospital, had the ability to perform a CT scan on her. Wouldn't that make sense?
I can't comment on that.
Right. And yet, the only CT scan that we have in the records that were to you and to us, frankly, was the CT scan that was done early on, and they never repeated it, did they?
Not that I'm aware of.
Right. I want to point out on Exhibit 230, which is the Department of Radiology report of that abdomen for tube placement. If you can take that down, go to 230 for me. We've got that on the screen right now. Once again, this gentleman, Corbin Asbury, MD, is the person who signed it, and a member of Radiology Associates of the Fox Valley. So he does things similar to you, correct?
I
A
would
radiologist?
just tell you he's a radiologist. I don't know what he.
Of course not. But we know that he read this abdomen for tube placement on 10/13, correct? And he listed right down there below the word technique, it says person. So he's telling the physicians who are interested in reading his report that there is a portable, the comparison is to a chest done on 10/11/21. Fair enough?
Yes.
And isn't it true, doctor, that you do a comparison between a previous film of a similar type to determine whether or not there was any progression or improvement of the lung disease?
Not necessarily. That's not the question that was being asked on this exam. It is, where's the tube? And the reason why you look at the old exam is because if the tube was placed earlier, you want to actually know if it's migrating distally. That's the purpose.
Have you seen in the radiology studies that have been provided to you that the NG tube had been placed prior?
No.
Right. So as a result, let's be fair, this would not compare to a prior film in an effort to determine whether the tube had migrated or had moved.
Not until you look at it. You
Right.
don't know.
And in his findings, which we've highlighted below comparison, his findings are patchy bilateral mixed interstitial and alveolar infiltrates unchanged, right?
Yes.
And what does that mean to the lay person?
What he's saying it is that he did not see a difference between the two x-rays.
This is a point of your dispute with this particular interpretation, correct?
Yes.
Okay. The subjective nature of what you do.
True. And I also think strongly stated there, if you look at his impression, what is he focusing on? Where's the tube?
Sure.
About the gas distension of the stomach or anything that is actually new.
Got it.
So it's the question they asked.
So would you be able to opine on whether, if a patient is recovering from an overdose of Precedex lorazepam, whether or not, or how that would impact the that you saw on the 13th of October?
That's out of my wheelhouse.
Okay. So your imaging studies can't tell you why Grace's condition was deteriorating, correct?
No, I just can tell you that it was deteriorating.
They can't tell you whether appropriate medications were being given, correct?
Correct.
And they don't tell you whether she was receiving appropriate respiratory support, correct?
Correct.
Tell you whether the nursing staff was monitoring her properly, obviously.
Correct.
And they can't tell you whether any medical decisions contributed to her deterioration, correct?
Correct.
You don't have an opinion. We've already don't have an opinion on causation, on the cause of her death. And you don't have an on interventions. In other words, whether different medical might have prevented the progression of her disease, correct?
Correct.
If I could just have a moment to review, Judge, I could be very close to
Okay. We're just going to finish this witness and then we'll take a break. And then the question that I received from the jurors, follow-up that I would maybe like that person to answer just by writing a note is that wait for lunch or is that something that needs to be now? And just get the bailiff, please. And does the bailiff have another note? Is that?
This is a question.
Thank you, Judge. I don't have anything further.
Okay, back to you, Attorney Guzzi.
Just one question or so, Doctor. When we look at that radiology, the read by Dr. Asbury, if we take him at his word and he describes it as patchy bilateral mixed interstitial and infiltrates unchanged. The X-ray still was bad.
Yeah, they weren't going away.
It was getting,
They weren't improving.
and even the X-ray on the 11th was in terms of diagnostics and what the progression was severe,
Yes,
drastically affecting Grace's ability in and expired carbon dioxide.
with that level of lung involvement, I would agree with that. Yes.
If anything, we're talking a matter of small degrees here. Thank you.
Attorney Franco. Administer.
One question. The plaintiff's expert, Dr. a professor of medicine, an ICU critical care specialist at University, has already testified to this jury, and he indicated in his testimony that in his practice, he sees hundreds of films and does the initial read. Obviously, he's not a board-certified radiologist, so they would send the film to someone like you for what they call an overread. Is that fair?
No, because not creating an official report.
Of course.
When there's an official report, that's termed overread.
Okay.
Reader.
You're the primary reader, right? He testified that he's seen worse lung film images in a 54-year-old suffering from COVID who survived. You wouldn't have any reason to dispute that testimony, would you?
I can't dispute that. I'm sure he's telling what he.
Right. Thank you. No further questions.
Attorney Guzzi, anything? Okay, so just by a show of hands, how many of the jurors have questions for this witness? Just one, two? Okay, so if we can pass those down to the bailiff, and if the bailiff can bring all the notes up to me first, please. All of them. And there's one more. I'm just going to separate the one out that's not a question. Okay, so what we're going to do is just take a morning break. I just handed a message to take a break. And then my understanding is that the other juror is good waiting. If that's not the case, just let the bailiff know when you go back to the jury room, because we want to accommodate you and not trying to make it uncomfortable for anybody. So if that juror who said it can wait till lunch, if you really needed to do it during this break, it's not a big deal. You just let us know and allow. And you can just do that confidentially with the bailiff. And then I'd like the bailiff to come back in right away and let me know. At this time, we'll take a break. Are excused. All right, everyone may be seated. Dr. Binstock, you can stay here if you want, or you can step down, whatever you're comfortable with. We'll know how long it's going to be in just a few minutes. You can stay? Okay. Counsel, you want to approach, I've marked as exhibit 551, two different pages. I'm going to seal exhibit 551, just given the nature of that information from the jurors. But it's what I was referencing, and you have a better understanding what I was referring to with the jury. It's 2 pages. The first page was the initial request. Then I asked if it could wait till lunch. And you'll see on the second page what the answer was. So it sounds like the juror can wait till lunch, but we'll see if that's, I don't want to make them uncomfortable. I also received a note in that packet from the juror, the other juror, that she needed a break right away with that personal issue. So that's why I stopped and took that break right now, because I think that's what we promised her. Okay. So that one I'm not marking because I've been trying to monitor that schedule along. Obviously didn't do a good job this morning. So I'm going to rip up the note that led to the break right now. Exhibit 551 is under seal. Any issues with that?
No.
Okay. Can we see what the answer is? Okay, you guys can go back if you want. Yes, and then I'm going to, there are 3 questions, and I haven't looked at them other than just to make sure they're questions. They'll start with the defense break. If you could write your notes on it, and then they'll be brought up to me and we'll mark them. Let's just kind of clean up a couple things. And you guys can go back if you want, or whatever you're comfortable with. So as I said, I didn't really look at the 3. I pulled out the answer to my 1 question. Okay, so there's 2 of them with questions. Okay, so during the break, counsel, you can look at those 2 sheets with questions. Okay, counsel has. I'm marking as exhibit 552. Okay, you guys have read that, and it's you have the jury number, so I don't know if you want me to take that up with that juror individually.
Might be worthwhile knowing what was heard.
Okay.
We don't know the extent, maybe it's just 2 words, but maybe there's someone giving.
Okay. We got a couple things going on. So what was the answer is the first question. Sure. Okay, so you guys can sit down. So I've marked as exhibit 552 a note from a juror. Just read that into the record too, and and we'll make a copy for everybody.
Right.
So
I agree with
we should have it down here. Okay.
Judge, I agree with Mr. Frankowiak. I think it's probably prudent to bring her in individually and inquire as you normally would.
Okay, so I just, a couple of things. First off, can we have Debbie get one of the bailiffs down here? And then, once we get that bailiff, we'll bring in juror 537. There's two questions that you will circulate between counsel. Okay, so I don't want to lose track. So what I'd like is for a bailiff to bring in juror number 537. And you can also give the phones back to the jurors during this break. So they need to make some calls, so that can do that. And I'll take that other question or comment. And then I always want one bailiff here and one down by the jurors.
537.
Yes.
Okay.
And the note that I just received had to do with the sealed exhibit, and that juror said lunch is fine. Okay. I marked as exhibit 552 a question, or not a question, a note from a juror. It says, last night in a restaurant, I overheard nearby conversation about this trial in snippets. Then my dinner guest asked me if this was the trial I was a juror for. I stated, I can't say anything. I can't answer. No additional questions were asked. And so we'll bring that juror in. I imagine everybody wants me to take the lead on that, so you're not the bad person. Now that I've looked at this, we don't have a juror 537, but I think it should be 587, who's been asking questions the whole time, so I'm not sure if there's some intent. She's labeled at 587 and all the other times.
We've got a question from 537.
Okay. You can just come on in and have a seat. All right. Good morning, and thank you for writing the note to us. You are juror 580. Okay, the note on here says 537. And I mentioned to the attorneys in all of your questions throughout the last 8 days, you've put 587. So I just wanted to make sure that this note was from you. Yes?
Yeah.
Okay, and thank you for doing that. You didn't do anything wrong. And I shared this with the attorneys, which is what I have to do. And what I want to do is just ask a couple questions so that I understand what happened. The attorneys may have some questions, and then you'll just be excused back to the jury room, okay? This situation that you highlighted on the letter, to me, you didn't discuss with any of the other jurors, is that correct? Okay, and thanks for doing that, because there shouldn't be any discussion with the jurors about anything to do with this case. You were gonna raise your hand, yeah. Okay, perfect. And what did she tell you? Excellent, and that's why you wrote your note? So we appreciate it. Where were you out to eat last night? Okay. Okay, and you wrote in here that you were out with some guests. I don't need to know who you were with, but you said at a nearby table, you overheard some about this trial. And were you able to hear what they were saying, or did you just hear that it had something to do with this trial? Okay, and to the best of your knowledge, just tell us what you heard.
Well, a couple of things they said they were taking conversation about. I didn't and one of them corrected. And I haven't seen both either. But our friend, our guest, picked up on the conversation that they had seen those words in the past be about this trial. kind of dismissed it and they asked right back. So I'm gonna have to go with that. But keep talking about it. But that's my word that
Okay. It's amazing how friends want to just know everything,
I
right?
know.
Yeah. I hear you. So this conversation that you overheard with posters and billboards, was there anything negative or positive about the posters or the billboards or about this case, one way or the other?
And then I think everything.
Okay. By the other people, you mean the people who were talking about the posters and billboards? Okay. Got it. And you didn't hear anything of substance about the case? Okay. You didn't hear anything that you would use and would be able to block, you wouldn't be able to block out? Okay. Does that experience that you had impact your ability to be fair and impartial? At the beginning of this case, during voir dire, I know you joined the jury later in the process, right? You filled in somewhere, I think, in the afternoon. But I had asked you specifically, would you be able to render your verdicts based upon the evidence presented during the trial? Now you've heard a lot of it, as well as the law that I give to you, and not on anything else. And I think you answered yes, correct? And is that still your answer? You're still going to be able to do it on all of the evidence that comes in, including the law that I give to you? Yes. Would that experience last night impact you in any way? Okay. I don't know who wants, any attorneys have questions? Start with you, Attorney Guzzi. Attorney Frankowiak.
Nothing on behalf of the hospital or Nurse
No
McGinnis.
questions, thank you.
Okay, thanks again for letting us know. Don't discuss with any of the jurors what we just talked about or your experiences last night, okay? All right, thanks. So exhibit 552 is received. Any issues or questions about that, Attorney Guzzi,
No, Your Honor.
Attorney Frankowiak,
No, Your
and Attorney Administrator?
Honor. No, Your Honor.
During the doctor's examination this morning, I just want to make sure we're on the same page. 37 was introduced by Attorney Administrator. We had a sidebar. I explained to the jury what my ruling was. So anybody want to add to that sidebar? Attorney Administrator?
No, sir.
Attorney Guzzi?
No, sir.
Attorney Frankowiak?
Nothing, Your Honor.
I always get a little uncomfortable when we're throwing stuff up on the screen and we're going to mark exhibits. So things were admitted, but you didn't ask to admit 233, which was the static view of the CT image, or 235, 238, 230, 247, and then the overlay onto 248, I believe, and the exhibit 249 or its overlay. So are those being offered now?
Move for admission.
Any objection to that? Okay, so those will all be received. There was also a reference to a check X-ray at admission.
Yeah, I think that was 233.
233 was a static view of a CT image. Yes, so I'm talking. The clerk said what?
232 was
232 wasn't offered, so that I'm referencing.
Best X-ray.
Okay, so are you asking for both of those to be received?
Move for admission.
Any objection? Okay, so 231 and 232 are received. The individual who needed the break, I think, 20 to 25 minutes, or usually 20, but we'll give her, if we were able to do like a 10-minute break, is that enough for everybody? The jury's been in there for 17 minutes, so I imagine they want to get back. Start at 57 after on this clock. We're adjourned. First of all, I appreciate the notes and it's a reminder to me that all of you have your own lives going on and things to do. And so I know one of you is going to do some shower kind of on your personal life and if there's anything else we can do, just let us know. It just like just happened. The second thing is and I don't know if I reminded you of this last night. Sometimes I feel like I every time, but this case is public, so things are happening in the outside world. And if you have contact with anyone, including, family members, friends, or you're at the bowling alley or at the local bar, right? I told you that on Friday night. The obligation or the responsibility is to report that right back to us. And so when you do that, thanks for doing that. We're at the point where we have questions from the jurors. I marked as exhibit 553 the questions from juror 386, and I've marked as exhibit 554 the questions from juror 580. Correct that number on exhibit 554. And the questions are the following, Doctor. For the portable X-ray, if the patient is not able to take a deep breath, how will the X-ray look be affected? It's an interesting tone, Mr. Administrator.
That's my warning that I better be back for.
Okay, it was like 4 minutes too late. All right, so I'll try it again. For the portable X-ray, if the patient is not able to take a deep breath, how will the X-ray look be affected?
That's a very good question, and that's a common thing that we deal with every day in radiology. And there's varying degrees of severity. It can be so bad that to where the radiologist would actually comment on it to say non-diagnostic or limited view of the lower lungs. And so what you do is you sort of use if you have the opportunity to use the before and compare and say, okay, how low, we call it low lung volumes, how low is it relative to the others? And then use that to make some assumptions in your interpretations. For example, the lower part of the lungs, when you don't take a deep breath in, your diaphragm moves up. So the lower part of the lungs sometimes can be a bit more dense, and it almost looks like plates, almost very flat-like. So it becomes quite obvious. The other thing when they don't take a deep breath is the pulmonary vessels, which course through both lungs, they become more prominent, and you take that into consideration just to make sure you don't say the patient's in heart failure or something of that nature, if that makes sense.
Right. And next set of questions are the following. After the October 13, 2021 X-ray of Grace's lungs, some darker areas are still not showing hazy or infiltrated. Would this area be enough to sustain life, enough lung capacity to survive?
That would be a very tough question to answer. The answer is what we see involved with the infiltrates really restricts the ability to bring oxygen in. So it's going to limit, so I said around 80% of the lung that we could see was definitively involved. So now you're left with 20%. So that tells you a statement right there that it would have.
Okay, so I'm going to skip down to another one of the questions on the same sheet, but it says because you just answered it, I think. You stated about, begin quote, 80% of Grace's lungs were infiltrated, end of quote, in reviewing her X-ray of October 13, 2021. Yes or no?
Yes.
So with only her having 20%, could Grace have survived?
We can't tell that.
What percent of lung capacity is needed for live and breathe? Tell us the smallest amount in percentages.
That's going to be a pulmonologist question. That's out of my wheelhouse. I can just say that if you depend on your lungs to live, and you are left with a certain part not functioning, it's going to make it a lot harder to fight anything you're fighting.
Have you seen lung x-rays of COVID patients with total infiltration, total haze, who survived?
Not total. I've seen some pretty severe exams that have survived, and I've seen some pretty mild to moderate exams that didn't survive. It's all the person's ability to fight it.
Okay. Do we have any other questions from the jurors? There are none. Attorney Guzzi, follow-up questions based on those questions and answers?
No, Your Honor.
Prowiak? Attorney Administrator?
No, sir.
Excellent. Doctor, your testimony is complete. Thanks for being here this morning. You may step down. You're free to leave.
Thank you.
Exhibits 553 and 554 are received. Okay. And who is the next witness?
Matter of the defense will be calling Dr. Gates.
Right, if you want to just come on up to the witness stand, and when you get up here, if you could remain standing and raise your right hand.
You do solemnly swear or affirm that the testimony you shall give shall be the truth, the whole truth, and nothing but the truth to help you God? Please have a seat. Can you please state and spell your name for the record?
David Fisk, David Fisk.
Witness Attorney Frankowiak.
Thank you, Judge. Can you hear me okay on this?
Yes, just fine. Thank you.
Okay, thank you. If at any time you can't hear me, let me know. We'll try to adjust it. Sometimes these microphones are a little glitchy. And if you could speak into your microphone, then we should be able to hear you okay, okay?
Can you hear me?
Sir, you are a medical doctor,
Yes, I am.
and do you have a particular medical specialty?
Yes, my specialty is infectious diseases.
And what do infectious disease doctors do?
So as infectious disease doctors, we take care of cases of a range of challenging infections, such as drug-resistant infections or superbugs that we might read about in the news a lot. We take care of cases of bloodstream infections, artificial joint infections, infections in limbs related to diabetes. We take care of with HIV, liver diseases such as hepatitis infections caused by infectious viruses. We take care of infections that are related to travel when people travel abroad and come back with an unusual infection like malaria from another country. We take care of that. We also see patients who have, a lot of patients who have weakened immune systems and may have that from chemotherapy or a transplant, organ transplant or a bone marrow transplant, and therefore are at higher risk of infections. So we get involved in a lot of those cases. We take during the COVID pandemic, and still, of course, COVID has been a major part of our world as infectious disease physicians. And the list.
Doctor, it sounds to me like you take care of and you see patients with all number of infectious problems or etiologies.
And in particular, those that other physicians may not feel comfortable managing. So we often, get involved when an infection that a patient is known to have is felt to be particularly challenging to manage, or at times we get involved in cases where there's sort of an unknown and there's a question of whether there's an infection in it, and the physicians aren't quite sure what's going on with the case, and then we would get invited into the case to help provide evaluation and guidance if infection is present, and if so, how to manage it.
Okay. And that brings up a point, doctor. When a patient, for example, is in the hospital, they might be followed by a hospitalist who is managing the overall care.
Yes.
Okay. And then if they have a specific question that might require some specialized expertise in it, they can call in a specialist.
Correct.
And your role, as I understand your testimony, would be as a specialist in the area of infectious diseases. So if a managing doctor has some questions about a problem that may be caused by an infectious disease, they could call in you as a specialist to give some guidance on that.
Our cases come not only from hospitalists, they are referred to us by critical care physicians, surgeons, resident physicians, emergency room physicians, OBGYN, all other specialties can refer to us if they're concerned with and a potential infectious issue.
Your Honor, may I approach the witness?
Doctor, I'm handing you a copy of the document previously marked as exhibit number 304. Are you familiar with it?
Yeah, that's my CV.
CV set forth your educational background, your work history, and your professional accomplishments and qualifications?
Yes, it does.
Okay. I'd like to just start out, if you could, by having you just run down your education and your medical training for the jury so they can understand who you are and what kind of education you've had.
Sure. I did my undergraduate work at the University of Virginia, and then did my pre-med work, post-baccalaureate pre-medical program at Goucher College in Baltimore, Maryland. I then attended medical school at Johns Hopkins University, and that was from 1993 to 1997. And that was followed by 5 years of postgraduate training at the University of Michigan, which included 3 years of an internal medicine residency and 2 years of an infectious diseases specialty fellowship.
Okay. And I want to just have you explain a little bit that postgraduate training. You said there was a period of 3 years, special fellowship of 2 years. If you could just explain that aspect of your education and what it involved.
Yes. Yeah. So our fellowship is when someone wants to subspecialize in a subspecialty of internal medicine. Other examples would be gastroenterology, cardiology, pulmonology, kidney disease. There's numerous specialties. Infectious diseases is one of those. And so in our training, we work with infectious disease specialists and focus on learning the various aspects of infectious disease illness and care of individuals who have infectious diseases, and also involve research on issues pertaining to infectious diseases.
So that 2 years of fellowship training, as I understand, would be in your specific specialty of infectious disease.
That's correct.
Okay. An individual might, for example, specialize in a different area like pulmonology or critical care, and that would be specialty, whereas you have the specialty of infectious disease.
Yes.
Okay. Are you board certified, Doctor?
I am.
Okay. And what board certifies you?
It's the, what is it called? American Board of Internal Medicine subspecialty of infectious diseases.
Okay. And what, if anything, does that involve to become board certified with that certification?
Well, first of all, you have to successfully complete fellowship training to be eligible. And then initially you have to pass a certification test that is put out by the board, which inquires about cases and issues related to infectious diseases. So you have to demonstrate competency in the field with that. And then there is a recertification process following your initial certification. And that recertification process is aimed at making sure you stay current in infectious disease practice and in infectious disease care and management. And throughout my career has changed some. Initially, it was every 10 years you had to take a recertification test. And I did that 10 years after my initial board certification. And then it has evolved further so that now it is more a continuous process of ongoing learning and demonstration of competency 3 months, you have to review case questions and issues and demonstrate competence by answering those questions to the board's satisfaction.
Are you currently employed, doctor?
Yes.
And who's your current employer?
Yeah. I essentially work for myself. I'm employed by my own medical corporation.
Okay. What kind of things do you do? What are your job responsibilities?
Yeah. So I spend about 2/3 of my day in a typical day seeing patients inside a hospital setting. And the hospital I work at is called Cottage Health, which is a 3-hospital system in coastal California. And it's the main referral center for the coast of California, pretty much between the San Francisco Bay Area and greater Los Angeles area. And so I see patients there in all areas of the hospital. Other than pediatrics, we don't see many patients in pediatrics because we're fortunate enough that we also have pediatric infectious disease available to us. The adults on the internal medicine floors, we see patients on the surgery floors, patients in the emergency room, patients in the post-operative setting, and patients in surgical intensive care in our neurology unit and in our medical intensive care setting as well. So I'm rounding on patients and trying to help patients navigate their infectious disease illness. So that's a majority of my day. And then I spend some other time doing work for a tech company that I work for called PHC Group, or Public Health Company, and some expert reviews like cases like this.
Do you have any current hospital appointments?
Yeah, I'm appointed as to 3 different hospitals, Cottage Health in Santa Barbara, which is the main campus, and 2 smaller hospitals in California and San Ynez, California. And then in terms of, are you asking about roles that I play in addition to the clinical care there, or?
In addition, do you have any roles that you play at those 3 hospitals that you are involved in for Cottage Health?
Yeah, I also chair the antibiotic subcommittee, which of the Pharmacy and Therapeutics Committee, which is the group of physicians and pharmacists involved in what medications the hospital wants to stock and have available for management of infectious diseases.
Do you have any teaching responsibilities?
Yes.
Okay,
Yes,
and what are those? Can you just give us some examples?
Yeah, our hospital is a USC affiliated teaching center. And so I work on a regular basis every day with from the internal medicine training program that we have, and also the surgical training program that is at our institution. So I work with them. Sometimes they will round with me, and I provide lectures to them on occasion as well. So they're a regular part of my daily work, which I enjoy very much.
Based upon your testimony, I understand you must have personal hands-on experience treating patients with various infectious diseases?
Yes, extensive.
And has that been the case throughout your career?
Yes.
Okay. Do you also have personal hands-on experience specifically providing care as an infectious disease specialist for patients suffering from COVID-19? Okay. Can you explain in a little more detail the amount of experience or the kind of experience you've had caring specifically for COVID patients in the role of an infectious disease specialist?
Yes. Well, of course, when COVID first came around, it was new to all of us. And so right out of the gate, when there's a novel or a new infection of concern out there, our colleagues and community up to the infectious disease experts, because we had, that's part of our role. And that's something that we, during our training, actually, were trained to expect. We were trained to expect that epidemics and pandemics happen. They're a part of history, and that likely some point during our career, we would experience something like the COVID pandemic. And we also, were initially involved because COVID is related to previous outbreaks of other coronaviruses, such as known as SARS and MERS, which we've heard about in the news. And so we had some basis and understanding of those other viruses that we could bring to the table to help individuals with COVID. And so right from the get-go, initially, when COVID patients started being diagnosed and admitted to the hospital, we early on every case that came in to sort of help with the management of this and optimize the care and treatment of individuals with COVID. And then as the pandemic evolved and the case burden exploded and mushroomed, we and our colleagues also became more familiar with treating cases. We then got involved on a more selected basis with the more complex cases of COVID, the individuals that may have been sicker or had more complex infection. And as treatments and evidence for COVID treatments arose, we were charged with helping to understand the pluses and minuses of the various treatments, and when appropriate to recommend or deploy their use for our patients. So my care of patients ranged from the first COVID patients that came into our hospital and some who were seen who may have had milder illness early on, but also patients intensive care setting treating. We at one point had 3.5 ICUs full of COVID patients in our hospital. So it was all hands on deck, to help care for that extraordinary volume of sick people.
Fair to state that you've had experience patients from the very beginning of the COVID pandemic all the way up until the current day?
Yes.
Okay. And you actually answered my next question, which was to detail for us the extent of the experience that you've specifically had in that caring for COVID patients or consulting on COVID patients in the ICU setting. And you mentioned you have multiple ICUs full of COVID patients that you have consulted upon. Okay. Have you, in the course of your career, provided care or consulted upon patients like Grace Schara in this case, who might have a cognitive disability or might have, say, Down syndrome?
Yes, absolutely.
Okay.
Our institution in our community where our main hospital is, there's a residential care facility for individuals with developmental disabilities and developmental delays. And so we partner and they experienced significant outbreaks in that facility. Many of the patients from there came to us for care, and unfortunately, some of them succumbed to their COVID. So it's a frequent occurrence during the depths of the COVID pandemic.
Okay. Do you have any personal experience in the area of hospital infection prevention or control?
Yes, I do. I was the medical director of our hospital infection prevention and control program from 2009 until 2023, and have some training in background relating to hospital epidemiology as well.
Okay. Doctor, have you given any invited lectures or other entities specifically on the subject of COVID-19?
Yes, I think over 30 of those.
Okay. I'd like to talk about COVID-19 just to set the stage, to give us a little tutorial about what we're talking about with this particular infectious disease. Can you just briefly explain what, in general terms, COVID-19 is?
So, COVID-19 is really the name for the disease that's caused by a virus known as SARS-CoV-2. And so we all call it COVID, but really the germ that drives it is SARS-CoV-2. And so COVID as a disease is caused by this virus, which is a member, as I referenced earlier, of a larger known family of viruses called coronaviruses that have caused human disease as long as we know. And there are numerous coronaviruses out there, some of which just cause common colds, and others of which can cause more severe illness, like COVID or SARS, and fatal illness like we see with COVID or SARS. SARS meaning the original SARS outbreak. And on top of that, individuals who have weakened immune may experience some of the other coronaviruses, and that can progress to severe disease because they may have weakened immune systems that allow it to cause more damage than it would in most individuals. And so when this new virus came around and initially detected in late 2020, we quickly realized that it had the potential for devastating impact because of some of the early reports of outbreaks not only in China but in Hong Kong. And really what drove home for me the extraordinary of COVID is when we saw the cruise ships, the Diamond Princess cruise ship and others, where so many individuals and such a high attack rate on these ships were coming down with COVID, even though people continue to get sick even after they were sort of quarantined to their rooms on these ships. And when we saw that, we could realize that not only did this have potential for extraordinarily wide transmission of the virus, but also potential for such serious disease that we all now it has created.
Dr. COVID-19 has been.
Let's go to the bathroom. You can go now. All the rest are just going to stay here.
By the way, is there any water I could have?
Yeah, we'll get you a water. Just hold off until we get all the jurors back.
May I approach with
Sure.
water?
Thank you.
We have all jurors back. Attorney Frankowiak, you can continue your direct exam.
Doctor, I've heard COVID described as a pandemic. Would you agree that COVID-19 constituted a pandemic? Okay. Doctor, what is a pandemic, briefly?
So a pandemic is an infectious disease related illness that has widespread countries and causes significant not only illness but societal disruption.
How is COVID-19 typically transmitted? If you could give a brief explanation of that.
Yeah. So COVID-19 is transmitted in multiple ways. As a viral particle, it can be expelled from our respiratory tract where it takes hold in its initial infection, and it can land on surfaces and be acquired when we touch a surface and then rub our eyes or touch our nose or our mouth. It can also be transmitted as a fine aerosol that stays suspended in the air for prolonged periods of times and then directly inhaled into our respiratory tract. So it is with what we call respiratory transmission that has also features of airborne transmission.
In 2021, were there prevalent, for example, strains of COVID-19?
Yes, as we all recall, I think with our, if we think back with all the pain and suffering that this virus caused for all of us, we do remember different waves of this that spread around, and throughout 2020, it really became the dominant wave was the wave known as the Delta variant, and that was widespread in the United States at the time of Ms. Schara's illness.
Doctor, in 2021, how did COVID typically affect those who were infected, in your experience?
Yeah, well, there was a broad range of how it affected people, but the most common symptoms were individuals getting fever, respiratory symptoms like cough, shortness of breath, tightness, but there also can be symptoms such as low appetite, headaches, sore throat, gastrointestinal symptoms. You know, with different variants, there was some variants had more diarrhea associated with them than others did, but also we think of COVID as a blood vessel disease as well, because it gets into our blood vessels and causes high degrees of inflammation in our blood vessels. And so we saw higher rates of diseases associated with blood vessel problems and blood vessel clotting, such as heart attacks and strokes were known complications of COVID. And we saw increases in cases of those from the virus. But really, you know, the list of illnesses and complications from COVID is much more widespread is much more broad, I would say, than we usually think of, because it can really impact a range of organs. It can impact our kidneys, it can impact our brain, people getting long COVID, and the list goes on.
Doctor, were individuals dying in 2021 as a result of being infected with the COVID-19 virus in your experience?
Huge numbers of people at various times during 2021, yes. And the most common sort of pathway that we saw that led to that was where it moved down into the lungs, caused pneumonia, and ultimately respiratory failure that led to people's demise.
And did you personally witness this process that you've just described in patients that you treated?
Over and over and over.
Were there any factors that placed individuals at a higher risk for experiencing severe COVID infection or death from COVID-19?
Yes, there's certainly numerous risk factors that have been as predisposing someone to more severe COVID. And the ones that are sort of known to be the most potent increasers of risk would include advanced age, or residence in a care facility, such as a nursing home, would be a particularly high risk situation, an individual for COVID. But there are also numerous other risks. Many other chronic diseases, such as heart disease, pre-existing lung disease, or kidney disease, can also increase the risk of severe outcomes from COVID. Individuals who are obese did worse with COVID. And that's something we see in a range of respiratory viruses like influenza as well, because when people have extra weight, their body has higher levels of inflammation that are going on in their body. And those high levels of inflammation are part of what causes the symptoms and the overwhelming illness that these viruses like COVID can create, and risk factors, quite a other range of those as well.
Were there treatments or interventions as of October of 2021 that tended to statistically decrease the risk that an individual might contract a severe or fatal case of COVID?
As of October 2021, you're saying?
Yes. Mm-hmm.
Yes. There were, and really, as of October 2021, the treatments that offered the most benefit and most well-validated benefits in reducing risk of death from COVID included treatments with dexamethasone, which is a steroid medication, which is used to blunt inflammation created by the virus. And we were just talking about how that inflammation causes so much damage within the blood vessels, but also the lung tissue itself. And so steroids like dexamethasone were a standard part of treatment in reducing mortality from COVID and complications from COVID once the COVID got severe. And individuals who were given steroids, the sort of trigger point for that was that they were requiring extra oxygen and oxygen supplementation. And that's when they were felt to benefit from medicines like dexamethasone. Also, there by that point had been antiviral drugs. So we think about antibiotics for bacterial infections. Analogy, when we have viruses, we can have antiviral. And remdesivir, the antiviral drug, had been shown to decrease mortality 2 weeks after completion of a course of it and 4 weeks after a course of it for hospitalized individuals with COVID. So it was used widely and still is used as a standard of care in the hospital setting. There were other drugs that were also aimed at blunting the excess inflammation that we've talked about that had been validated and shown to have some mortality benefits by late 2021, and that included IL-6 inhibitors, of which tocilizumab is an example, and also throughout the pandemic and in October of 2021. There was use of convalescent plasma medication, which is, in a sense, a way of borrowing somebody else's immune system to help you fight off COVID. And what you're doing is you are borrowing the antibodies that someone else has, which can help fight off COVID because they are in COVID before and had experience in creating antibodies. And so that plasma from other people is pooled and it contains the antibodies that then can be infused into someone suffering from COVID. And the benefit of convalescent plasma it was sort of varied throughout stages of the pandemic. It was felt to be helpful, and then there was a period of time where evidence suggested it wasn't helpful. But then later on, we learned that it was particularly helpful when there were high numbers of the antibodies contained within each dose of the convalescent plasma. So its use has varied over the course of the pandemic, but in October 2021 was also something potentially beneficial for an individual with COVID. Okay. And then there's other medicines in the body family as well that are out there.
Okay. Thank you, Doctor. We're almost done with your COVID tutorial, rest assured. You've mentioned the Delta variant, and there's been some testimony in this case of the Delta variant. Could you just briefly explain what the Delta variant is and whether it had any distinguishing characteristics during its prevalence?
Yeah. As we saw with successive waves of COVID and successive variants arising, each new that came around seemed to have adaptations that allowed it to be more transmissible than older variants and more infectious. And in many cases, not all, but in many cases, cause more severe disease. Yes, previous waves of COVID had caused. And Delta in particular was much more transmissible than the Alpha or Gamma waves that had preceded it. And also had more disease associated with it, higher rates of hospitalizations. Canadian studies showing, hospitalizations 2.5 times that of hospitalization rates, 2.5 times that of previous waves and previous variants, and also higher levels of admission to intensive care and higher risk of death, 1.5, 2.5 fold, increased risk of death compared to prior waves. So I think, if I think back to the level of concern that we saw in successive rounds of the pandemic, our level of concern for the danger that we saw in the Delta wave was as high as it ever got. I don't think we ever had a higher level of concern than when we saw Delta coming around as it had originally been, identified in India in late 2020, and we saw what it did over there in the news, and we knew it was coming.
Okay. Doctor, I want to talk a little bit about this case, if we could. Prior to developing your opinions in this case, did you review the medical records for Grace Schara's hospitalization at St. Elizabeth Hospital between 6th and October 13th?
Of 2021, yes, I did.
Okay. Did you understand, or do you understand that you've been brought here today to offer some testimony as an expert in the field of infectious disease in a lawsuit filed by the father of Ms. Grace Schara, the patient in that case?
I do.
Okay. Doctor, have you reviewed the reports and opinions offered by plaintiff's sole physician expert in this case, pulmonologist Dr. Burdine?
Yes, I have.
Okay. Would you be able to detail briefly for the jury what expertise that you believe you were able to offer in this case as an infectious disease expert as contrasted with, for example, a pulmonologist?
Yes. And I think one way to phrase that is the roles of a pulmonologist and an infectious disease physician, in a sense, complemented each other in the care of individuals with severe COVID. Our expertise as infectious disease physicians is in the realm of understanding the virus itself, what the virus, its structure is, what its characteristics are, transmissibility, where it infects in the body, and the types of symptoms that it can cause. And also what we bring to the table is an understanding of the sort of state of the art and standard of care and leading edge of treatments available for that virus. And so our expertise is in terms of, helping dispense those medications, prescribe regimens that are appropriate for individuals fighting this virus. And on top of that, our expertise involves issues related to prevention of infection transmission in hospitals. And that's not an area that the pulmonologists focus on, so-called epidemiology or healthcare epidemiology. And how else do we differ? The pulmonologists where their expertise involves more in the support of individuals who have respiratory failure, people who can't get enough oxygen into their bloodstream. The pulmonologists have the expertise to know what tools are available for a given patient to help that patient optimize the ability to get oxygen into their body or to blow off carbon dioxide, so-called ventilation from their lungs. And we also have, as infectious disease physicians, an expertise in parts of the body damaged by COVID beyond the lungs. And pulmonologists don't have that expertise.
Okay. Thank you, doctor. According to your experience with COVID as an infectious disease expert, Did Grace Schara in October of 2021 have any specific risk factors that you believe placed her at an issue of experiencing severe COVID or death from COVID?
Yes, the risk factor that she displayed was her overweight status, described in some of the records as being morbidly obese, and individuals with a high degree of overweight status did much well with COVID, as we had mentioned. She also had not been vaccinated for COVID, and at that time, the COVID vaccines offered roughly a 90% reduction in the chance of dying from COVID. So as she had not been vaccinated, that led her risk to be higher than someone who would have been vaccinated at that time.
And were those validated by studies at the time of the vaccines that were available as of October of 2021?
Yes, that was documented in a range of studies for the different vaccines that were available, and high quality studies that have been we call randomized clinical trials, which are the type of study that in the world of interpreting medical literature provide the greatest degree of evidence for a desired outcome.
In accord with your study of COVID-19 disease and your own personal experience treating patients suffering from COVID disease, did individuals in ages or Grace's age group contract cases of COVID that proved to be fatal?
Yes, absolutely.
Now, Dr. Burdine has offered some statistics that a very low number of people in Grace's group and ended up passing away as the result of that. Are you aware of studies or articles that may address that?
It's a way I think of it is a very low percentage of individuals in Grace's age group succumbed to their COVID, but because so many people were sick with COVID at that time, there still were significant numbers of deaths from COVID in individuals and even in pediatric situations, in the United States and globally.
Simply being in an age group, a younger age group, for example, not a geriatric age group, did not offer proof or protection against severe COVID disease or even death from COVID disease.
But it offered some degree of protection in that someone who's 20 in general wasn't as great a risk as somebody who was 80, but the protection was far from absolute. And so certainly we had steady number of individuals, unfortunately, that we saw who were much earlier in life who ended up in the ICU or dying from COVID disease.
Doctor, have you developed a number of opinions in this case from your perspective as an infectious disease expert after having reviewed the materials? Okay. Your Honor, may I approach?
You a copy of the document previously marked as exhibit. You recognize that document?
Did you say, did I recognize that document?
Yes.
Yes, I do.
And what is that document?
This is the report that I drafted and filed after reviewing the some evidence provided to me on the case of Ms. Schara.
And does this document
Set forth a summary of the opinions, all of in this case?
Yes.
Okay. Please keep that document handy. We'll go through your opinions. I'd like to address them. You can certainly feel free to refer to that document to refresh your recollection.
And can I just add one thing that I would say, this and my deposition, the bodies of two have established my opinions.
And that's a good point, Doctor. You've been deposed in this case, true?
Yes.
And you answered some questions that were posed to you, and that's okay. And you described your position as well as those set forth in your report.
Yes.
Okay. You hold an opinion as to whether Grace Schara's medical case history is or is not consistent with severe infection leading to death?
Yes, I have an opinion on that. And my opinion is that Ms. Schara's case was very much consistent with severe and fatal COVID disease.
To go over some of the factors that you've identified in your report. And the first is what you term the sequence of illness. Based upon your review of Grace's hospital records, was the time sequence of Grace consistent in your experience with the development of severe COVID-19 disease?
Yes, it fit very well, the time sequence of events. You know, typically what would happen with COVID is first came down with fairly mild symptoms, just like a cold or a routine flu. After several days, as inflammation ramped up in their body, they began to get sicker and might develop more symptoms such as more difficulty, higher fevers, more pain, more lethargy or confusion. And so it's not the type of thing where someone would go from dead and having a symptom to dying a day or two later. The process of decline to the point of what we call severe COVID disease was generally at least 5 days symptoms and sometimes as long as 10 to 14 days till severe disease. And when I call something severe COVID in my mind, that is meaning that somebody had a need for extra oxygen support and extra oxygen requirements to support their breathing and oxygenation. And so the progression from onset of severe disease was in that time range. And then when people develop severe disease, there would the time to death would and generally would follow up, lag behind that. And so in the 2-week time range from onset of symptoms to death is a very typical time course for the progression of severe COVID disease.
Based upon your review of the records, doctor, in this case, do you have an understanding that Grace had a positive home COVID test September 28th?
Yes, my understanding is she had a positive home COVID test that was to the physicians and the care providers upon her arrival to the hospital.
Okay. Your Honor, may I approach the witness? Okay.
Doctor, I'm handing you a document that's been previously marked as Exhibit 434.
And do you recognize that document?
Yes, this is the report of the CT angiogram, where the, in a sense, the CAT scan of her chest that was performed on October 6th, on the day she presented to the emergency department.
And you understand that she went to the emergency department on the 6th and had this CT scan, and did that show anything experience as an infectious disease expert that would give you an idea as to the level of her disease or the existence of her disease at that time?
And I've also reviewed the images of the scan personally. That scan in both lungs, which whenever we see pneumonia on both sides of the chest, we know that's even a more serious illness than when somebody just has it on one side of the chest. And it showed extensive amount of pneumonia at that point, even much more so than was revealed on the initial chest x-ray. And that's not surprising because CT scans are more sensitive at picking up damage to the lungs than x-rays are. Importantly, this scan was also done for another reason, which was to evaluate for blood clot in the lungs, because I know that was the initial concern when Ms. Schara went to urgent care, was the possibility of a blood clot. And this test with the what they call the angiogram part of this test ruled out a large blood clot in Ms. Schara's chest.
Your Honor, may I approach the witness?
You could take a look at that.
You recognize that document?
Yes, I've been handed the department report from October 6th from Ms. Schara's evaluation there.
Publish a page of that document? 28, correct.
Was this among the documents sent over last night?
You can walk up to the witness stand and just take a look at it if that's easier, Mr. Boylan.
Okay, Judge, I'll actually get it pulled up on the computer, so I don't have it on paper, but I'll pull it up on my screen.
Publish it then.
I've got it now. Thank you.
It can be published.
I'm sorry?
Asked if it can be published. It can
Yes,
be.
yes.
And the answer is yes.
Page 23.
No, it's okay. No problem.
Doctor, in this initial, I guess, report that you looked at, there's some vital signs there. Did you identify any vital signs that would lead you to believe that there was some significant compromise?
Yes, absolutely. The one that to me stands out the most here is the fact that oxygen saturations in her blood, or the amount of oxygen that is being carried around her bloodstream, was at the lower limits of normal, even though she was getting supplemental oxygen. And so we see here at 16-12 hours, her oxygen saturation was 90% when she was oxygen through the nose at what a rate of, we call 3 liters of nasal cannula. And so when you see values in that range, that sparks concern. Individuals should have higher oxygen saturations generally than that when they're not using extra oxygen. So we saw that, and then throughout the course of her ER stay, the need for increasing levels of oxygen support for Ms. Schara. And additionally, she had other unstable vital signs at times during her admission, including elevated heart rates at times, and low blood pressures at times during her emergency department stay. 1707 hours, her blood pressure was 82/40, which is getting into the dangerously low range.
Doctor, according to the date of the COVID test and then the admission to the hospital on the morning of October 7th, admission on that morning was about 10 days after symptom onset. Was there any significance of that to you?
Just that it falls within the sort of typical range where we see when someone is starting to deteriorate from their COVID, that would be within the typical time span that we would see that deterioration start to happen.
Okay. Doctor, you also taught COVID testing. In your opinion, was Grace's COVID testing consistent with the development of severe COVID disease?
Absolutely. The home tests that were available for COVID at that time, that I imagine most of us, if not all of us, had used at one point, were the COVID antigen tests, where we would swab our nose and then stick the swab on a thing and look for the little color bars to diffuse and develop in front of our eyes. And those antigen tests at that time when they were positive, were highly predictive of active COVID disease in the body, and that the virus was actually reproducing in the body. Those tests have, at that time, were not, if they were negative, sometimes they missed an active COVID infection, but when they were positive, they were very highly predictive of disease. That has changed some in later ways in the current day of the pandemic. Those tests, because of changes in the virus, are less predictive than they were then, but at that point, their predictive value was acceptable.
Thank you, Doctor. Based upon your review of the medical records, were Grace Schara's symptoms consistent with severe COVID disease?
What, throughout her time course, or do you have a specific time frame during her thing that you're asking about, or?
Sure. Well, for example, fever. Did she exhibit fever?
Yes. I mean, I'm just asking, do you mean her symptoms on a specific day or in general throughout the course of her illness?
In general, doctor, because
Okay.
you've had a chance to look at her
Sure.
entire course, what are the symptoms or were symptoms consistent with the development of severe COVID
Yeah.
disease?
Yeah, in general, her symptoms were exactly the common things that we would see with severe COVID. She had fevers intermittently throughout her hospitalization with values as high as 104, 7 degrees, quite elevated temperatures. She had fast breathing rates, which are characteristic of individuals who are struggling to get enough air and enough oxygen in, which of people with COVID. She had lost her appetite before she came to the hospital, as described in the notes, and that was seen, and many of us I know experienced that ourselves when we had COVID. She was documented in the emergency department notes at one point as having had a cough and a sore throat, which are also can be symptoms of COVID. And later on, at times during the hospitalization, displayed confusion, which is a symptom that we saw very frequently and still see very frequently in people with severe COVID as they're battling their infection. And in particular, as their ability to get oxygen into their bloodstream declines as the lung function is impacted by the virus. So she had confusion. But what I think is really the sort of penultimate symptom that we saw in Ms. Schara's case was the fact that despite all the efforts she was making to breathe and get more oxygen in, her body's ability to obtain adequate oxygen levels dropped off over time, and there was need for increasing attempts at more intensive levels of supporting her with extra oxygen delivery. And ultimately, her body was not able to keep up with that. And so that symptom of progressive respiratory and oxygenation function was really a hallmark of severe COVID disease.
Your Honor, may I approach this witness? Okay.
Is exhibit 431, 432, and 433. If you could reference them.
Okay, awesome. Okay. Permission to publish 431, Your Honor?
Objection.
Okay. Page 68. A little bit about fevers, doctor. Do you have in front of you?
Yes, I do.
Okay, this is a note that is dated from, it looks like the October 8th, and this was a note that was in the record that you've seen before?
Yes, by the consulting infectious disease physician, Dr. Zeman.
Okay, and we have, there's an objective vital signs, and you said the patient is febrile. Well, what is febrile?
Sure.
Okay, and it said had 104.2 at 0200 on 10/8/21, and temperature currently is 102.4. When you mention fever, is this, for example, one data point that you're relying upon on the 8th to indicate or to understand that she was experiencing fever on that date?
Yeah, I mean, this is what defines fever, that her temperature readings were elevated on that date. So this, there's really no other way that we would define being these elevated readings.
And permission to publish 432. Okay, 54, page 54. Okay, doctor, once again, we have another section. Now, this is a document that's from a little bit later. This one is from, it looks like the 11th. So we're now several days. Another section up here where the vital signs are also showing, or is there anything on this particular document that would show you that a fever persisted several days later on the 11th?
So she was documented here on the 10th as having a temperature of 100.1 at noon on the 10th, so the day before this note was written on the 11th.
Okay. And finally, 432, permission to publish. Four- 433, page 40. Okay. Doctor, is there anything on here that indicates fever or that you're able to determine it fever? This looks like this is now the 13th of October.
Yes, this is Dr. Shokar's note from October 13th, documenting that at the time of the evaluation, the note was written, this temperature was 101.4 degrees. So day after day, we're seeing abnormal temperature readings here.
Thank you, doctor. Now you mentioned, you mentioned earlier that one of the treatments for a steroid called dexamethasone.
Yes.
Did you understand, based upon your review of the records, that Grace was receiving dexamethasone while she was in the hospital?
Started shortly after her arrival at the hospital.
If you could explain to the jury, does dexamethasone, is it known to, for example, suppress fever?
Absolutely, yeah. So steroid medications, when we take them, can blunt the body's ability to generate fevers. So when we have patients who have elevated temperature readings and are taking significant doses of steroids, like Ms. Schara was, that tells us that in reality, in the absence of steroids, those temperatures actually would have been much higher. So a reading of 101.4 steroids might have been 103, 104, or sometimes even higher. So when we see fevers in a patient on steroids, we know that there's a intense process of inflammation in the body that's active.
From your perspective as an infectious disease physician, is the continuation of a fever like that concerning in the face of a patient who's receiving dexamethasone? Why is that?
Just because it tells us that the underlying disease process is running rampant and that the body is not gaining the upper hand at fighting off the disease process that's driving the fever. And in Ms. Schara's case, of course, that was her COVID-19 disease and fevers associated with that.
Okay, doctor, you also mentioned in your report some of the physical exam findings for Grace. In your opinion, were Grace's physical exam findings consistent with COVID-19 disease?
Yes, overall, if we take the totality of her hospitalization, you know, the symptoms of fever, shortness of breath, and then at times confusion and agitation, and also the lack of appetite that was mentioned. These are all, you know, very typical of what we would see with our individuals who were suffering from this disease, and cough as well, of course.
Doctor, what about coarse respirations? Did you see evidence of coarse respirations?
Yes, I saw that and described in one of the physical exams by, I believe that was Dr. Shokar. I have to refer exactly, but her physical exam upon the hospitalization and an ER evaluation was shown to have coarse breath sounds. So when the doctor was putting a stethoscope over the lungs and listening, they were hearing abnormal patterns of airflow, which are typical of what we would see in someone with a pneumonia.
Okay. May I approach, Your Honor?
Yeah, I got it. Marcus exhibit number 430. Is that a note from the medical records
You have seen before?
Yes, this is Dr. Baum from the 8th.
Okay. Permission to publish a page of this document, Your Honor? Okay. Page 16 of 430. Okay. Doctor, do we see on there, it looks like under the physical examination section, there's under the chest, it looks like there's a denotation there of coarse respirations. Do you see that?
Yes, coarse respirations with decreased respirations at the bases.
And what does that tell you?
Yeah, that tells us that somebody's lungs are not functioning normally. Normally, when you listen to the chest and so on, you hear a gentle pattern of air just kind of whooshing in and out of the lungs, like we hear, normally when we're listening to someone breathe. But you can hear extra sounds in the lungs because there might be fluid in the airways that is causing a rattling sensation in the chest, or solid material sometimes in there that's causing a disturbance in the air flow in and out of the lung gets turbulent and it creates extra sounds. So it's an important clue to us that from a physical exam that somebody's lungs are compromised.
Doctor, did you also see evidence in the various exam findings throughout the hospitalization of increased agitation and confusion?
Yes.
Okay.
Various times. Yeah.
And in agitation, confusion, in your experience, is that something that you saw often during the progression of COVID-19 disease?
Yeah, very commonly in people with severe COVID and respiratory failure from COVID, we would see agitation or confusion. And there can be many reasons for that. Some of that could be something such as when people get fever, sometimes they can feel off or get confused, particularly when they're hospitalized. But on top of that, the COVID virus itself has been shown to infect certain brain cells site. And so when the virus is in the brain itself, that can contribute to the brain not functioning well and confusion. I think in Ms. Schara's case, one of the issues that was probably most tightly related to her confusion was the challenge her body was having at getting appropriate oxygen in and the need for extra oxygenation. So confusion is a very common feature in patients ill with COVID that we would see who were needing oxygen supplementation.
Okay. Doctor, now I know you are not an expert radiologist. For example, you're not specialized in radiology, true?
True.
Okay. Do you, however, or are you experienced in reviewing radiographs, chest x-rays, things of that nature, experience as an infectious disease doctor?
Yes, it's a very integral part of our work as infectious disease physicians. I look at CT scans, x-rays, and MRIs every day of my work.
Okay. For example, with infectious disease that might affect respirations or the lungs, are you experienced with looking at radiology studies?
Definitely, yeah, and have training in it throughout the course of my medical school and residency and fellowship as well.
And as a infectious disease physician, do you often look or rely upon reports of radiologists when they're looking at chest films?
Absolutely.
Okay. May I approach, Your Honor?
Before he does, could you tell me what date you're looking at presenting him documents for with radiology?
All of the reports throughout. I'm going to hand him 434 through 438.
I may ask for a sidebar at this time.
is overruled. Go ahead.
Doctor, I'm going to hand you some documents marked as Exhibit 434, 435, 436, 437, and 438. I'm going to hand them to you as a stack to keep coming up and handing you them individually.
Okay.
Please refer to those documents.
Permission to publish 434, Your Honor? Okay. Doctor, we're looking at number 434. And what is number document?
434 is the report of the sixth CT angiogram of the chest with IV contrast.
We've talked a little about this one before. There's an impression section there under number 2. What does that say?
Of infiltrates with areas of consolidation in both lungs, likely related to pneumonia.
And from your perspective as an infectious disease doctor, is this an important finding? Why is that?
I think the mic might have gone. There we go. Yeah, I think it's a hugely important finding because it indicates that the patient has one, but both lungs that are compromised by a disease, and in this case, like infectious disease, such as pneumonia.
And as we've noticed, this is from the very first day when she first came to the ER. So this is very early on in the course of the records you've reviewed in this case.
Time we see a bilateral or pneumonia on both sides, that rises up in my world to becoming a life-threatening infection.
Okay. Judge, permission to publish 435?
Yes, I gave you permission.
All of them? Okay, thank you. Okay, what is this, what's this report, doctor?
This is 435 is the chest x-ray from October 7th, I believe. Let's see. All right.
Okay. So that would be the next day after exhibit 434 that we just looked at.
Yes.
Oh, now there's an impression here. Can you read that impression?
Yes, it says increased dense hazy opacity in the left lung, decrease in right basilar opacity.
Okay. And as an infectious disease doctor, does that tell you anything?
Yes, that there's evidence of pneumonia on both sides of the chest, but at least from the x-ray, it is a little more pronounced on the left side and a little less pronounced on the right side than it was based on the October 6th study to which they compared this one.
Okay.
And again, I'd emphasize that not to the CT scan, but comparing that to an October 6th x-ray.
Exactly. Okay. Push 436. Doctor, what's the date of this exam?
This is October.
Okay, and what is this document that we're looking at here?
Portable chest x-ray.
Okay, and it looks like there's some findings under lungs there. Can you read what's written there?
Hazy and reticular opacity in left greater than right lung bases is overall similar to prior.
As of the three that we've looked at so far, is there anything getting in the condition here based upon your review of these documents?
Yeah, well, anytime we look at x-rays, it's important to not only look at does it show improvement, but also look at the technique used, because there are one x-ray taken one day has a different technique, variations in technique for. And that technique largely relates to the amount of radiation delivered at the time that film was taken. And so you changes in findings on x-rays based on technique variability. So first of all, you have assess the film and decide if the amount of radiation used to expose the film is similar to the study or not. And if it is, then you know you're comparing apples to apples, and you interpret findings such as shadows in the lungs or pneumonia in the lungs, and as to whether it's better or worse. To your specific question, as of this date, I would say it showed that there was still ongoing evidence of pneumonia on both sides, but that according to the report, it to have worsened a little bit on the left side and maybe improved a little bit on the right side since the October 6th baseline.
37? This looks like it has an exam date of October 11th now. What are we here?
We're looking at a portable chest X-ray from October 11th.
Okay, and there's what does the impression say?
Worsening pulmonary opacities are visualized bilaterally, concerning for pneumonia or edema. Left pic terminates near the atrial junction.
Now, the words worsening pulmonary opacities, does that mean anything to you in terms of I guess, your concerns as a infectious disease doctor?
Certainly. I mean, worsening pulmonary opacities can indicate worsening of pneumonia, but as they mention in this, that sometimes they're, as they said in this report, well, maybe that's fluid, but just pneumonia. Maybe it's just water in a sense. But as an infectious disease, and really as any physician, when you see worsening opacities or more dense shadows in the chest, have to be concerned about worsening of a previously documented process when you know there's a pneumonia there to begin with.
Okay. The last thing we'll publish here is number 438. Okay. Now this one looks like it's a study on October 13th. Is there anything different about this study? Well, let me ask that in a more direct way. This particular study, doctor, is not a chest X-ray, is it?
No.
Okay. The previous ones that we looked at were chest X-rays.
Yes.
And this one is an abdominal study?
Yes.
Okay. It was done for a different purpose than looking at the lungs themselves.
Yes. It says on the study requisition here that the reason for the study was taking an abdominal film to assess placement of a tube. And when a patient gets a tube placed in, like a tube in through the nose that goes down into the stomach, you take an abdominal film to assess the location and where that distal part and the end of the tube. So that was the purpose of this study.
Now, the lungs are also visible in a study of this nature, but it's not the purpose to focus on them.
Correct.
Okay. You mentioned a little earlier about the penetration of radiation and during different studies are taken. Is there anything at all that you could observe about an abdominal X-ray as compared to a chest X-ray in terms of the penetration of radiation and what that means to the interpretation of a study like this?
Are you asking in general, or are you asking with my review of this specific film from Ms. Schara?
By that, did you have an opportunity to review the specific film from the chart during your review of this case?
Yes, I have.
Okay. And were you compare, for example, the chest X-ray on the 11th with this abdominal X-ray on the? Okay. Are you able to comment on that specific review? What the effect of the fact is that one was a chest X-ray and abdominal X-ray?
Yes, in my review of the two X-rays that you referenced, the abdominal X-ray on the 13th that did contain some visualization of the chest also, that study on the 13th had more radiation exposure used than the X-ray on the 11th.
What does that mean?
So what that means is, if you're thinking of the lungs and opacities or pneumonias or other findings in the lungs, if you use more radiation to the film, those abnormalities and shadows in the lungs will look not as bad. So they will look artificially decreased compared to a study that has used less radiation.
Based upon your review of those studies on the chest X-ray and the abdominal X-ray on the 13th, did you come to any conclusion about what the X-ray on the 13th would have looked like if it were a chest X-ray rather than an abdominal?
So I didn't come to necessarily conclusions how it would have looked if it were a chest, but I did come to conclusions that if the amount of radiation, the exposure, if you will, was adjusted to be equal to that of the chest X-ray on the 11th, that the abnormalities in the lungs would have looked worse on the 13th than they did. So they would have been more dramatic, even more dramatic than those abnormalities were from the chest X-ray on the 11th.
Do you believe radiology study that you looked at from the 13th, which was the abdominal study, basically understated the degree of sickness or that are observable on that study?
It all depends what you're comparing it to. You know, I think if you're comparing it to the X-ray of the 11th, yes, I think it relatively understated the degree of in the lungs.
Okay, thank you. Now, you also talked in your report about the labs. In your opinion, are Grace Schara's lab studies throughout her stay consistent with a severe case of COVID-19?
Yeah, if we look at her labs as, you know, if not any one specific lab, but if we look at her labs in total, it was very much consistent with someone with COVID infection that over time progressed to a fatal illness. And there are a couple of labs that I think really help me illustrate that, and were lab findings that we saw over and over in patients that we have cared for.
Permission to approach, Your Honor?
You may. Doctor, I'm handing you a copy of what we've marked as Exhibit 439.
Yes, these are lab reports on Ms. Shara from between October 7th and October 13th. Select labs from her case, not the overall body of lab work.
Your Honor, publish a page of this document.
Any objection? All right.
Doctor, I want to call your attention specifically to the D-dimer numbers there. Do you see what we're talking about there?
Let me find it on this page. Yes, I do see that.
Explain what we're seeing, what a D-dimer is and what we're seeing there.
Yeah, so a is something that develops in our bodies and in our bloodstreams when clots in our blood vessels are down. So if we get, a cut and then we get a clot, remember over time, absorbs that clot. And as the clot starts to be degraded, that creates this byproduct known as a D-dimer.
That we're seeing here, it looks like, what are they telling us in terms of, what are those numbers? There's 22 and then 23,657. If you could explain what the date ranges and what these tell you.
Sure. On October 8th, her D-dimer test was a value of 2,243. And October 13th, it was almost 10 times that amount, a value of 23,657. Whereas the normal reading for a D-dimer test would be a value of under 500.
Okay. As an infectious disease doctor, did that have significance to you, that finding or that D-dimer?
Absolutely. And the reason this is me as an infectious disease doctor is D-dimer values of 23,057 were incredibly rare. Prior to COVID, in my career, I had never seen a D-dimer anywhere near that high. But during the COVID pandemic, we started to see values of D-dimers like this as routine features of our patients with severe COVID disease. And that's, as all goes back to the idea that we talked about earlier of COVID also being a virus that invades the blood vessels and causes damage within the blood vessels. And so this is really a marker of some of the damage that COVID is doing in the body. And not only are we seeing this value quite elevated, but we're seeing it increase in a 5-day period leading up to Ms. Schara's death, increased by almost a factor of 10 to a value of 23,657. And like that, we also know from studies were correlated with worse outcomes in people doing poorly from COVID. I would add that also, as an infectious disease doctor, we don't only think about infections. We think about, well, why else, our lab values abnormal? And initially, D-dimer in Ms. Schara's case was one of the tests that was used to look for a blood clot in her chest. It is also a screening test for somebody who has a pulmonary embolism. And if that value comes back normal in someone, you can be very confident that somebody doesn't have a blood clot in their chest or a pulmonary embolism. And so, so that's the fact that these values are elevated. We know a pulmonary embolism was ruled out by that October 6 CT scan. That leaves her COVID infection as, in my mind, unequivocally related to why these values are so sky high and worsening during her ICU stay.
And I believe you had said you'd never seen that before, or almost never saw that before the COVID pandemic?
In general, values in this range were extraordinarily rare. And prior to the COVID pandemic, I'd never seen one personally this high, but now I've seen it hundreds of times, all due to COVID.
Thank you, Doctor. Permission to approach?
Doctor, I'm handing you a document that we previously marked as Exhibit 440.
And do you recognize that document as a document you've seen before?
Yes, these are more lab reports from Ms. Schara. And these are dated October 10th through 13th. And also blood cultures from October 7th.
Permission to publish, Your Honor? 90, page 90. Doctor, there's on the bottom there under the hematology there's the WBC. Is that white blood cells?
Yeah, her white blood cell count.
Okay, and it looks like there's some numbers there that include a number of 7.9 on the 10th and 14 on the 13th. Am I reading that correctly?
Yes.
Okay. As an infectious disease doctor, does that have any significance?
Yes, absolutely. I mean, the values from the 10th, 11th, and 12th are in the, and if you reference the one on the 10th with a white count of 7.9, that's a normal value, whereas on October 13th, the value had almost doubled from the 10th up to 14, which is above normal. And a white blood count is one marker of many that we use to understand the likelihood that somebody is suffering from an infection. White blood counts are measures of inflammation in the body, but higher white counts are frequently driven by infections. And so when we see a white count double from the normal range into the abnormal range over a period of, 3 days, you start to get concern for a worsening inflammatory process, and in her case, with disease.
In your experience as an infectious disease doctor treating patients with severe COVID, things typical of late stage COVID? Okay. These findings that we just talked about, that hugely elevated D-dimer rate and this rise in the white blood cell count, are these findings characteristic of, for example, a condition of oversedation?
No, they're not. There's no relation over sedation to an elevated D dimer.
Okay. You talk a little bit about respiratory failure leading to inadequate oxygen in the bloodstream in your report. In your opinion, did Grace exhibit respiratory failure leading to inadequate oxygenation that was consistent with severe COVID disease?
Yes, there are different types of respiratory failure, and she had, acute, what we call acute hypoxemic respiratory failure, meaning that she needed extra oxygen supplementation to try to maintain oxygen values in her bloodstream. That became, unfortunately, more and more difficult to achieve as her infection.
Permission to approach?
I'm handing you a document previously marked as exhibit number 1. You've seen in your review of the medical records.
Yes, this is Dr. Shokar's note October 7th, and I've seen this before.
Okay. Permission to publish, Your Honor? Okay. Now, at the very top there, Doctor, at the top of that note, this is now from, looks like the 12th of October. The doctor's indicating there that after this morning's assessment, the patient's oxygenation saturations have deteriorated, requiring BiPAP settings of 100% FiO2, yet still her oxygenation was in the low 80s. Does this constellation of findings cause any concern to you as an expert in infectious disease?
Absolutely. I mean, what we're seeing here is that despite breathing pure inflow of oxygen, 100% oxygen, where normally we're breathing like 20 oxygen on our own. So she's breathing pure oxygen and still not able to maintain adequate levels of saturation of oxygen in her bloodstream. And as an infectious disease doctor, when someone with COVID and we see this, we know that generally at this point, the only way that to survive, or not even really not likely, but we even have a reasonable chance of surviving COVID would be if they were and placed on a ventilator.
And this is a fairly typical find end stage or late stage COVID where you have someone who's on the maximum setting of oxygen through, for example, a BiPAP mask, and yet still that person is unable to maintain an adequate oxygenation.
Yeah, when we see readings like this, it brings back a lot of almost flashbacks in my mind to so many of the patients that I've cared for who, you would see declining. And when you see readings like, they're in big, big trouble. And unless additional measures, invasive measures were taken, intubation, that they were not likely going to survive.
The number, an oxygenation in the low 80s, that's obviously abnormal.
Yes.
Okay.
Yes.
And are you familiar with, I guess, the effect of physiological effect upon the body of an inability to get or obtain enough oxygen?
Yes. I mean, what it really comes down to is at this point, your body is not able to provide enough oxygen to its vital organs to function. So when you see this problem happening, you're going to start to see organs shutting down in the body, such as the brain gets compromised. People's alertness levels can change, and they can become more confused or lethargic. They can develop kidney failure. They can start to show signs that their heart is under strain, and they might be irritation or even heart attacks can happen in this case. And
I
the list goes on.
One of the things you have, lack of oxygen or an insignificant amount of oxygen being can affect your ability to be aware. It can make you sleepy.
Absolutely. That's one of the hallmarks of, and often when when anybody presents in any medical setting, alertness is down, one of the first things that's done is they're always checking the oxygen level, because that's such a common reason people to not be awake fully or alert or thinking clearly.
Doctor, there's been some mention in the medical records and here at trial that there were periods of time on the October 13th where Grace was noted in the records to be somnolent. When one is deprived of adequate oxygen, is that in your experience a common finding, somnolence, as a result of that lack of oxygen over an extended period of time?
Absolutely. Yeah, particularly in people who don't have a previous history of long-term lung disease with low oxygen levels. If this is an acute, a new onset problem for someone, they're almost always going to be somnolent when their oxygen levels are.
Personally observed in treating COVID patients over the course of your career?
Absolutely. I mean, over 100 times did we see people that were somnolent from failure to get oxygen into their bloodstream from COVID.
And if a patient were experiencing abnormally low oxygen saturations over a period of several hours, would it surprise you that they would be noted as sleepy or somnolent?
No, I would actually, if it's this low in the 80s, I would often, that in many cases.
Okay. And if it were even lower than the 80s, again, you would certainly expect to see some result of air hunger or lack of airflow?
I wouldn't just term it air hunger, but really inability of the lungs to take in adequate oxygen and deliver that oxygen to the bloodstream. And when the lungs are starting to fail like that, somnolence becomes near universal.
Now, all of these things that we've just talked. Oh, certainly, absolutely.
So members of the jury, what we're going to do today is just take a 60-minute lunch break. All of you prefer 45 minutes, but this will give, I think, one of you enough time to do what needs to get. And so we'll start back up, 60 minutes from now, which will be about 12:40. During this break, we're not to discuss the case with anyone, including each other, no independent research. The food is ready for you, and they'll also make sure that the phones are back to you, so you have those. We'll see you in an hour. The jury is excused. All right, you can step down, doctor, if you want, and you could be back here in an hour. Does that work for you? Yeah, thank you. During that time, we had one sidebar. Attorney Boylan, you had asked to discuss what had been marked as exhibits 434 through 438. During the sidebar, you mentioned some deposition testimony, and I think your argument was focused on two things. One was that it may be cumulative, but then the stronger or the argument more time on talked about the fact that this witness's deposition testimony mentioned something about the images and them not being analyzed. Given the fact that he doesn't have any computer devices here, or machine was the word you used to help him, you thought that it'd be not helpful for the jury, and I think my response was, I think all that's proper cross-examination if that's happened. Anything you want to add to that sidebar?
To what was said in the sidebar, no. I would want to add that when we left the sidebar, indicated that the objection was overruled. And I actually had asked for a sidebar without making an objection because I was looking for your honor's wisdom on this point. So when we walked away and said that my objection was overruled, perhaps you did that by saying, I'm going to let him do the testimony. That's all.
Right, I'm not sure I did that intentionally. And I think you're correct. I think you asked for not an objection. Let me know if you want me to correct that.
I wouldn't mind.
Just by when we bring them back in, just mention that.
I'll leave it in your hands, Judge.
It brings it up again, a sidebar where I allowed them to ask anyway. Do you want me to?
We'll leave it, Judge. I just wanted to tell you that I wasn't sure whether it was the case or not, but I knew I did not make an objection.
Okay, I think you're right on that.
That's fair,
And,
but nothing more to say about
anything either of you would like to say on the sidebar? Attorney Guzzi?
No, not unless the objection or the comment about human.
Okay. I think during that session, I don't know if mistake in writing down exhibits. Do you have the exhibit list? Just gonna look at what the clerk has. So has 429 been offered or has been discussed? Attorney Francowiak, that you have 428 through 441, but I don't have 429 being mentioned.
No, I don't put 429. I think all the others I did, but 429 was not.
Okay, and then 303 are his report and CD.
Yes.
In that order. Right. You're offering those?
Yes.
Any?
no objection, Judge.
All right, so 303, 304, and then 428, and then 430 through 440. I think that note that I put under seal that we read earlier of that one juror who's going to do something during the lunch hour, I think that's the reason I gave 60 minutes. I just don't think he's going to be able to do that in 35 minutes, given the details of that record. I don't know the locations of things, but I think it's going to be more like closer to an hour. So it's going to give an hour lunch instead of 45. Anything else we need to do before we take our lunch break?
None from the plaintiff.
Nothing, Your Honor.
Okay, so we'll start at 12:40 on this clock. We're adjourned.
Maybe seated.
Members of the jury, hopefully everyone was able to accomplish what you do during the lunch hour. Our plan this afternoon is just to have a normal afternoon, so we'll finish this witness and then start and finish at least one more witness, but we'll see where it takes us. Frank Kowiak, are we?
Coming up the elevator just as I
Okay.
spoke to him.
So the witness will be here shortly and Doctor, you're back up on the witness stand and you can just have a seat when you get up there. Just a reminder to the still under oath and subject to the rules of perjury. And I think Attorney Frank Kowiak, you are finishing up your direct examination.
Okay, doctor. Before we broke for that break, we talked about a number of aspects of your opinion. These 7 or so aspects that we've talked about, do they fit a classic pattern for a case of severe progressive fatal COVID-19 disease in your personal experience as an infectious disease expert?
When you combine information on the time sequence of the events with her home COVID test result that was positive, lab values, her vital signs, her X-ray images, and her progressive signs of respiratory and lack of ability to get oxygen into the blood, all at a time when the Delta variant was killing large numbers of people. It all fits very, very tightly and consistently with a case of severe COVID, and unfortunately the type of case that we saw all too many of during this time window.
And doctor, have you personally witnessed this exact pattern in treating your own patients?
As I was just type of constellation of symptoms and lab findings and imaging findings and clinical course after hospitalization is really a classic type of COVID disease for severe COVID induced respiratory, and one we saw over and over.
Okay. Doctor, I wanted to ask, looked at the records in this case. Grace did not receive any antibiotics during her hospitalization, true?
Not that I saw, no.
Okay. Was there at all that required antibiotics?
Well, antibiotics are for treatment of a bacterial infection, and I saw no evidence in her case to suggest there was any presence of a bacterial infection. So no, antibiotics were not indicated as therapy here.
When we talk about infections, for example, the COVID-19 was a viral infection.
Correct.
And you don't treat viral infections with antibiotics, true?
No, so viral infections, antibiotic, because antibiotics kill bacteria and bacteria only, antibiotics would not have any effect against SARS-CoV-2, the virus that caused COVID. However, there are antiviral medications that are out there which can have effects against viruses, including the remdesivir drug, has the ability to kill the SARS-CoV-2 virus.
Doctor, you read my mind. These questions I was going to ask you relates to the opinion set forth in your report on some standard COVID-19 treatments. In October of 2021, what medications were provided to seriously ill, hospitalized adult COVID-19 patients who required oxygenation supplementation?
Yeah, and I'm glad you phrased that as seriously ill on oxygen, because it's when you're talking about someone who's an outpatient with COVID or someone who might be in the ER, but oxygenation. So at this point, in late 2020, the really constellation of medicines that would have comprised care for someone with severe and decompensating COVID, meaning worsening during the hospitalization, would have included the dexamethasone that she received, remdesivir, the antiviral, an IL-6 like tocilizumab, and also a convalescent plasma would have been a useful addition in this situation.
Okay, without, I guess, writing a textbook on these medications, I'm going to very briefly at least explain what these medications are. For example, you mentioned dexamethasone. What is dexamethasone?
So dexamethasone is a steroid drug, and which is a drug that, when given, blunts the inflammatory that our body creates. So normally, when our body faces a challenge, whether that be we bump our elbow and bruise our elbow, or be Ebola virus, when our body has an insult, our immune system responds to that by releasing inflammation to counteract it. And so inflammation is a necessary byproduct of the body's defenses against infection. But if you get a bruise on your elbow and it swells up, you get inflammation there too, because that your body sees there's a wound, there's a damage, and it needs to clean up that area. So that's how dexamethasone works.
Is this the medication mentioned earlier too that would tend to inhibit fevers, and therefore if you're seeing a fever when a patient is on this medication, that's a concerning thing for you?
Yes.
Okay. And did Grace receive dexamethasone?
Yes.
Okay, that was consented to by her father?
Yes.
Okay. You also mentioned remdesivir. Again, I guess without writing a textbook on it, can you tell us what remdesivir is?
So it is an antiviral medication that, when given, has the ability to directly attack the viral particles of SARS-CoV-2 that are in our body and make those viral particles decompose so that they can't reproduce in our body.
Okay. According to the medical record, did Grace receive this medication?
She did not.
Do you know why from your review of the record?
My understanding is it was something that was not agreed to by her family.
Okay. You also mentioned something called, and I'll try to pronounce this correctly, tocilizumab.
Yes.
What is tocilizumab?
So that is a drug that we call an IL-6 inhibitor. And IL-6 stands for interleukin-6. And what happens when you give tocilizumab is it effectively also blocks inflammation development in the body. So interleukin-6 is part of the chemicals around our body that create more and more inflammation. And so since some of the damage to our bodies caused by COVID was when inflammation got overactive, that the tocilizumab drugs, although not developed for COVID, were found to have benefit and favorable outcomes when given to those with severe COVID while they were in their first 24 hours of ICU care, or when they were transitioning from lower levels of extra oxygen support over to higher levels like the high flow nasal cannula or BiPAP devices that can provide more substantial oxygen supplementation.
Was the effectiveness of tocilizumab supported by studies or other scientific evidence?
Absolutely, yes. And so not every study that was done came out with favorable results for tocilizumab or similar drugs in the IL-6 inhibitor family, although over time, the data became more and more compelling for the use of this agent, and it became part of our standard repertoire for severe COVID disease treatment.
And by October of 2021, was that medication in the standard repertoire for treatment of COVID-19?
For people who had very severe disease while they were in their sort of early phases of what we call decompensating, meaning transitioning into the ICU to need care or requiring these extra levels of oxygen supplementation above just a typical nasal prong. And it ultimately has been shown in many studies to have reduced mortality and reduced death rates associated with its use for that situation.
According to your review of the medical records, did Grace fit in the category of patients who would be a potential candidate for tocilizumab?
Yes, absolutely.
According to your review of the medical records, did Grace receive tocilizumab?
No, she did not.
Review of the records, do you have an understanding as to why she did not receive that agent?
My understanding was that it was proposed by the treating team at a point during her hospitalization, but that it was not, it was never agreed by her family to provide her that medication.
Have a section of your report talking a little bit about your knowledge and experience with some medications typically given in the ICU. Your review of the records, are you aware that Grace received certain anti-anxiety medications in the ICU, including Precedex and lorazepam?
Yes, and anti-anxiety or generally medicines that can calm people and help people cope with respiratory distress like they have from COVID or other.
And were those medications that have been used in the treatment of your own patients in the ICU for severe COVID?
Yes, in fact, I would say that the patients who were in the ICU were treated with and lorazepam. Although those are not medicines ordered by me, they were generally ordered by medical care colleagues for the management of those patients.
Okay. For what purpose generally were these type of anti-anxiety medications typically used in an ICU setting for COVID-19 patients, in your experience?
Well, reasons are numerous, but the most common reason for it was the distress created by the inability to breathe, and the sense of shortness of breath, the inability to get oxygen in the body, and the body can to try to get more oxygen in, and that creates a tremendous sense of anxiety and panic amongst who are struggling to breathe. Also, devices that are used in the ICU can be difficult to tolerate. Devices such as anything like any sort of a face mask, the nasal cannula pieces that delivered oxygen into the nose, when those were set at what we call high flow types, they create a sense of a lot of wind blowing in the face that people sometimes couldn't tolerate. BiPAP and CPAP masks can be uncomfortable because they're adhered so tightly to the face to get a seal so that the oxygen is delivered into the chest. And many other reasons. You know, people have high fevers. They get confused and anxious from that. And just for many people, even being ICU setting itself is stressful. They're out of their own home environment. They're sick. Well, there's machines all over the place. Their sleep-wake cycles are disturbed. People are coming in the night to check vital signs, and the list goes on and on and on.
And in your experience, patients suffering from these severe deficits and are suffering from COVID can frequently experience these significant anxiety or events?
Absolutely, absolutely. Not only from COVID, but again, also from some of the systems and instruments and devices that are used to help someone survive COVID, that those can cause anxiety and alone.
Okay. Now, in treating patients in an ICU setting, have you prescribed and ordered medications for your patients in the ICU?
Absolutely.
Okay. That's something that you as a physician can do because you have the ability to prescribe medications.
Yes.
Okay. The ICU nurses caring for your patients do not order medications, but they would instead administer the medications that you might order for them if you thought the medication was appropriate.
Correct.
Okay. Given that you've prescribed or ordered medication for patients in an ICU setting, would you be the adjustment and redosing of medications required to, for example, respond to changes in a patient's condition?
Yes, I'm very familiar with that. It's a pretty broad question. So
Sure.
certainly, some medicines I'm more familiar with, others I don't even touch or don't have good knowledge of, but others I'm, have in-depth knowledge of.
In your experience, can changes in a patient's condition in an ICU occur rapidly?
By the minute or by the second?
Okay. By nature, a patient who's in an ICU generally is quite sick.
Yeah, absolutely. And that's why they're placed there. They're felt to require more careful and close and intensive monitoring to respond to these, critical illness, but also sudden changes in condition that can arise.
Okay. Would it be practical in an ICU care setting to require, for example, a physician to contact a patient's POA to discuss each and every medication addition, dose modification, or administration of every common medication before making change?
No.
And in fact, is that required as part of the standard of care in an ICU in October of 2021 for a physician to have to contact a patient's POA to discuss and every medication addition, dose modification, or administration of common medication?
That was not the standard of care in October of 2021, nor has it been at any other point in my career.
Is that?
It's something that's not even feasible, first of all. Medication dosages for a range of medications, such as blood pressure support medications, medication to help adjust heart rhythms, and medications that are needed in crisis or emergent situations, medications that have to be used when if somebody needs to be intubated in order to have a chance to, they can't endure the intubation unless they're given medications before that. And so that is an emergent situation at times where it has to be, immediately, or you won't have a chance to intubate the patient because they will have passed. And really complex patients in the ICU that have different illnesses or diseases they may have hundreds and hundreds of medication dose adjustments in the course of a day from medicines that are used concurrently to take care of such ill and unstable patients.
And the use of typically used medications to keep a patient comfortable, for example, like Precedex and lorazepam would fall in that category of medications that would not require, for example, permission from a POA for dose changes or administration.
Yeah, I don't personally Precedex. I do prescribe at times lorazepam for patients, but certainly those medications are really provided under what I think of as sort of the general consent for hospital services, and that not each time something like that is ordered or administered or a dose changed is consent from a POA requested or obtained.
You also discussed in your opinion the role of the mechanical ventilator in the treatment of COVID-19 patients. Now, in your review of the deposition testimony in this case, did you become aware of some concerns expressed by Mr. Schara relative to the use of mechanical ventilation via endotracheal tube?
Yes.
Okay. According to your review of the testimony in this case, what's your understanding of Mr. Schara's belief as to the efficacy of mechanical ventilation via endotracheal tube?
Understanding of the case was that Mr. Schara held an opinion that ventilators for potentially harmful for patients with COVID and added to rates of from patients with COVID.
Doctor, in your opinion, in October of 2021, did mechanical on a ventilator via endotracheal tube represent a useful and sometimes necessary mode of treatment for patients suffering from a severe COVID-19 infection?
Absolutely.
Can you explain for the jury the history of how ventilators were viewed and used throughout the COVID pandemic as time went along?
Sure. So, very earliest days of the COVID pandemic, when cases arrived in the United States in January of 2020, there was hesitance to use ventilators initially because people were so sick and they were placed on a ventilator. By that point, most of them died. And as the pandemic evolved, it was realized that the reason that those people initially placed on ventilators had died was because they had such issues with COVID, and despite the potential advantages a ventilator would have given, it wasn't enough to make a difference and overcome the COVID damage to the lungs and the COVID burden on their bodies. But that was only in the very earliest days. It wasn't long until ventilators became the standard of care for someone with respiratory failure from COVID, and became widely used as an effort to try to sustain people who had severe COVID lung disease, and were in and the norm in ICUs. And in fact, they became so much the standard of care that ventilators ended up being in shortage around the country. And many of us will remember all these reports of hospitals running out of ventilators. It happened. And there was something was developed called the Dynamic Ventilator Reserve through the American Hospital Association, which was essentially a way for hospitals running out of ventilators to borrow ventilators from other facilities that had them available. And that's something institution participated in. And in fact, we shipped ventilators to New Jersey to help institutions in New Jersey and patients in New Jersey that needed mechanical ventilation. And so ventilators have played an essential role in helping people survive COVID pandemic and remain in use as we speak today.
Doctor, in your own hospital in October of 2021, did you utilize ventilators in the treatment of COVID-19?
Yes. Over and over, it was a standard for our sickest patients with respiratory failure.
And I believe you said you have had a chance to read the depositions of plaintiffs, two experts in this case?
Yes.
Are you aware, as you sit here today, that both plaintiff's nursing expert and plaintiff's pulmonary expert agreed that respective hospitals, they used ventilators in the treatment of COVID-19 patients as well?
Yes, I'm aware of that.
And did that surprise you at all to read that?
No. I don't know of any hospitals in the United States that I'm aware of that did not use ventilators for COVID treatment in October of 2021.
Okay. Do you have an opinion as to whether a mechanical ventilator would have been a potentially useful option for the treatment of Grace's severe COVID disease in October of 2021, had her physicians been allowed to intubate Grace and to put her on a mechanical ventilator?
Yes, I do have an opinion on that.
What is that opinion, doctor?
My opinion is that once Grace got to the point of having such severe COVID disease that she was not able to sustain her oxygen levels despite the use of the BiPAP device. Hope of survival would have been to be intubated and put on a ventilator. But that even then, if she had, I think her chances of survival would have still been low, consistent with what we know about advanced COVID infection, but she would have had a better chance to survive.
In your records, did you encounter any instances in which physicians had requested authority for Mr. Schara to place a ventilator should her condition decline precipitously to a point where she might require mechanical ventilation to preserve her life? Do you have an opinion as to whether it was consistent with the standard of care for these physicians to seek authority from Grace's decision to place her on a ventilator should her condition so require for the preservation of life?
Yes, I think it definitely was standard of care. And I think if the treating physicians and critical care physicians had not discussed that and proposed that as an alternative, would have fallen beneath the standard of care. I think the standard of care was absolutely to bring that out as an option for potential therapy for.
Review of the medical records, did you find any instance in which Mr. Schara granted authority for the use of mechanical intubation with a ventilator for Grace?
You mean with intubation with mechanical ventilation?
Or with a ventilator?
Yes, I saw it. It was and proposed to him.
And did you find any indication in the medical records where that authority was in fact granted?
Not see that authority would.
You also talk a little in your report about some agitation that Grace was experiencing. In your experience as an infectious disease expert treating COVID patients, is it typical for patients to experience the type of agitation that you've already discussed here today?
Yes, for severe COVID disease.
And that is as you describe it, like an involuntary agitation rather than voluntary agitation, for example, caused by air hunger.
I guess I don't differentiate them. To me, any type of agitation has a cause, whatever the cause. But certainly it was tightly in the COVID patients I've cared for with the, severe COVID disease, very closely associated with respiratory failure, lack of ability to get adequate oxygen into the body, and also use of machines to try to augment that ability and oxygen delivery.
And in your experience, were there typically multiple triggers for such agitation?
In many cases, yes.
Okay. Is the presence of fever one such potential cause of agitation?
Indeed, yes. Fever itself is a strong driver of agitation and or confusion in those in healthcare settings.
Okay. And you previously mentioned that low oxygen levels can also be a driver as well.
Yes.
Okay. Can nutritional problems sometimes be a driver?
They're very nutritional problems are known risks for development of agitated delirium in healthcare and hospital settings.
Okay. In a COVID patient in the ICU, particularly one who is receiving non-invasive mechanical ventilation like BiPAP, when that person's experiencing agitation, important from your perspective as an infectious disease doctor to address that agitation?
Although generally I leave the management of that to the critical care physicians on the case, but I recognize it as an important intervention. Because when people are agitated, it makes them able to work with the machines that are augmenting their breathing and augmenting their oxygenation. So we definitely recognize it as a very step to try to keep someone calm to have a chance to improve their respiratory function.
In this case, that it was the removal Shara's father, Scott, from her hospital room on the morning of October 10th that was the cause of Grace's agitation in the ICU in this case. Do you have an opinion to a reasonable degree of medical probability as to whether it was the removal of Grace's was the cause of the agitation that you saw evidence of in the record?
That Mr. Shara's removal was the cause of Ms. Shara's agitation in the hospital.
You do not? Okay. Do you have as to what was the cause in Grace's particular case of the agitation that you were seeing?
I think the causes were numerous. I think the causes were mostly the severity of her COVID disease. Her body had to work to try to get oxygen in. Also, the fact that she had pre-existing cognitive issues that increase that someone in a hospital setting will become agitated. Hospital for a prolonged period, we find that their sleep-wake cycles get changed. They often sleep awake at night, and their sleep is very disturbed at night, particularly in the ICU. Contribute to agitation as well, and just for many people, of course, just being a familiar environment and in a hospital setting that is sterile and has scenes and strange people all over the place, that itself can be a driver of agitation. So I think it was really multiple contributing factors that drove that.
Doctor, have you reviewed the death certificate of Grace Schara?
Yes, I have.
And do you understand as you sit here today that the death certificate for Grace indicates that her death was a result of COVID-19?
Acute hypoxemic respiratory failure due to COVID-19, yes.
Do you agree with the opinion in her death certificate as to that cause of death?
Absolutely.
Do you hold that opinion to a reasonable degree of medical probability?
I do.
Okay. Are you aware, based upon your review of the materials in this case, that the plaintiff in this case takes the position that Grace Schara's cause of death was something other than COVID-19?
Yes.
Okay. Is it your infectious disease doctor?
Yeah.
Plaintiff in this case that Grace Schara's death was somehow caused by
yes, I've seen that proposed as a driver of the cause of death for Ms. Schara.
Are there aspects of the case, in your opinion, that would refute this contention that Grace Schara's death was caused by oversedation?
First of all, on the day of her death, it was documented that Ms. Schara was kind of thrashing her head and moving around when the nurses tried to the nasogastric tube in place on her face, and also when the nurses or respiratory therapists were trying to the oxygen delivery device on Ms. Schara's face, that she was thrashing around. And that's not something consistent with somebody who is sedated. Somebody who's over sedated hardly moves, and sometimes doesn't move much at all, and sometimes responds only to, when we to pain and to induce painful stimuli to get somebody to move. So when someone with simple maneuvers such as putting up at all, sometimes responds only to, when we to pain and to induce painful stimuli to get somebody to move. So when someone with simple maneuvers such as putting a piece of tape on the cheek, repositioning an oxygen device is thrashing around, that argues against that. Additionally, when people are over sedated, their brain can't tell them to breathe. And so the respiratory rate drops to below normal levels. If we think about it, a classic example is the epidemic of narcotic overdose deaths that we're seeing in the United States. Those are characterized by people who their narcotics make them so they can no longer respire and no longer trigger a breath. So their respiratory rate drops and to the point they can't sustain life any longer. And on the day of Ms. Schara's death, her respiratory rate on numerous cases was several times the normal level. And that argues against over-sedation. People who are overly sedated aren't breathing at super high rates. They're breathing at low rates. Other evidence that we saw is related to her blood gas testing and some of the lab work. When people are over-sedated, one of the paramount findings of that from lab work to support that is a buildup of carbon dioxide in the blood. And that happens because the people are not breathing at normal rates, and the lungs cannot exhale the carbon dioxide that's building up. And so you see supranormal, high above normal levels of carbon dioxide on arterial blood gas testing. And on October 12th, the blood gas testing done in Ms. Schara documented normal levels of carbon dioxide.
Have you reviewed the all three of the expert reports authored by Dr. Burdine in this case?
Yes, I have.
Okay. And he testified to a theory that he holds as to the cause of
Handing you them individually.
Okay. And that was not seen on Ms. Schara's blood gas from October 12th, the day before she died. Her pH was normal. Additionally, on the morning that Ms. Schara died, there was not a blood gas, but there was an arm blood draw that measured something called bicarbonate in her blood. And her bicarbonate value on the morning of the 13th was also normal. And to have a metabolic acidosis, you generally see, you have to see below normal bicarbonate values. And by the afternoon, shortly before her death, that bicarbonate value from an arm blood draw was repeated, and it was only slightly below the normal range. And so that is something that would not have reached the realm of clinically significant because it was so close to normal. And so we see no evidence in the chart whatsoever from the lab testing that Ms. Schara ever developed acidosis severe enough to make her overall blood pH drop. And additionally, importantly, the concept here of a metabolic acidosis does nothing to explain the other critical findings in Ms. Schara's case, that she had abnormal chest x-rays with infiltrates. She had fevers, sometimes high fevers, throughout the course of her hospitalization. And she had D-dimer values that rose to, by a factor of 10 over a period of a few days. None of those have any connection to a metabolic acidosis at all, and ultimately are all brought together under a unifying diagnosis of COVID-19 disease.
Doctor, I want to talk a little bit about to address in your report.
Not only familiar with them, I helped develop those protocols and policies for my institution as part of the incident command team for the health system.
Okay. According to your experience, were hospital policies that restricted visitation widespread during the COVID pandemic?
Yes, actually, they were very widespread and in many places mandated by health departments.
Hey, why did your hospital have such policies, and why did the health department frequently mandate such policies?
There were multiple reasons for it. One of the key reasons, of course, what we all aim to is protect patients. And the more people during the midst of a pandemic, when COVID is rampant in a community, the more people coming in and out of a hospital, the more COVID is going to come into your hospital, and the more patients are potentially exposed to COVID. So that was a key driving factor. A second factor was that there were critical shortages of healthcare workers during these waves of COVID, in particular the Delta wave. And so there was also a need to protect healthcare workers and as to whether it's better do their work taking care of patients. And in fact, the critical water in a sense, but those are the primary reasons of the restriction on hospital visitation.
You mentioned in there that there was a critical shortage of hospital workers during the depths of the pandemic. Were physicians and nurses in your own institution during the COVID pandemic required to wear personal protective equipment while in ICU rooms?
Yes.
Okay. Was it understood that personal protective equipment provided a level of protection against contraction of COVID for healthcare providers?
Yes, particularly if that involved the use of N95 masks.
Okay. Was PPE in October of 2021 100% guaranteed to prevent a caregiver from becoming infected? Yeah. Would the presence of a symptomatic visitor in a COVID ICU ward in October of 2021 have been concerning for you?
Not only concerning, it would have not been something that would have been allowed to continue in not only in the ICU, but in the hospital in general.
Okay. In the course of your preparation of your opinions in this case, did you review physician testimony of Nurse Allison Barkholtz?
Yes.
Are you aware, as you sit here today, that Nurse Barkholtz has indicated that the primary reason she required Mr. Schara to leave the hospital on the morning of October 10th was because she was concerned for his health and safety given the severe COVID symptoms he's been expressing?
Yes, I was aware that that she noted that he was exhibiting symptoms of consistent with COVID, and so that was the reason he was asked to leave.
Okay. Are you aware from your review of Nurse Barkholtz's testimony that it was hospital policy at the time to request that COVID positive or symptomatic visitors either stay away from the hospital or leave the hospital?
Yes.
Okay. Do you have an opinion as to whether St. Elizabeth Hospital's policy restricting visitation during COVID pandemic and that symptomatic visitors leave the hospital complied with the standard of care as of October of 2021?
Yes, it was the standard of care, as was actually screening individuals upon entrance to the hospital for potential COVID symptoms. Not only visitors, but healthcare providers and staff were also screened for that at most institutions.
Would Nurse Barkholtz's action in relating to Mr. Schara that he would need to leave the hospital in light of his symptomatic status and impaired physical condition also be consistent with standard of care?
Yes,
Okay. Do you hold that opinion to a reasonable degree of medical probability?
I do.
In your own treatment of ICU COVID patients in October of 2021, how did you typically communicate with family members for your patients?
Well, we used a range of measures, given that most COVID patients in our hospital did not have visitors in alignment with our hospital policies and our health department orders. We communicated in many ways by telephone, sometimes by FaceTime. And one way that was particularly helpful was that iPads were actually given to the patients, and myself and the patient could communicate on FaceTime jointly with a family member or a patient's support person, who might have been outside the hospital or sometimes in another state or occasionally even another country.
And that was something that you personally did in the treatment of your patients throughout the COVID pandemic?
Yes.
Okay. Was that in response to the fact that due to the exigent situations of the COVID pandemic that you weren't allowed to have visitors routinely in the hospital?
Yes, for most patients, except again, only by, exception were these patients, were patients allowed to have visitors or under extraordinary circumstances. And in that case, even in that case, visitation was quite limited to certain hours of the day.
Okay. And this communication that you would have virtually with family members of your own patients, would that include even for patients who had, say, an active POA or might have a disability that would require them to have a decision maker offsite?
It did at times, yes. If we did not have a decision maker or POA present because they fell under the small number of patients that were allowed, visitors, or if they were at the end of life and which was characterized as death was felt to be imminent within the next 24 hours, patients had visitation at that point. So in that case, there would have been a visitor present. We would have been able to communicate directly in person, but in other cases, there weren't visitors present, so we used virtual mechanisms for that as well.
And were you able to adequately communicate with family members, even in the situation of a POA, remotely, like through the iPad, like you discussed?
It's never as good as being face-to-face with someone, and we all realize that. And the optimal way is to have someone available face-to-face to talk to, because you always have, I think, a more productive discussion. But given the limitations of the demands of the COVID pandemic and the amount of illness that family members often had, because remember, anytime there's a patient in the hospital with COVID, everybody in their household was likely exposed. So a family member of an admitted patient is going to have a higher chance of being transmitting COVID just by the fact they have a higher recent exposure and are incubating COVID. So so certainly we prefer face-to-face anytime, and that's for any situation. But in the absence of the ability to have that, we found the virtual mechanisms quite effective, particularly FaceTime. I think FaceTime was really made patients feel more at ease, that they could visualize their loved one or their family member as opposed to just, hearing a voice on speakerphone.
Doctor, based upon your review of the materials in this case, are you aware that the plaintiff contends that resuscitation measures involving the administration of medication reversal agents could have been initiated at the time of Grace's arrest?
Yes.
Doctor, do you have an opinion as to whether resuscitation efforts conducted at the time of Grace Schara's arrest on the evening of October 13th were likely have resulted in resuscitation?
I think the chances of resuscitating Grace at that time approached zero. A, because of the severity and advanced state of her COVID and the damage it had caused in her body, but also B, because anytime resuscitation is attempted after someone has had an arrest, it universally involves the use of mechanical ventilation. And it was, Ms. Schara was not one who was eligible for mechanical use of a ventilator because of decisions made on her health care. Understandable decisions, I would add, but decisions made from her family that even if resuscitation had been attempted, she would have died because there would have been no ability to use a ventilator.
Okay. And let me just ask a little bit further or drill down on that just a bit. In terms of the performance of, say, CPR, in order to be successful, would that require, or would that have required mechanical intubation?
Yes, really, we don't ever attempt CPR or, other quote unquote heroic measures like defibrillation if ventilation has not been going to be used, because a big part of a arrest leads to the buildup of extra carbon dioxide in the lungs. And when you use a ventilator, you can then, in a sense, take control of that removal of carbon dioxide from the lungs. And so it's an absolutely critical aspect of resuscitation when heroic measures are desired. And without it, it's futile to attempt resuscitation.
Of if a reversal agent for some sort of medication were given at the time of the arrest, doctor, would that still require intubation in your experience and expertise?
Absolutely. Yeah. Someone like Ms. Schara, had inability to deliver oxygen into her lungs because of her progressive COVID, and then went into cardiac arrest. If that arrest were related to over-sedation medications, ventilation and use of a mechanical ventilator would have been integral to any attempt to save her at that point.
Why is that?
Because those over-sedating medications, and so if you're over-sedated, you can't initiate breath, so A, you can't get oxygen in your lungs and body, and B, your lungs can't then blow off the carbon dioxide that builds up. So people have carbon dioxide toxicity as well. Look for
your opinion that any attempt at resuscitation of Grace Schara on the evening of October Doctor, does the placement of a DNR require a physician order?
Yes.
Okay. Would the rescission of a DNR order require a physician input?
Yes, it would require a physician order. And in some states, two physician order.
In your experience as an infectious disease physician working in an ICU setting, would it be would a nurse have the ability to simply ignore a DNR order?
No.
Okay. A DNR order could not be rescinded without a doctor to do that.
Correct.
And the doctor would have to show up, assess the situation, and decide that a rescission is appropriate.
Well, the doctor would have to have had a discussion with the either the patient prior to the arrest or with the patient's POA in order to rescind an order. The doctor wouldn't necessarily have to be physically present if that discussion with a POA occurred via telephone.
Okay. Doctor, do you hold an opinion to a reasonable degree of medical probability as to whether Grace Schara's illness and death based upon your review of the medical records represents a classic case of COVID-19 disease during the lethal Delta variant wave of the pandemic?
Yes, I do.
What is that opinion?
My opinion is that Grace's case, unfortunately, was a textbook case of progressive COVID leading to hypoxemic respiratory failure and death.
Doctor, as an infectious disease specialist who treats patients just like Grace in an ICU during the same time frame, did you personally witness the same type of downhill course ending in death that was exhibited by Grace in this case?
Yes, all too many times.
Do you hold an opinion as to whether Grace Schara would have died as a result of her COVID-19 infection had she never been admitted to St. Elizabeth Hospital on the morning of October 7th?
I do. I think she would have died.
Sorry. I understand that what he's going to say, but quite honestly, it's just speculative. And there's testimony from Dr. Shokar even about the inability of a doctor to determine at one point any other person will die. Speculation.
Experts are allowed to speculate. So you want to ask?
Doctor, do you hold an opinion as to whether Grace Schara would likely have died as a result of her COVID-19 infection had she never been admitted to St. Elizabeth Hospital?
I do have an opinion.
What is that opinion?
My opinion is that she would have died from her 19 disease, and in all likelihood would have died even sooner at home because she would not have been able to receive the level of support that she received during her hospitalization in terms of additional mechanisms for providing oxygen supplementation, and she would not have been receiving dexamethasone treatment at home either.
Doctor, do you hold an opinion to a reasonable degree of medical probability as an infectious disease specialist as to the cause of Grace Schara's death?
Yes.
What is that opinion?
That she died from COVID-19 disease as a result of SARS-CoV-2 virus infection leading to acute hypoxemic respiratory failure.
Doctor, do you hold all of the opinions you've expressed here today to a reasonable degree of medical probability?
I do.
Thank you, doctor. Those are all the questions I have for you.
Attorney Guzzi,
Questions, Your Honor?
examination.
All right, thank you, Judge. Judge, just based upon based upon the direct exam, I do have some documents that I know will be, I'm pretty sure I'll mark as exhibits. So there are going to be others that I may also bring up on my computer that I came up as a result of the direct exam. So I'll have some other documents as well. But for now, I have a set of documents that would be marked, yes. St. Elizabeth, Guzzi, and the court. So those documents have the exhibit sticker on them, but no number because we didn't know what number would be coming next. And at some point, I will also need to get the cord plug, let my computer show the computer screen.
No, we're gonna do it on this.
And I'm not asking for it to be brought up yet, but just that I have the ability to bring it up when I need to. Thank you. All right, Dr. Fisk, hello.
Hello.
I met you in California for the first time back in February. Do you remember that?
Yes, I do.
Okay, nice to see you again.
Likewise.
When you were out in we were out in California back in February, you told us about your background, and you also have a business that you are the CEO of, is that right?
So I'm the Chief Medical Officer of public health company now known as PHC Group. So I'm not the CEO of that. I have my own medical corporation, which is just David Fisk, MD, Medical Corporation. So that's in a sense my employer. So I work for myself.
So do you have a business side and a practice side? Is it fair to say that?
A business side.
Do you have a business that's working on, I think, getting better to recognize with AI the coming next pandemic?
I don't own a business to that effect. I contribute and I'm a consultant for PHC Group, and which is a business aimed at improving our ability to detect and provide guidance on pathogens and biothreats. That's a small minority of the time that I spend.
All right, thank you. One of the things we talked about when we met previously was your level of expertise or your level of knowledge on Precedex. And for example, if I asked you, why is there a requirement for Precedex to be administered in an ICU? Could you?
Yes, it's as in many drugs, it's something that has a significant risk profile to it, and so-called a narrow therapeutic index. So it is a drug that can have benefit, but also a drug that has risks with it. Plus, it is something delivered intravenously.
When did you learn why it has to be administered in ICU?
Oh, well, and that may vary from institution to institution. At our institution, it's been that way as long as I can remember.
Okay, so in practice, you understand it to be administered in ICU, and I'm asking you, why is there a requirement everywhere that it must be administered in an ICU?
As I mentioned before, it's because it's a drug that has what we call a narrow therapeutic index, where it has a level at which you can provide the dose at which you can provide it that's beneficial, but it also has risk for side effects and complications if the dose is adjusted, and for an individual that dose causes side effects. So it's a drug where the risk-benefit ratio and risk-benefit calculation has to be watched very carefully, and has to be monitored closely with careful attendance to the effects it's. And are you seeing the desired effects or the undesired effects, and how much of each?
Okay, and you feel comfortable commenting on that?
Again, I don't consider myself an expert in Precedex. I don't prescribe the drug. But I am familiar with it, and it's used in many of the patients that I care for, but it's not something I consider myself an expert in.
So there are questions about Precedex that you cannot answer. Okay, I actually am going to ask to each party, I'll let you know, I want to bring up his deposition transcript. And I'm going to bring up page 197 of that transcript. I don't want to bring it up yet until everybody else has a chance to get there. And then I will ask the court that I could publish that to the jury to refresh Dr. Fisk's recollection. 97, starting at line 14.
No objection. No objection.
It's on my screen, so I'm plugged in. Dr. Fisk, do you remember when I asked you, I don't know, earlier this year, if you could tell me why is there a requirement for Precedex to be administered in an ICU? After some much wrangling, you told me first you don't want to comment on it, and then your answer on line 25 is you can't comment on it. Is that the testimony you gave in February, that you can't comment on why Precedex is given in an ICU?
Yeah, I spoke in the deposition and I provided my insights today, and that's all I have to offer on it.
Why is your answer different today than it was then?
Question was a little different.
Here's my question, and I made Judge ask the court reporter to read it back. My question was, why is there a requirement for Precedex to be administered in an ICU?
Yes. Yep. My answer would be the same, that because it's a drug with significant risk, and as with all drugs that are required, it's not specific to Precedex. All drugs that are required to be given in an ICU are drugs that require very intensive monitoring because of the relative benefits and risks of the drug. So again, I'm not familiar with Precedex and in terms of providing it as a drug. So I don't want to comment and have anything to offer on that.
Is it because the FDA has a package insert for Precedex that says Precedex must be administered in an ICU?
I don't want to comment on that. I'm not familiar with the Precedex package insert.
You're not familiar with the Precedex package insert?
Detail, no.
No.
I'm familiar with the drug and its use. I've seen it, but I have not, because it's a drug I don't use and prescribe, I have not reviewed the Precedex package insert in detail. I saw an outdated version of the package insert, I believe was submitted as an exhibit from Dr. Burdine. But again, it's not an area of my expertise, so it's not something I focused on.
I would ask screen to go away so that the deposition is closed. I'm going to ask you a question. Could you tell me whether it's the standard of care to ignore hypotension during the administration of Precedex?
No, I can't comment on specific issues that if they are associated or felt to be triggered by Precedex, but I can respond by saying anytime there's hypotension in a patient, it's the standard of care to pay attention to it, whatever the cause.
And that's not what I asked you. I asked you whether you can tell me whether it's the standard of care to ignore hypotension during administration of Precedex. Your answer is no, you can't tell me, can you?
That's not my answer. No. So you're asking a question that goes beyond just what can happen in the administration of Precedex. I'm not offering standard of care opinions on Precedex dosing and management because I don't use it. But say hypotension during that time, that is a standard of care of which I'm familiar with. And so my answer would be, because hypotension has arisen in the patient, the standard of care is that it should be evaluated and attention paid to it, and it should not be ignored.
Is it the standard of care to administer morphine to a patient who is without a pulse?
Um,
This states the evidence. Overruled. Go ahead and answer.
So, in most situations, it is, it depends upon the cause of the lack of a pulse. But in general, morphine administration is not given to someone without a pulse.
And ask for the computer screen to be brought up. I'm sorry. And it's page 209 of the deposition transcript. Here you gave me a really not a straight answer, but in February you did. I asked you the question, is it standard of care to administer morphine to a patient who is without a pulse? And then it says there's some objections, but you're the witness. What was your answer?
Is no.
You? We could take the screen down. I'm going to ask for exhibit 132. And I'm going to put on the screen. Everybody has a copy of it.
And we'll have the clerk pull out the original.
I have it on my screen. I could bring it up on my screen.
Or that's in the packet that you just handed to us?
I'm sorry, Judge. I did this numbering wrong. It is the third document, or actually the second document in that packet. It's a February 10th letter to Mr. Frankowiak. It was labeled Exhibit 132 at the deposition. I apologize. It's going to have a new number.
Number
79.
Exhibit 79 is being handed to the witness.
And could we bring my computer screen back up? Because that's where I'll have it. I'll ask to be, with your permission, Judge, for number 79 to be published to the jury.
That's fine.
Could you identify this document for me, Dr. Fisk?
Sure. This is the invoice that I sent to Mr. Frankowiak on February 10th, 2025 for my work on this case since December 2nd, 2024.
Is there a second page to the document?
Yes, that's a June 14th invoice to Mr. Frankowiak for the same, but from a different time span.
So are these invoices accurate?
As far as I know, but if there are any mathematical errors, I'm not aware, but they look accurate as of that time.
So as of that time, as of February 2025, asking you the questions about morphine and Precedex, how much had you charged for your time?
Meaning in total between the two?
Yes, doctor.
Yeah, about $32,000.
To today's date, do you know how much you've charged for your time?
No.
Do you have an estimate?
No.
February 7th and February 10th on your invoice, as well as 8th and 9th, there's indication that you were drafting your report on those days.
And also on the 3rd of February, it says I was drafting my report.
All right, in the 6th.
Yes.
All right. On the 7th and the 10th, when you were drafting your report, you had some calls with a Jason F.
Yes.
Who's that?
Mr. Francoia.
Going to have another exhibit. It's the document that was exhibit 134 from the deposition.
Mark that as exhibit 80 and turn it over to the witness.
Wrong. Do you recognize that document, Doctor?
And looking at exhibit 80, I see 2 pages of emails between myself, Mr. Francoiak, and other members of his staff.
Do you see an email from you on February 10th? Is that the day you wrote your report? You completed your report February 10th?
I don't know off the top of my head.
Do you have your report in front of you as one of the exhibits?
Sure, let's reference it. It was filed. Filed February 10th.
Okay. So you have an email here on February 10th, around midnight, 12:13 a.m. to Mr. Francoiak.
I do.
Says you have a couple quick questions for him. Do you see that?
Yes.
What were your questions for him on February 10th at 12:13 in the morning when you were? Go ahead.
I don't recall. I assume they were questions related to my drafting of the report, but I don't recall the specifics of those questions.
Thank you. Did you ever file an updated report?
I honestly don't remember. Whatever's been provided as exhibits but I don't remember if it was ever refiled. I don't think it was.
Okay. And during your direct examination, Mr. Francoiak did not present you with a copy of the updated report, of any updated report. You don't have one in front of you, do you?
The copy that I have is the February 10th one.
Okay. That's the only one I have either, and I believe that's the only one that's in the court record. I actually need to ask for the screen then to be turned off again so I can something that hasn't been marked before it's to the jury. You spoke about in your direct examination being an infectious disease specialist, and you were asked in some ways to compare what information you could offer versus what Dr. Burdine could offer as a pulmonologist. Do you remember that topic? So your wheelhouse is the infectious diseases. Tell me if you agree with me or not. Dr. Burdine's wheelhouse is pulmonology. Okay. Pulmonology is what?
Pulmonology is the field that is related to the study of the physiology of the lung and abnormal pathology and illnesses that arise within the lung.
Okay. So Dr. Burdine is a lung doctor, you are not. Grace Schara had Down syndrome. Are you aware of that?
I am.
How independent was Grace Schara?
So I don't have a huge amount of information on that, but my understanding is that she was living at home and had able to feed herself and also had family members around her that were supportive of her, but I don't have a lot of details on that.
Understanding is that?
Yes.
Where do you get that understanding from?
The documents and records that I reviewed in this case.
Well, I want to tell you sort of a fork in the road as to Grace's Down syndrome. Tell me, where did Grace Schara go on her own versus where did she go with someone else?
Yeah, I don't have great detail on that available in my recall.
Okay, so instead of great detail, then I need to take it down a notch. Tell me any detail you have about that question.
Yeah. Well, I know that she attended a concert with family members at some point.
Anything else?
Nope.
Would you agree that Precedex can cause a drop in blood pressure?
Again, I don't present myself as an expert on Precedex, but it is something I have observed in patients of mine who I've seen on the drug.
Would you agree that morphine can cause a drop in blood pressure?
Yes.
You agree? You acknowledge that a drop in blood pressure can lead to a production of lactic acid?
Yes. It's severe enough and sustained enough so that the muscles in the body are not adequately perfused with blood and that the waste products of the muscles are not adequately removed by blood flow. So not always, but it can.
Okay. So depending on what the dosage of Precedex is, along with the dosage of morphine combined, based upon the dosages of those and the patient's characteristics, the lactic acid could get too high?
Overruled. Go ahead.
Yeah, so there are so many factors in the body that regulate the production of lactic acid that I think it's impossible to tie two medications to overproduction of lactic acid, but you also have to assess overproduction versus the body's ability to clear lactic acid. So the level of it in the body is a balance of the buildup and removal of that. So,
what would affect the body's ability to clear the lactic acid?
So there are many factors in certain electrolytes in the body, pH issues in the body, how well conditioned somebody's muscles are there, in terms of in terms of their cardiac function, their cardiac output, and many other factors. It's a very complex balance within the body. So it's a question with two medications, and that again, when hypotension arises, when medicines are happening, It's not always because those medications are administered. Hypotension arises because of progressive infection. And so that can lead to a buildup of lactic acid at the same time somebody's been receiving other medications like morphine.
If a person is over sedated and their respiratory rate drops to a certain point, I am going to ask to have the witness shown the next exhibit. It was exhibit 133 at the deposition. It's the document entitled Documents Provided to Dr. Fisk.
We marked as exhibit 81 and the clerk will provide it to the witness. Break right after this exhibit when you finish with this.
Okay. Dr. Fisk, do you recognize that document?
Not off the top of my head, no, but I have, I don't know the date that this document was drafted, so I can't say I recognize it.
I'd like to bring the document up on the screen. And if there are no objections, I would like to have this document published. Oops. And you have a copy of the document in your hand, is that right?
On the screen, but what I have is a copy of Exhibit 81, if that's what you're referencing.
Is it marked Exhibit 133 in the bottom right-hand corner?
Well, there is a 133 written, but under the word exhibit, there's a number 81.
The clerk places the trial exhibit over the deposition exhibit.
Which it's placed over the deposition exhibit.
Yes.
Okay.
So he's looking at, and I think I'll clear this up on the way it was marked. So exhibit 81 is the same as deposition exhibit 133.
Thank you, Judge.
Okay, which is the document that everybody is looking at.
So up on the screen, Exhibit 133, do you see that has your name on it and the date?
I see my name and I see a date, but my vision is not so great. Now I can see it. Yes.
So the document you now have is Exhibit 81. You've previously seen Position Exhibit 133
Okay.
in February of 2025. Is that right?
Okay.
Is that yes?
I have no reason to dispute that.
At the top of the page, the second bullet point indicates you reviewed the medical records relating to this case from St. Elizabeth Hospital. Is that right?
That's right.
And those were labeled numbers 1 to 996. Do you see that?
Yes.
Do you know whether that's the complete medical record or not?
I believe it is, but I know that's what was provided to me and what I reviewed.
And that's what you reviewed to write your report?
Amongst other things, yes.
Right, and you list many other things that you reviewed, but in terms of the medical records from St. Elizabeth's Hospital, that's what you reviewed, right?
As far as I know, yes. It's possible that at some point, I don't remember the timeline, that additional records may have been requested and provided regarding laboratory values or something, but I don't know if that was with this 996 or not.
You don't know the timeline. When would that be?
Like I was saying, it's possible that some lab reports were provided to me after this. I don't remember in relation to the timing of the deposition.
Okay. But at the time you gave your deposition and the time you wrote your report, this is what you had, right?
Yes.
Are you aware that's actually not the complete medical record?
Again, I have no reason to dispute your understanding of that. So.
That's all I'll have with Exhibit 133, Judge, and I believe you indicated we would then take a break.
Yes, Exhibit 81, you mean?
Exhibit 81, yes, Judge, thank you.
So, members of the jury, at this time, we're going to take an afternoon break. We'll take 20 minutes or so. Whenever you're ready, let the bailiffs know, and we'll get you back in here. The jury is excused. And all right, you may be seated. Any objection to the receipt of 79, 80, or 81?
No objections.
No objection.
If, the deposition transcript was referenced, are we going to have that marked and received as an exhibit?
Judge, at this point, I'm still using the deposition transcript to either refresh his recollection or impeach him. I would not offer it as an exhibit. If it's the court's practice to do that, we can do it.
Defense position on it?
Only impeached with the original transcript.
So do you have the original one somewhere here?
Actually, Mr. Fleiter would have the original.
Okay, and is he somewhere in the courthouse or?
He's nearby. I'm not sure exactly where.
Okay, so eventually we're gonna mark the original position. Can we agree on that?
Yes.
Okay, and we'll give it an exhibit sticker then of 82. And the clerk will follow up, you know, either by the end of the day or sometime tomorrow to get that marked and received. Any objection to that transcript being received as exhibit 82?
Objection.
Okay. I don't know if has anybody noticed anything with the jurors?
Is there one? Is he missing? Is there one?
No, they're not
Oh.
missing. Okay. It seems like one has been sleeping most of your questioning, Mr. Frankowiak, not to call.
Has been what?
Eyes closed. If you guys didn't, then I don't have a problem with it. But I was thinking of ways to, and the people who are coughing, I don't know if they need to step out to get something to drink, but it's getting a little bit interfering with my ability to listen. That's a different issue. So I just ask that you kind of take into understanding where we're at and appreciate that. But go back to the jury issue. So I just encourage you all to pay attention to that. And but it was from 1 to about 1:35 where I think it was like a 20-minute window, and that juror had opened their eyes twice for maybe 5 or 10 seconds each time. Not suggesting they're necessarily sleeping. Maybe they're just listening with their eyes closed, which is maybe normal, or it was abnormal for what I observed for the last 8 days. So you guys, I want to raise the issue because I think that's my role. And then if you want to pay attention to it, let me know if anybody has any issues. Anything else before we take a break? Okay. We'll see everybody at 2:30. We're adjourned. right, you can be. Well, welcome back, members of the jury, and I know you have windows in those rooms, so one nice thing about being here is you can't see that it's 80 degrees and blue sky outside, right? There's nothing to see, but we're just going to try to go for another hour and a half. It might be a little longer than that, depending on where we're at. When we took a break, Attorney Boylan, you were in the middle of your cross-examination, so that's where we'll pick it up.
Thank you, Judge. Dr. Fisk, are you ready for the next question? Does a person blow off carbon dioxide when they're hyperventilating?
When they're hyper or hypo? Hyperventilating, they do. And they're also blowing it off when they're hypoventilating, just not as much.
Thank you. So they're blowing off more carbon dioxide when they're hyperventilating?
Yes.
A pulmonologist would be able to testify about that as well as you?
I think the question of carbon dioxide and hyperventilation is also something I would say is under the purview of general internists, hospitalists as well. So it's a concept and a event within the body that is, I think, crosses specialties and is sort of appreciated and evaluated and monitored by a multitude of physicians.
All right. A hospitalist would know that if a person is hyperventilating, they're blowing off carbon dioxide.
Many of them will.
Should a hospitalist know this?
Yes.
Are you aware that Dr. Shokar is a hospitalist?
Yes.
You still have your report in front of you?
The February report that I filed, you mean?
Yes, doctor, and that's the only report that we have.
Exhibit 303, yes, I have it.
Do you see the fourth full paragraph down starts Ms. Schara? Do you see that?
Which page?
The first page, I'm sorry. The first page.
The one that says Ms. Schara, unfortunately?
Yes,
yes, yes, I see that.
Okay. Judge, may I publish this report up on the screen? It's already been received, correct, as 303? So in that paragraph, Dr. Fisk, there's a sentence where you talk about vaccines and a 90% reduction in risk of death from COVID-19. Do you see that?
I do.
And that's a paragraph that you have some footnote on. Do you see that?
Yes.
All right. And the footnote is to a certain article. Do you see that?
There are 2 footnotes to 2 articles.
Okay. I'm sorry. I would like to bring up the article that is in that first footnote by the website. I can also bring it up. It's in the court record as another docket entry, but I would like to ask him about that article.
As an exhibit?
It has, if his report has been received, it was filed also separately in the docket at docket number 529, I believe.
Okay, so 529 would be part of the court file, but not of the trial record.
Yes, Judge.
So the question is, do we want to mark that later, like we're going to do as deposition testimony,
Yes, Judge.
separate trial exhibit? Okay, so that would be number. Is that good with you, Attorney Frankowiak?
In your report that you have in front of you, Doctor, there is an internet citation in footnote 1. Do you see it? Oh. Do you see the footnote 1 has an internet citation to this article?
Yes.
And you probably can't see the internet bar at the top, but it ends in 8891 is the last information as the internet citation. Are you familiar with this article about the effectiveness of COVID-19 vaccines against the Delta variant?
Yes, I am.
You are.
As to, specific questions regarding the content of the article, I have not recently reviewed the article. So for detailed questions, I would have to take time to re-review it and update it. But the conclusion that I put in the report is based on review of this article in its entirety, not just the abstract. And what we're seeing here is the abstract.
Well, the entire article was submitted to the court as docket 529 by your lawyers. This is what was submitted to the, here it is. Article from the New England Journal of Medicine about the effectiveness of COVID vaccines against the Delta variant. Is this the entire article you're talking about?
You'd have to scroll down. That does look like the PDF of the whole article. Yes, that would be the PDF of the whole article.
Okay. But you cited in your report this website link, this document that I brought up initially, what you can now call the abstract.
A summary statement of the article, which then when it may be different from each.
Time the article talks about death, it says the number of case follow-up periods are currently insufficient for the estimation of vaccine effectiveness against severe disease, including hospitalization and death. Nor does that article say that that vaccine is 90% effective against the Delta variant.
Could I visualize a copy of the article and I can point you to the appropriate place?
Yeah.
I can't, I would have to have a paper copy. I'm sorry, I can't see it. Or I'd have to go over in front of the screen and stand there and review the whole thing.
If you want.
Okay.
Earlier that we'd have had it as an exhibit.
Should have it.
Well, I have it, but if we're gonna have him review it, let's mark it as an exhibit.
Sure.
Okay. If you wanna take a look and make sure it's the same one that you're thinking of,
Jason.
let's give it to the clerk first. So Exhibit 84. It's gonna be Exhibit 84. So I believe 83 is gonna be the two combined, is that right? Attorney Boylan,
I'm sorry, Judge.
83 are the two articles combined?
I was going to get to the second article with him.
Yes, so that's
The link-
83.
The link at least to the second article.
Okay, so this will be 84.
But Judge, given the length of this article, we can have it marked, but at another break, I would prefer that you have the time to read this article unless
You can read
I would like to continue on with my questions at this point in time.
Okay, is that helpful to you? So why don't you give that to Attorney Boylan since it's his questioning, and you can ask your next question, Attorney Boylan.
Judge, I'm going to continue with the questioning and come back to this article after the doctor has had time to read the entire thing. Dr. Fisk, in your report, as you continue on right underneath this area of your report, you continue on to what you call the 7 aspects of Grace's case relating to COVID-19. Do you see that?
I do.
And do you remember at your deposition, you added another, was the epidemiology of what was going on at the time?
Yes.
So you had 8 aspects. Were any of those aspects age?
Were any of those aspects age in terms of the aspects that I'm reviewing were her case being consistent with severe COVID-19, and an individual aspect is not age, because I can't look at someone and say, you're 85, that's related to COVID. Everything I listed here were aspects of her case that were associated with her known diagnosis and supportive of her diagnosis of COVID. So age is a risk factor for COVID, but age is not something variable within Ms. Schara. She had a fixed age, and all these other 7 and then the 8th aspect that I listed, those are things related to her disease and also what was going on in her community with the community prevalence of COVID and how common COVID was in her community as a part of the United States.
But you're on the are you on the first page of your report? Could you look there?
I'm on the, you mentioned the 7 aspects.
Yes.
And that goes on the 1st, 2nd, 3rd, and 4th pages. So I was looking at those.
All right. So on the first page, when you're first talking about the aspects, you say those relate to her decline and demise as a result of COVID.
Yes, I see that.
Okay. So, are you aware Dr. Burdine has testified that age is the number one factor that would be indicative of whether or not somebody would die of COVID?
I am aware of that.
You listed 8 factors and you did not include age at all.
Right. I didn't include it as a factor that contributed to her death because we know she had COVID. What age is a risk factor for acquiring it and also a risk factor for progression of disease. So I didn't list that because she didn't have advanced age, but she has these other risk factors or clinical findings that supported her diagnosis of COVID and the severity and documented the severity of her COVID.
Okay. On page 2 of your report, are you there?
Yes.
The second paragraph, starting with when she was admitted.
Yes.
And you see midway through that paragraph, you that she would have had severe sepsis. Do you see that?
I do.
Did anyone at the hospital ever diagnose her and write in the medical record that she had severe sepsis?
No. Although they did not write it or document it in the record, they treated her as if she had severe sepsis and managed her for that condition.
Thank you, doctor. On page 8, I'm going to ask you about now. And when you're there, I'm ready.
I'm ready.
So there's a long sentence to begin page 8, and then the next sentence starts about in the absence of negative pressure.
Yes.
Could you tell me what that means?
So negative pressure involves the status of a room and the organization of a room. And negative pressure means that there's pressure sucking air into a room and as opposed to a positive pressure, which would push air out of a room. And so negative pressure is one measure that is available in many hospitals for reduction of risk for infections that hang out in the air and infections that are aerosols and spread with the mechanism. So it's something commonly used for treatment of when individuals have COVID disease and they're in hospitals where people have infections, say like tuberculosis. It's something that can be done to protect other patients and visitors if the visitors are in such a room, and also protect staff.
Okay. So having a negative pressure room where disease may spread is helpful.
Yeah, but it was not always the case in COVID that people were in negative pressure rooms, but it is helpful.
There was a lot of hospitals rooms and a lot of hospitals and a lot of patients, and so it wasn't possible to get everybody into negative pressure rooms.
That's right.
And that's why you pointed out in your report.
Yes.
Are you aware what kind of room Grace Schara was in?
I learned last he was in a negative pressure room.
How about the hallway? Have you ever heard of a negative pressure hallway?
So you can have the hallway is not necessarily the same as the room. You can have a room that's negative pressure and a hallway that's positive pressure. You can have both that are negative pressure. Usually you don't confine it to a hallway because a hallway is not a confined space. When you're talking about room pressurization, you may be talking about an entire unit that may have doors around the unit. So.
You learned last night for the first time that she was in a negative pressure room. How did you learn that?
Attorney Frank Koyak mentioned that to me.
Why?
Because of this aspect in my report that I mentioned in terms of infection control issues. I would add that negative pressure rooms are not, they don't provide absolute protection against acquisition of an airborne infection. As you mentioned, they are helpful in reducing the risk, but they're not absolute proof and protection.
Judge, I'm going to move to strike that answer. There was to be no additional expert testimony that wasn't disclosed in a report or in a deposition.
Door was open.
Objections overruled. I think you asked him that question.
Actually, Judge, I'm sorry. I think I didn't. I think he had answered my question and then he said, I would add that and continued.
Oh, so you're asking only to strike the last part of his answer when it was yours?
I would add that, so on and so
Okay,
forth.
and I agree with you on that. So it was not responsive to the question. So that last couple sentences that this witness just said will be struck and cannot be regarded by the jurors. The previous questions and the initial questions, though, I think are proper.
Absolutely. I wanted to ask him that and I wanted to get his answer.
Okay.
Thank you, Judge. I'm going to have another exhibit which had been deposition exhibit 130. It is the Ascension Hospital Response and Recovery Resource Document.
We'll mark that as exhibit 85 and we'll hand that to the witness.
Thank you.
All right, Dr. Fisk, do you recognize the document that's been placed in front of you?
Yes, I do.
Okay. And it was exhibit 130 at your deposition in February. Your name on it. I imagine the one that is now marked has that exhibit sticker over that. But if you'd go to page 2 for me, Dr. Fisk. Tell me when you're there.
Yes.
Paragraph 9 in page 2. But actually, I'm sorry. I'm going to have to go to the first. I don't mean for this to be jump around, but this is Ascension's policy regarding visitors to the emergency department and acute settings. Do you see that?
I see it's a statement about returning visitors to those settings.
Okay. Paragraph 9. Do you see there's a subsection A and then there's a little subsection 1. And then it says visitors are not allowed unless they meet the following exemptions. Number 1, designated support person. Who does it say the designated support person is?
It gives an example. It says a caregiver who tends to the needs or concern of a person with a short or long-term limitations due to illness, injury, or disability.
Grace's family, her advocate?
I mean, her designated support person at this time, my understanding is her legal power of attorney. Her mother was not able to visit due to illness. And so the designated support person at part of the hospitalization was her father, and later in the hospitalization was a sibling.
Okay, so she had a designated support person at all times?
As far as I recall, yes. I actually know there was a brief time period between when the father was asked to leave and then when the sister arrived, I believe, that there was not a designated person present, but I think it was less than a day or something like that, where the sister was not there.
It was brief and less than a day?
If I recall, yes.
the designated support person here, this is the policy written out. Does it say it doesn't apply on Sundays?
No?
I would like to bring up another exhibit, Judge, in 1 minute. Let me make sure I have the right one. It was deposition exhibit 131. It's the of images. Dr. Fisk, do you recognize that document that was exhibit 131 at your deposition?
Um, yes, I recall you showing me parts of this that where you had, I believe, had outlined, put some outlines around the lung tissue on some of these X-ray photo reproductions, which also would state are not the way that we review X-rays, nor was the way I reviewed the imaging in this case, because it's far preferable for interpretation of them to review them on a computer screen, which is the standard way that we do that.
Your computer screen with you today? You didn't?
Nope.
I think Dr. Binstock was here this morning, brought his computer screen to go over his images. Are you aware of that?
No.
And it was the same difficulty we had at your deposition when I wanted to ask you about these things. And you told me you really go through them with me because you don't have your computer screen with you. Could you flip to the 6th page here in that packet? Are you there? You see
I
that?
believe so. The one where there are outlines around the lung.
Right. And
Yeah,
at that day when we were back, I'm sorry.
Go ahead.
Okay. We were both talking at the same time, and that's my apology. So back in California, when I met with you and asked you to go through these images, and you told me it's not how it's done, but you didn't have your computer then, I asked you to take a Sharpie, and I gave you whatever color choice you wanted, and you picked red. So up on the screen, you'll see Dr. Fisk, you'll see it's red, you had picked red. And I asked you to identify where in the lungs, whatever we're talking about was going on. And I mean, that's what you circled, right?
I surrounded the area of the lungs as a whole in the body.
Okay. Can you go to the next page? In fairness, I think that is probably like how the ink bled through, possibly. Do you know? Okay. But, so it's not really a circle because that's not a circle, but you just drew a line around both of the lungs in their entirety.
Yes, because the lungs are you asked me about the diseased portion of the body on Ms. Schara that was impacted by her COVID.
I would have asked you to point to where the infiltrations were. And instead of doing that, you circled the entire lungs. See that on the screen?
I see that the lungs are outlined, but that's, the area of the body with the disease process.
You were talking earlier, Dr. Fisk, about vital signs
Yes,
and the fact that Grace had low oxygen even with supplemental oxygen. Do you remember that?
low oxygen saturations, yes. At times, and that was not always did she have low oxygen saturations during her hospitalization, but she was on supplemental oxygen throughout her stay, and at times, despite that, had low oxygen saturations. So that's a situation that we can infer if the oxygen were removed, the patient would have low oxygen saturation levels in the absence of oxygen if they're needing oxygen supplementation at times to sustain that. So,
Are you familiar with a nebulizer?
yes,
Is a nebulizer something that could help to open the airways to improve breathing?
and some people yes, and some people no. They would have to have situation called reactive airways in order for that to be at opening the airways.
Okay, and if it did, opening the airways could improve the breathing and help with the oxygen. Is that the case?
In some cases, yes.
In some cases, yes. Are you aware why the hospital decided not to allow Grace to have a nebulizer?
Yes,
Why?
because at this time, nebulizers in hospital settings were it was recommended against use of nebulizers because the nebulizers can more COVID virus from a patient who has hundreds of millions of copies of the virus in their lungs, and it can spread more into the air and increase the risk of transmission of COVID within the hospital. So the hospital was following what was a widespread practice and standard at that time during COVID against use of nebulizers.
So possibly the reasons why she had issues with oxygenation was the hospital wouldn't allow a nebulizer.
I would not confirm that. I think that is an assumption because we don't have evidence that she had a significant pre-existing asthma condition or reactive airways disease that would have made her benefit more from these that I recall. But even so, the of meter dose inhalers was really the standard of care at most hospitals in the United States at that time.
Are you aware that Grace wore a CPAP? Okay. She was in a negative pressure room.
Yes,
Same rule for the no nebulizer in a negative pressure room?
at many facilities, yes.
Well, not at all, was it? You said at many facilities. That wasn't the rule at every facility, was it?
Correct. It was not the rule at every facility. Not every facility limited the use and banned the use of nebulizers during time periods during the pandemic to begin with. So, but again, it was the norm.
You also testified about some confusion by Grace. Do you remember that?
Yes.
Tell me about her Down syndrome with relation to the confusion. If she had been left alone in the hospital for, you called it a brief period of time, I'm going to tell you, I disagree with you. But if Grace was left in the,
Sustained. Go ahead, Attorney Boylan.
you say that one of the signs of Grace's disease of COVID was confusion?
You were asking a question?
Yes. Is that the case? Did you talk about confusion earlier being an indicator of COVID?
So yes, I saw in her records that at various places it was referenced that there was some confusion, lack of alertness, inability to interact with others at what would have been her normal baseline.
She was a Down syndrome patient who was left alone in the hospital for the first time in her life. Do you think that impacted her level of confusion?
I think that someone with pre-existing cognitive issues is known to have increased risk of confusion during hospitalizations. So I think her Down syndrome played a role in that at baseline. I can't say what additional, and I wouldn't assume that absence of a family member added to that. I can't assume that.
I'm not asking you to assume that. I'm asking you whether that's a possible cause of her confusion.
It's one of many. I think it's not a probable cause of her confusion, but I agree it is possibly added to it, but was a minor factor in comparison to the other factors that we have discussed today already.
Is that because you believe she was left alone for a brief period of time?
Even if she had not had a support person during her entire hospitalization, I think the other aspects of her case that increased her likelihood of getting confused were far more significant factors in driving that confusion. Fever, oxygen starvation, and acute illness requiring ICU care, etc.
You just mentioned oxygen starvation, and we talked about the nebulizer. She didn't get to get one. She was left without her advocate, and now you mentioned fever. Are you aware what the Precedex I'm going to strike that question. Fever. Is it part of a possible reaction to an overdose for your fever to
That in their own respective house.
Or if someone has evidence that because of prolonged oversedation, the lungs start to deflate and the patient gets what's called atelectasis, where the lungs are starting to kind of collapse on themselves. That can drive a fever. But from pure sedation, fever is not generally what we associate with that.
So something could happen as a result of the overdose that then leads to fever, right?
Overruled, go ahead.
In general, if that case, or are you asking if fever in Ms. Schara's case was related to oversedation?
Well, I think you were talking in general about fever and COVID patients. I'm asking you about fever and someone who's had an overdose in general.
Yeah, fever is not a common feature of overdoses. It's possible if a complication of an overdose arises, such as somebody vomits and then they aspirate. But it is not on our list of things that we generally associate with fever.
Okay. You were talking about some vital signs, and one of the dates you went through was October 10th. Was there a significant event that happened in Grace's life on October 10th that may have been the call for her vital signs to act up?
Well, the significant event that I identify as causing, and when you say vital signs act up, again, we want to be very specific because there are multiple different vital signs that are tracked. But if we look in general, and we'd have to pull up her numbers from the 10th and review them, I think her fever values and other abnormalities and vital signs that we saw throughout her hospitalization, at times fast heart rate, at times elevated respiratory rate, and at times low blood pressure or hypotension, those the driving cause for those throughout the duration of hospitalization was her COVID infection.
Could the items that you just mentioned in her vitals be related to a significant event that happened in her life on October 10th?
I think the significant event happening in her life on October 10th was progression of COVID disease.
Is there only one significant event that could happen in her life on October 10th? You can't identify for me another?
So I'm not sure what event you're fishing for, but to me, the most significant event was her COVID.
I'm not fishing for any event. I'm asking you, what other significant event happened in Grace's life on October 10th?
So you're alluding to is, she received other medications that day.
It's not, but I'm asking you, what other significant event happened in Grace's life on October 10th?
In terms of her medical issues?
In terms of her time at St. Elizabeth's Hospital in Appleton, Wisconsin.
Yeah.
Overruled. Go ahead and answer.
Let's see. On that day, I'll review my report here.
Judge, I can move on. I'm happy to withdraw the question, but if anybody else wants it answered, I can wait.
You can move on if you want. It's your witness.
Yeah, that's the day that her father was asked to leave the hospital, but I don't have that date off the top of my head.
You talked about some coarse respirations earlier in your testimony.
Yes, that was documented on her physical exam. Coarse breath sounds, not coarse respirations, but coarse breath sounds on October 8th.
For helping me understand that. And what I was going to ask you in follow-up was, somebody who would be an expert in that area within his wheelhouse would be a pulmonologist?
Well, it doesn't take just to understand coarse breath sounds. That's something I evaluate every day in my evaluation of patients. I listen to their lungs and their breath sounds.
Okay,
And
but I'm not asking. Go ahead.
Okay, physicians in general, that's part of their evaluation, and part of a wide range of physician training is to evaluate the character and quality and number and rate of breath sounds when you're listening to the lungs.
It's something a pulmonologist, it's within the scope of his expertise?
Yes.
Okay. Certainly not a lawyer's, but a pulmonologist's. Agitation, you also mentioned. Were there events and things going on with Grace that also may have caused her agitation other than what you described?
I have identified the main factors for her agitation that I saw in my report. And I know we've, also today been talking about her father's being asked to leave the hospital as well. But I think the multiple triggers that I identify on page 6 of my report are to me, after reviewing the case, the far and away most important factors driving her agitation.
Is fever a potential side effect according to the Precedex package insert of the use of Precedex?
Again, I haven't reviewed in detail the latest Precedex package insert, but see fever reactions to almost any drug that's administered short of the steroids that we talked about earlier. You can get fever from taking an antibiotic. You can get fever from taking cardiac medicine. So it's a generally accepted risk associated with multiple medications.
You also mentioned a high D dimer in relation to COVID.
Yes.
Okay. Do you know what the Precedex package insert says about that?
No.
What about sepsis? Could you have a high D dimer as a result of sepsis?
You can, and Grace had sepsis during her stay for at least part of her time, and so that could contribute to the values of this, but never in patients who were septic For other causes in my career, would I see a D-dimer anywhere near approaching the higher value that Grace had on October 13th?
Once a patient is over or past the acute respiratory phase of COVID, what would be the impact on the white blood count?
So there's no one answer to that. With COVID, some people's white count goes down below normal, and some people's white count goes up above normal. Also, white count can be influenced by dexamethasone. That can increase white counts as well. Generally, that's in the first couple days that the medicine is administered, and that effect is not seen several days down the road.
Is Grace over or past the acute respiratory phase of COVID?
In my opinion, never. She, as her death certificate stated, it was signed out as acute hypoxemic respiratory failure. So in my opinion, she never passed the quote acute phase, although her illness lasted longer than many. And she had entered also later in her course into what we would call sort of the proliferative or fibroproliferative phase, where you're likely more get sort of solidification of the lungs, and the lungs become stiff and not able to expand and do their function. So I think she entered that phase, but she never left until she died, unfortunately, the acute aspects of her case.
Did Dr. Shokar ever determine that Grace was over the acute respiratory phase of COVID?
Yes, Dr. Shokar, in his notes, had talked about Grace entering a more chronic phase of COVID.
So did you disagree with that?
I do.
Okay. And I'm interested in the fact that you mentioned that issue with respect to the death certificate. Because, do you know who signed the death certificate?
Not off the top of my head, no. First diagnosis on it was acute hypoxemic respiratory failure.
Oh, do you know who signed the death certificate?
As I said, no.
Would it surprise you if I told you it's Dr. Shokar?
That wouldn't surprise me.
What is a forensic pathologist?
So a forensic pathologist is a physician or a doctor that performs postmortem analysis on patients and has completed residency and training in the field of pathology.
You're not a forensic pathologist, are you?
Nope.
Could you give me a definition again of hypoxic?
Of hypoxic?
Yes, please.
Sure. So there is the blood carries oxygen, the red blood cells carry oxygen, and there are normal levels of oxygen within the bloodstream be tracked. And for most individuals, that's a value for hypoxemia of greater than 93%, or greater than or equal to 93% is the norm. So values less than that can be what we call hypoxemia. There are also there's also a version of hypoxia what we call alveolar hypoxia. So low oxygen levels within the lung that absorb the oxygen, although that's not the measurement of it in the bloodstream. So.
Do you know what the Precedex package insert is about hypoxia being a potential side effect of a use of Precedex?
Specifically what that package insert states, but I am familiar with an effect of the drug in my patients.
So hypoxia is a potential effect of the use of Precedex.
Yes.
Why was morphine given to Grace on October 13th?
The reasoning that I saw described was to try to decrease her respiratory rate. And therefore, in hopes, potentially improve her ability to get oxygen into the body.
If someone is hyperventilating in order to compensate for a lack of oxygen, what would happen when you slow that person's breathing?
Go ahead.
Can you repeat the question, please?
It's the court reporter to read it back.
If someone is hyperventilating in order to compensate for a lack of oxygen, what would happen if you slow down breathing?
So the answer to that is it depends why they have a lack of oxygen. Some people who, and again, hyperventilating to me means a higher than normal respiratory rate. Some people who are hyperventilating because of a lack of oxygen would improve their oxygen delivery to their body if the respiratory rate slowed down, whereas other people would see a decline in that oxygen carrying capacity and oxygen delivery to the blood and to the tissues when their respiratory rate slowed down. So you can see both scenarios when a medication is given that decreases the respiratory rate. At times, when patients are hypoxic and hyperventilating, what they're doing is their breaths are very shallow, and so their respiratory rate is high, but they're only getting air into and out of the upper portion of their respiratory tract. So they're not actually getting the oxygen all the way down into their lungs. So in some cases, if you slow down the respiratory rate for someone who's hyperventilating, that air can make it all the way down into the lungs and you can improve oxygen delivery to the lungs.
Earlier about ventilators and resuscitation, this is broadly. And you talked about the chances, Grace's chances without a ventilator. In fact, I think this appears near the very end of your report that you have in front of you. Do you remember that in general? Okay. How soon can a ventilator be placed in an emergency?
Can be placed at times in less than a minute, at times at least an endotracheal tube, maybe not a ventilator, but an endotracheal tube that is then connected to a bag, and the bag is used to squeeze the bag and deliver oxygen and air into and out of the lungs. So an endotracheal tube, less than a minute. Oftentimes it takes longer than that to get a ventilator set up and connected to the endotracheal tube.
Are you aware from your review of the medical of any provider at St. Elizabeth's Hospital who ever went to the family and told them that if you don't agree right now to a ventilator, now Grace will die?
I don't recall anyone saying that here now. I recall, I believe, Dr. Baum documenting that essentially if he felt her course was would ultimately lead you or not placed on the ventilator. But to your specific question about here and now, anybody going to the family and saying that unless it's placed in this second, she will die? No, I don't recall that.
You spoke about DNR orders in general. And you spoke about, and correct me if I'm wrong, that a DNR order requires a doctor's order.
Yes,
It also requires the patient's or the advocate's or the POA's consent, right?
yes.
Should the DNR order be signed and in writing?
Yes.
And who signs it?
It's signed by the physician. It is then co-signed by, in most cases, the patient or representative, and at times a witness. There are times, however, DNR orders are placed on patients. This is very rare, but there are times where it's placed by an order of two doctors concurring to the order because the patient cannot provide consent and there's no person identified who can act on their behalf as an agent. So there are times after two doctors confer that DNR orders can be placed in that situation, but that's very unusual.
I want to ask you about standard of care in the hospital. And you can tell me this is outside or within your scope, okay?
Okay.
Is it a breach of the standard of care to fail to discuss an adverse event with a patient or their advocate power of attorney?
I think it depends upon the magnitude and intensity and significance of the adverse. For example, somebody in a hospital, gets an IV placed, and the IV attempt fails, and a patient gets a bruise or a small blood clot on this near the skin surface next to that IV. That's an adverse event, but that type of adverse event is generally not going to be discussed with necessarily a representative because it is so rarely linked to clinically important subsequent events downstream. On the other hand, of course, adverse events that are of clinical significance and have impact to the patient, or at times adverse events that take the life of a patient, of course, we have a strong duty to review those and go over the patient or their representative.
And to fail to discuss a clinically important adverse event that may have downstream impact, would that be a breach of the standard of care?
If you're talking in general, not specific to any field or specialty, just based on the magnitude of an adverse event, if it had significant clinical consequences, yes, that should be discussed, patient or their representative.
Okay, let me give you a specific event. Placement of a PICC line. Would it be a breach of the standard of care to fail to discuss the placement of a PICC line with the patient?
Objection vague. Ruled, go ahead.
When you say discuss the placement, do you mean, can you clarify that and specify further, please?
To obtain, I'm sorry, to discuss, I understand why you're asking me to clarify. I'm sorry, to discuss, I understand why you're asking me to clarify. To First, obtain informed consent for it.
Yes, it is generally standard to obtain consent for placement of a PICC line because it involves a procedure as a placement of a central line.
Okay, if it had to be done in an emergency and the informed consent discussion didn't take place, I'm not saying that happened, but let's imagine that a PICC line was placed and nobody was told. Would it be a breach of the standard of care to fail to discuss that afterwards?
Objection beyond this witness's testimony in terms of being expert as a infectious disease expert.
I would also add it violates the motion.
Overruled on both. I think he's offered enough opinions that he's capable of answering this. Go ahead.
Repeat the question, please.
Can you just read it back to him, please?
If it had been done in an emergency and the informed consent discussion didn't take place, I'm not what happened, so let's imagine if line was placed and nobody was told, would it be infectious breach of the standard of care to fail to discuss that?
It wouldn't be a breach of the infectious standard of care, but if it were not discussed after emergent placement of a PICC line within a reasonable time frame, I would consider that a breach.
One second, I need to confer with my co-counsel. At this point in time, Judge, I'm going to ask for another document to be brought up once we disclose what it is, but it will be through Mr. Mendenhall's computer and not mine. So I'll unplug this. Because it's a fancier way than I do.
Has that document been marked as an exhibit?
I don't believe so yet. It's a cross exhibit, but we do have.
It's H. Okay. 0068. Let me get us linked up.
Who's it? It does not have an exhibit sticker on it yet, Judge. It's a document from the medical record that hasn't yet been brought in.
It has. The medical record is under this exhibit one. We've agreed to add stickers. So I will add a sticker to this.
So the next exhibit is 87, is that correct? Yes. So 87 is going to be which portion of the medical record?
It's page, it's from the certified record. It's page, I believe it's page 68 and 69.
So in exhibit 1, 68 and 69 are going to be marked as exhibit 87.
Yes.
Okay. Any objection to that, Attorney Frankowiak?
No, Your Honor.
Attorney Guzzi?
No, Your Honor.
All right.
Okay. All right. And when everyone's ready and with the court's permission, we would bring this up on the screen. It's again, Mr. Mendenhall's gadget over here.
Okay, so do you have the computer hooked up?
Doctor, do you remember testifying earlier about some of these COVID drugs, remdesivir and convalescent plasma
I
therapies?
remember, yes, yeah, convalescent plasma is not a drug, so I do remember testifying about those treatments.
Okay, I've got a daughter that works at the Vanderbilt University. let me tell you, it's tough for me to get to a conversation with her about something complicated. So I'll misstate these things, but it's a therapy. It's not a drug.
Correct.
This is from the medical record. Do you see that Grace was not a candidate for the use of remdesivir or convalescent plasma?
Yes, you say this is from the medical record. What, I can't quite see all the details, but, and the date, but I remember seeing in the medical record that that was stated in at least one note, but other notes after that went on to state it was not only she was a candidate, but it was also advised,
Who advised what?
treated with it.
I'm not understanding this. She was not a candidate, but was advised what?
Later on during her stay, I saw multiple notes referencing remdesivir usage in her case. And at one point I saw it stated she's not a candidate, but then I saw later at a subsequent time notes saying it was recommended and it should be used to treat her.
Oh, if at one point, this is October 8th, this note is from October 8th. Do you see that?
I'll take your word for it. I can't do that far.
October 8th.
Oh, it's down at the bottom. See it there.
Yes, now I see it. Thank you.
All right. So if at one point on October 8th, the father was told that Grace wasn't a candidate for remdesivir or convalescent plasma for whatever reason he was told that. Later on, if somebody asked to put Grace on remdesivir or convalescent plasma, he could have had in his head, I was already told she's not a candidate for this. No, is that possible?
Yes, that's possible that he could have had that in his head.
Would that be an informed issue?
Specifically, informed consent in this case is really for remdesivir is included with the general consent for hospital services. So additional prescription of remdesivir is not that requires signature of an additional informed consent document. Convalescent plasma, though, is a little different. Convalescent plasma did require a fully signed informed consent document because it was considered in a more experimental phase. Although even though it was considered more experimental, it was widely used and remains that it's used today. So the answer to your question is it depends upon which aspect of these therapies that we're discussing. So remdesivir, it's already covered. Additional convalescent plasma would require additional level of consent. And I'm seeing that later on, convalescent plasma was also recommended for Ms. Schara. And there was a statement saying that although consent discussions were had, the consent document was never signed by Mr. Schara.
So you told me, though, it's possible that once he was told convalescent plasma, that she wasn't a candidate for it, if he later didn't understand why she became a candidate for it after being told that she wasn't a candidate for it, that could be a failure to communicate with the father and a breach of the standard of care, couldn't it?
No, I saw later documentation that convalescent plasma was discussed again at a later date with the father at the time it was recommended. So I don't believe there was any breach there.
One moment, Judge Lawrence. you pointed out some portions of the medical record earlier where Grace had a high fever. Do you remember that?
Yes. Temperature, yes.
High temperature. Thank you. I knew I would get dinged again on the wrong word, but she had a high temperature. And the one you pointed out was the 104 degrees on October 8th. Do you remember that?
Yes.
Do you know their fever?
Sorry, no, 104.2 on October 7th, I believe.
Okay.
That's what I had.
Her fever resolved though?
No, her fever didn't resolve. Her fevers were up and down throughout her hospitalization, and there was, as described in my report, multiple days with fever, including the day of her death, October 13th. So to me, resolved means no temperature elevation over 100 degrees for a 48-hour window, and she did not achieve fever resolution.
Just now, we're October 7th and October 13th. You're aware that Dr. Burdine's opinion are that there were overdoses on those days.
Yes, I'm aware of that opinion.
You mentioned the very high D-dimer on the early morning of October the 13th. Do you remember that? What would you expect the treating doctor to do as a result of the very high D-dimer?
So there's no specific treatment just for a D-dimer. You have to resolve the underlying condition that is the driver of the D-dimer elevation. And in her case, that only the 13th, but the previous day when the D-dimer was quite elevated, I believe the 10th. And it was also elevated even before she came to the hospital, if I recall, when she went to urgent care. And the cause of those in her case was her COVID.
Okay. Did he order any tests as a result of the high D-dimer?
Not that I'm aware of, but I don't know what test I would order. I don't know of any tests that you would do at that point when you have an adequate explanation for what's driving it, and you know what therapeutic options are available to you and what ones are not.
You said he had an adequate explanation for what's driving it?
Yes.
Didn't about 5 minutes ago you tell me you disagreed with Dr. Shokar's conclusion about whether and where Grace was in the COVID?
Well, I think the adequate explanation, as I saw, was COVID and nothing else. And that explanation was throughout her medical record, throughout her stay, referenced in every day and by every physician that I reviewed records on.
My question to you was, didn't you just tell me that you disagreed with Dr. Shokar's opinion on where she was in COVID?
Yes, in terms of the quote chronic phase, but there also can be high D-dimers in the chronic phase. So I don't disagree at all with anything anybody said about the D-dimer at any point during her hospital stay.
You gave a conclusion at the end of your report and also at the end of your testimony here today that had COVID and she died of COVID. Classic case of COVID. Do you see that on page 8 of your report?
Yeah, I'm aware of that conclusion, but not only a classic case of COVID, classic case of severe COVID causing respiratory failure, hypoxemic respiratory failure.
And you believe that you can tell us as an expert when she was going to die?
No, but I can't tell you when she was going to die, but I can tell you at what point was her death more likely than not and more probable than not.
I'm going to bring up your report. Oh, okay. This will be my last document that I ask some questions about briefly, Judge, so I need to plug this back in and we won't keep playing the musical chair. I've put up the conclusion of your report up on the screen. And I'm looking at in that full paragraph there, starting with Miss Shara's. Do you see that?
Yeah, Ms. Shara's illness. Yes.
Okay, and then your third sentence in there starts, if Miss Shara.
Yes.
Ms. Schara had not been admitted to St. Elizabeth's on 10/7 and returned home with oxygen therapy, comma, she would have died from her COVID-19 days before 10/13/2021. Does that remind you that you give an opinion on when she would have died?
Asked me the day. So you asked me a specific question about the day. And no, I could not say the day when she was going to die, but I can testify that I think her death was later than it would have been because she was admitted to St. Elizabeth's and cared for at St. Elizabeth's.
Next sentence, similar, father had taken her home from the hospital after admission to St. Elizabeth's. She would have died sooner than she did. Are you not again telling us when she would have died? Two sentences in a row.
I'm telling you a time window when she would have died. I'm not telling you a specific day. And I do believe that the window that she would have died would have been some point earlier than October 13th if she had been taken home from the hospital by her father.
Would you be surprised to learn, or maybe you've read Dr. Shokar's deposition?
Shokar. Yes.
Are you aware Dr. Shokar testified about when Grace may have died or would die? And his testimony is that he doesn't have a crystal ball. He doesn't know when someone's going to die.
Yes.
Do you have a crystal ball?
That's why I give a time window. But based on my experience and care with large numbers of critically ill COVID patients and what care led to what outcomes, I can comfortably give a window that her death would have been sooner than October 13th if she had gone home from the hospital.
You can speculate, right?
No, I can say that confidently based on my experience and training.
That's all I have, Judge.
Counsel, you want to approach for a few minutes, please?
Looks like they cut the audio. They don't want anybody to hear what they're talking about right now. This guy is so full of crap. I have a feeling the judge
members
is
of the
not
jury, I was just
appreciative of this.
discussing with
Saying he knows when someone is going to
attorneys
die.
sort of the
I think that is
framework,
absolutely
and
ridiculous.
apparently the
to
witness
even think that that's
has
right.
an airplane or a return home, and so we're going to finish him
Let's see what the
today.
judges say.
We've been going an hour and 20 minutes, so we're going to give you just a quick 10-minute break, kind of reload, and then we're going to come back in, and it's going to be about 30 or 40 minutes from what they just told me. Everybody good if we just meet in 10 minutes? Okay. We're adjourned.
This seems kind of odd to me. A 10-minute recess, 10 minutes before the scheduled end of court for the day. that's not normal, in my opinion. I guess we'll see what happens, but uh, I can't believe this guy had the balls to say that that she survived longer because she was in the hospital, even though they caused her to OD 3 times. I think that is insane just to think that that is even remotely accurate or true.
we finished the cross-examination of the witness, so now it's going to be back to Attorney Frankowiak for a redirect. And just a thought, I want to make sure everybody's awake and paying attention. That's why I gave the break. I saw different eye rolls going different ways, so hold it against me if you're upset that I'd like to give you more notice than that if we're after the time I told you. But as the afternoon was building on, there's a lot of things I'm trying to balance. So hopefully this works out well, and then always just keep in touch with the bailiff if there's something we can do to make the schedule better or easier for any of you. But don't blame it on the parties or the witness on my decisions. Okay, Attorney Frankowiak.
Okay. Doctor, thank you. I just have a number of things I want to follow up to clarify if we could. Okay. All right. Doctor, in October of 2021, we had talked about, we're in the depths of the COVID pandemic. Yes. And there were obviously, visitation to the hospital was basically restricted.
Yes, it was in most cases prohibited.
So there were instances, in fact, most instances where no family members, POAs, things like that were present.
That's correct.
In a hospital, right? And records are done in the EMR, basically, right? Electronic medical record.
Meaning the record keeping associated with a patient encounter in the hospital? Yes, those are all, those are electronic, I think, in pretty much every hospital now in the US.
Ability, for example, for people to, come in and sign documents and things like that if they were remote from the hospital. True.
Remote. Yeah, if the people were remote, yes, it would have, they would have had to either, generally they come in, if they're signing some document in the hospital, it's generally in person.
We can agree that.
When a DNR order was entered in October 2018, it was generally placed in the EMR.
2018?
I'm sorry, 2021. It was done by placing it in the EMR.
Yes, generally.
Okay.
Yes.
And that was sufficient to satisfy the standard of care, the placement of a record or a DNR order in the EMR. True?
Objection. Mischaracterizes his testimony. Testified to the opposite on cross-exam.
It's clarification questioning.
I agree. So the is overruled. Go ahead and answer.
Let me repeat it. The placement of a DNR order in the EMR was sufficient to comply with the standard of care in October of 2021. True?
Yes, absolutely.
Okay. It did not require, for instance, any particular written document or signature in order to comply with the standard of care. Entry in the EMR was sufficient. True?
If the entry was there and it was documented by the physician that a consent discussion was had and recorded, yes.
And in this particular case, you saw in the records, for example, of Dr. Shokar, that he did indeed have a consent discussion in this particular instance with Mr. Schara.
For a DNR order, you mean?
Yes.
That consent discussion? Yes.
Okay, and that was sufficient to comply with the standard of care for Dr. Shokar. True?
Yes.
Okay, thank you, sir. Doctor, you were asked a number of questions just in general without any anchoring to this case and from, in terms of the standard of care. You recall being asked a bunch of questions about whether something was standard of care. You recall those questions?
Yes.
Okay. Well, you're not here to testify in general. You're here to testify about the facts of the case that you reviewed. True? Okay. So you're here to give us opinions based upon your expertise and the facts that apply to Grace Schara. True?
Yes.
Okay. Doctor, did you identify any instant medical record on the part of any nurse that you believe to have fallen below the standard of care in any respect with regard to the care of Grace Schara?
No.
Doctor, did you identify any instance on the part of any hospital and of the hospital itself that you believed to be, let me start that question again. Did you identify any instance in the record on the part of the hospital, St. Elizabeth Hospital, that you believe to fall below the standard of care with respect specifically to the care of Grace Schara under the circumstances in this case?
No.
Okay. Doctor, I'm going to ask you a question. Did you identify any instance when you reviewed the records on the part of any doctor where you believed any doctor fell below the standard of care with respect to the care that was rendered to Grace Schara in this case that you've reviewed?
Absolutely not.
Okay. I want to mark a couple of documents if we could. I'm going to take them from their medical records taken from exhibit number 1, but we'll mark them as separate exhibits. The first one will consist of pages 18 and 19 of the record. I'd like to mark that as a separate exhibit and publish that if I could.
And what exhibit number will that be? One document,
Yeah, 2 pages, 1 document.
so 445.
Okay, I would like to go to page 19 if we could, which was page 2 of that document. Okay, under the recommendation section. Okay. Doctor, you were asked some questions about remdesivir and whether it was available or offered or agreed. Do you recall those questions?
Yes.
Okay. Doctor, with regard to under the recommendation, now this is a note, Doctor, can we go up to the top to show what this note was? This is a note from date of service 10/7/21, okay? So why don't we go back down, Matt, to where we were, recommendations. And you had mentioned that you've seen some documentation. Under 3 there, it reads as follows. We discussed several different treatment modalities that we have for COVID with regards to remdesivir. She does not really qualify for this, but he informed me that he did not want this to be on this drug anyway, so the drug will not be utilized. Did I read that correctly?
Again, I can't see that, but that does sound familiar with what I recall from reading the record.
Okay. Now, you had mentioned earlier, you recalled seeing a record in which Mr. Schara had indicated, or someone had indicated that Mr. Schara did not want that drug. Is this that record?
That would be that record, yes, that he did not want that drug for Ms. Schara.
Okay, okay. So that was a record that you remembered, and in fact, it is in the record.
Yes.
Okay. To mark another record if we could, and this one will also be from exhibit number 1. This would include pages 54 and 55.
446.
Okay, when we look in, and what's the date on this one? Let's make sure we get the date here. Okay, this one's October 11th. Why don't we go down? Okay, Doctor, when we see here on number 4 here, it reads as follows. She is outside the window for the clinical utility for remdesivir, convalescent plasma, or the Regeneron, the monoclonal antibody, and these will not be used. Did I read that correctly?
Yes,
Okay. Now, first of all, so I understand, the word Regeneron, we haven't mentioned that. Is that another type of COVID treatment?
yes.
Okay. And now I want to just explore this concept a little bit. Outside the window for the clinical utility, what does that mean?
Yes. So what they're talking about is the time frame when a treatment would be expected to be most beneficial. And the time frame initially, as approved for remdesivir, was within the first 5 days of it. However, what over time evolved became there was more evidence for using it later on after in the course of illness, particularly for severe illness, after the first 5 days, because it was shown later on that the drug could still reduce the number of viral particles in assays that were detecting those viral particles in the body. So although the initial emergency use authorization of remdesivir recommended an initial sort of a 5-day cutoff, that evolved over the course of October of 2021. We were using this widely, and I'd say it was used in many cases for people who are into even their second week of hospitalization and after their second week of symptoms even.
Okay. And as we saw from the previous note there, it looks like Mr. Schara had made it very clear at the very beginning of the hospitalization that he didn't want that medication anyway.
That's correct.
Okay. And that's what you remember seeing when you testified to that effect?
Yes.
Okay. Now, it also mentions there that convalescent plasma and Regeneron and monoclonal antibodies were outside the window for clinical utility at that time. And we can agree that that was the case.
We can agree that that was the case for Regeneron. Convalescent plasma use, as I mentioned, has evolved over the course of the pandemic. But at this time, convalescent plasma was something that was used even beyond 5 days.
Yeah, you can take it down. Doctor, you don't hold an opinion in this case that the use of convalescent plasma would have changed anything with regard to Grace's outcome in this case, even had there been an agreement to use it?
I have an opinion that I think of the treatment options that were available at this time window, that convalescent plasma would have likely offered the least potential benefit of the other options that we discussed, but I certainly can't rule out that it would have offered no benefit as well. And so I think, as I saw in the record, that convalescent plasma ultimately was discussed and advised as a treatment option in the record, that I supported that opinion that the physician expressed.
And dexamethasone and remdesivir were generally the gold standard for the care of, or strike that, dexamethasone was the gold standard for care of COVID.
Well, really, it was a combination of medicines that was the gold standard. I think the gold standard was, it also depends, if we're talking in Grace's case specifically, I think the gold standard was dexamethasone, at least discussed and offered and considered, and remdesivir, I think, as well.
Thank you. And you recall that there was a note that tocilizumab was offered but was not agreed to by Mr. Schara.
Correct.
Okay. you were asked some questions about some calls. You were showing some documents that showed that you made some calls to me. Do you remember seeing those?
Yes.
Okay. And do you recall having some discussions with me, explaining to me medicine, just like you've been doing today?
Yes.
Okay. And I'm not a doctor, obviously. I don't have after my name, and you are, correct? Okay. And I thank you for explaining the medicine to me, doctor. And that's what you were doing on those phone calls, weren't you?
Yes, I think we were discussing the medicine behind the case and my review of the case, and also in terms of the structure of the report and what format be appropriate for report, but there was not discussion of what content should go in or should not go in the report.
Okay. You were also asked, I guess, or you were asked some questions about the difference between an infectious disease doctor and a pulmonologist. And I think the question that was posed to you is, we can agree that Dr. Burdine is a lung doctor, a specialist in the lungs. Do you recall being asked that?
Yes, I do.
Have you developed any opinion as to how a lung doctor could have failed to diagnose COVID-19 as the cause of Grace Schara's death under the clinical circumstances that you reviewed?
Meaning how failed to diagnose it or that it was the driving force in her illness?
Exactly. Do you have any understanding as to how a supposed lung specialist could fail to conclude that COVID was the cause of death under the clinical circumstances you reviewed?
No.
You were also asked some questions, or mentioned to you about the number of pages of medical records that you reviewed. Remember hearing those questions?
Yes.
Okay. You were provided a number of medical records, and were you able to arrive at your opinions based upon those records?
Yes, that's how I formed my opinions, was based on the review of the records that I received.
Did there appear to be anything missing that you would like to have seen that would have affected your opinions based upon your review of medical records in this case, or your treatment of other patients and your knowledge of?
No, I feel that I had a complete picture of what was going on in this case.
And I didn't see any records that were presented to you on cross-examination in terms of records that were not provided to you, true? Okay. Do you have any concerns at all about the opinions that you've arrived at this case based upon the records you've reviewed?
No, as I said, I think I have full confidence in the review and the data available to me to form these opinions. And it was quite an extensive data set, and there's overwhelming evidence in my mind for the conclusions that I've offered today.
So there was also an article from the New England Journal of Medicine that I presented to you at one point, but I don't think anyone followed up on it. I'd like to do that if I could. Would I have a copy of that? You had indicated you'd like to see the article?
Yes, please.
Okay.
And that is exhibit, is it 84?
84.
Okay.
There's a section that's highlighted that was highlighted when it was filed in the court on page 589. Certainly reference that. Let me know once you have a chance to look at that doc.
Let me know when you're ready to answer a question or two on that document.
And just for the sake of us with the jury, are you directing them to page 589? Is that what you said?
I did. There was a section that was highlighted there on 589. Okay.
Yes, I see the highlighted section there.
And as I understand it from your report, there's a footnote in your report that indicates the purpose of that article. And I think what was footnoted in your report was you had made a statement in the report that COVID-19 vaccines offered a roughly 90% reduction in risk of death from COVID-19. There was footnote 1 and 2. It looks like that was footnote 1. Anything indeed in that document that would support the statement in your report that COVID-19 vaccines offered a roughly 90% reduction in risk of death from COVID-19?
Yes, there is.
Okay, can you tell the jury what that is?
Sure. So first of all, this article reviewed a vaccine that was available to us in the United States, and it also reviewed a vaccine that was available in England, but not in the United States. The one in this article reviewed that was available to us in the United States is known, and they say in the terminology here in the text, is the BNT162b2 vaccine. And it says that after the second dose with the Delta variant, the effectiveness was 88%.
Okay, and that's what you put in your report. It's close to 90%.
In addition to the second article that I referenced from Science magazine as well.
Thank you. And you put footnotes in your report. Why did you put footnotes in your report?
To substantiate the figures and conclusions and evidence that I'm offering in the report. And I, did this to the best of my ability, using what I thought was the highest quality evidence we have from the most reputable journals and highest quality studies that are available in the COVID literature.
And to your knowledge, this study is still essentially accurate.
Yes, this is one of the gold standard studies for the BNT 162b2 vaccine. It is important to note that effectiveness of COVID vaccines, though, has changed over time, and their benefit to us over time for most people is not as great as it was during the Delta variant phase in October of 2021.
Okay. We're talking about this case in 2021. Obviously, that's what you're referencing in your report.
Yes.
Okay. You were asked some questions about negative pressure rooms, and I believe one question you were asked was about the effectiveness of negative pressure rooms in preventing the spread. Doctor, just so I understand, so we have a statement, negative pressure rooms are not absolutely effective or proof against the spread of COVID, true?
True.
Okay. They can be a helpful tool, but they're no guarantee. Okay. And they also don't help an individual who is inside that room who is still subjected to an aerosol.
Meaning an individual who's in the room, not a person who's infected, but a person who is susceptible or at risk to COVID? Do you mean?
Correct.
Yeah, a person who is in a negative pressure room with a COVID patient would have a somewhat reduced chance of acquiring COVID by being in a negative pressure room compared to in a regular room. However, what trumps that is the duration of time that that person spends in the room with a COVID infected individual. So COVID transmissions in negative pressure rooms to susceptible individuals who spent time in these negative pressure rooms is well documented, and also documented to correlate with the amount and time exposure that they spend in the room.
Okay. You were asked about a reference to your report, and I just want to clarify this specifically so we're not missing anything. The word sepsis was brought up to you. Do you remember?
Yes.
Okay. And you used the word sepsis in your report, didn't you?
Yes.
Okay. And you were asked whether anyone ever diagnosed sepsis in the medical records. True?
True.
Okay. And just if you could explain for me the manner in which you were referencing the word sepsis in your report when you wrote it, please.
Yes. So to me, the definition of sepsis, it has a designated strict medical definition, and it's characterized by the body's inappropriately brisk inflammation response to an infection. I think it can be viral, it can be a fungus, That infection can be bacterial, it can be viral, it can be a fungus, or even a parasite that triggers the sepsis. And when that happens, there are certain events that happen in the body. And one of the common themes is that the overwhelming inflammation impacts the organs in the body to function normally. And so you see that showing up as sometimes evidence of kidney issues, evidence of confusion, sometimes worsening respiratory function, sometimes liver failure. I mean, the list of organs that are impacted or can be impacted is not restricted to any one organ in the body. And so that's, to me, the definition of sepsis, but there are criteria that are used for diagnosing sepsis, and that involves a combination of clinical findings of organ dysfunction in the body, of which Ms. Schara had evidence of brain dysfunction because her cognition was different from baseline, and had evidence of respiratory failure because she couldn't support her breathing on her own without added oxygen and machines to help her breathe. It also depends upon presence of certain vital signs and lab to add to the certainty of the diagnosis. And so the time in my report, when I stated she had severe sepsis, was a time where she had displayed low blood pressures, elevated respiratory rate as well. And I can pull up some of the other features of it that led to that conclusion. But that's the background of it. And so, Ms. Schara, in a sense, met criteria for that, and she was treated for sepsis because she was given the supportive care to try to have her make it through and survive her COVID infection. Where is that? Just looking at the page of the report where I mentioned that.
How much more do you have, Attorney Kowiak?
Another maybe 5 or 10 minutes.
Yeah.
I know you said 30 and we're at 27, and I want to give them enough time and the jurors enough time before 5 o'clock. Unless your witness is coming back.
Let me ask the next question, Doctor. The fact that the word sepsis does not appear in the medical records does not concern you in any way?
No, it doesn't change my conclusions in the case whatsoever as to what transpired in this case, because the treating physicians took care of her as if she had sepsis.
You call it sepsis, they call it something else, but the clinical situation is exactly the same.
The outcomes are the same based on management. If the term sepsis had been listed in the medical record, her care would have been the same.
Okay. Do you have in front of you a document? This was brought up to you as a policy called Response and Recovery Resources. Do you have that?
Somewhere in this heap, yes. I think I have it.
Doctor, you were asked questions about that where you were read a portion of that policy, if you can find it, that said visitors are not allowed unless they meet the following exemptions, and one of them was a designated support person. Do you recall being asked that?
Yes, I have that.
That was number 9. Well, when we look up at number 2 on that same page there's a little section that says all approved visitors must screen negative, no symptoms or fever, per the most updated visitor screening tool, per the latest Centers Disease Control Symptom List, see references. And then there's a couple of little sections, A, B, and C under there. And C reads as follows. Any visitor that feels ill while visiting shall immediately report this to the patient's care team and depart the building immediately. Did I read that correctly?
Yes.
Okay. So in this particular case, Mr. Schara was indeed, an exception was made for him to enter as a designated support person because he was in the room for the first 4 days of hospitalization. We can agree with that.
Yes.
Okay. That complied with the policy.
Yes.
Okay. And then Grace's sister was allowed to take his place subsequent to his leaving the hospital. True?
True.
And Mr. Schara, ill while visiting, and was required under the policy to immediately report this and to depart the building immediately. Under the policy, that's exactly what happened, correct? Okay. Doctor, I'm almost done, but I want to ask you, you were asked some questions, Precedex and package inserts. You recall those questions?
Yes,
All medications have potential side effects, don't they?
Do.
If I looked at the package insert for Tylenol, is it going to warn me of the risk of death?
potentially. I mean, there's potential side effects from every medication we take, whether it be prescription medication, over-the-counter medication, herbal medications. And so the list for every medication is extensive.
And the goal is to weigh the clinical or therapeutic effectiveness of the medication against the potential side effects.
And that's with any treatment decision that we make. That's a universal for all treatments that we deploy. The risk versus benefit is always a calculation that we make.
Not just for Precedex, but for anything.
Correct.
Okay. Do you hold an opinion in this case that the use of some nebulizer would have made any difference in Grace's case?
No.
Okay. Do you hold an opinion that Grace's hypoxia was caused by Precedex?
I do not hold that opinion.
What caused her hypoxia in your estimation?
COVID disease caused her hypoxia.
Okay.
We also know that she had hypoxia even before Precedex was administered to her.
Okay. That's all I have. Thank you.
Okay, Attorney Guzzi? Anything?
Judge, thank you.
Attorney Boylan?
Judge. Dr. Fisk, you testified that billed 32,000, no, I'm sorry, I'm going to skip this. Dr. Fisk, you testified that during COVID, the standard of care changed for the entry of a DNR order, and that it was no longer required to be in writing and signed by the patient or the advocate. Do you remember that?
Tony?
It's cross-examination, so you can either agree or disagree.
I did not testify to that.
Did the standard of care change for the simply that it needed to be entered in the electronic medical record rather than signed on paper? Is that what you said?
So a DNR order needs to be signed by a physician, and documenting an informed consent discussion has occurred.
And you testified that if the patient or the power of attorney did not also sign it, two doctors should enter that DNR order. Is that right?
Oh, no, I that. I testified that in extraordinary circumstances, when a patient cannot provide the informed consent or their power of attorney or representative is not available to have the informed consent discussion, that is when DNR orders can be ordered by two physicians. So an example would be if a patient is in an ICU and is imminently dying, and that patient has is not alert, they're comatose, and there's no family or representatives available on behalf of that patient, the decision, if two doctors discuss the case, review the case, and concur, the decision can be made at that point when two doctors sign the order to have a patient DNR, so that they're not put through measures that are futile and can be very painful and prolong suffering.
What prevented the power of attorney from signing a DNR order because it was COVID?
I'm not quite following your train of thought. I'm sorry.
It had been in writing because it was COVID time. Like you told me, I believe that the patient or the power of attorney needed to sign the DNR order.
If they're present, they don't need to sign the order, but they have generally, if in a facility, they have the ability to sign often what's called a POLST form that can endorse that approach.
If they're not present, isn't there a way to get it to them electronically? We've talked about a lot about there's electronic communications available with the family. They couldn't get,
The post forms, to my knowledge, are only paper documents.
you can PDF a document and email it over, can't you?
Well, my understanding of a pulse document is that it is limited to in-person discussions and in-person signatures, not in an electronic format.
And something as important as life or death, the hospital is incapable of making a document available electronically.
That's not my understanding is that that's not a hospital decision. That's a larger decision on the availability of post forms in general.
What prevented Dr. Shokar from having a second doctor sign on to this order?
Yeah,
That's sustained. So next question.
Emergency use authorization therapies require informed consent because they are experimental.
many of them are when you do, it means what you mean by informed. It depends upon what you mean by informed consent. Do they require separately signed consent documents? No. They're under emergency use authorization. So, for example, we regularly prescribed remdesivir or Regeneron or other things under the when they were under the emergency use authorization phase before they had full approval, without additional consent documents being signed. We did have discussions with the patients or their representatives, and in those discussions went over the risks and benefits and fact that the drugs did not necessarily have full FDA approval.
Okay, this document from the New England Journal of Medicine about vaccine effectiveness, do you still have that in front of you? And there's a highlighted part that you referenced. When it says vaccine effectiveness, the effectiveness of a vaccine is not talking about what prevents death. What else is it talking about?
Yes, it also can attest to reduction in incidence of disease.
Symptoms or spread?
No. What do you mean by symptoms or spread? It can.
You won't get this disease if you get the vaccine.
I'm not quite sure what your question is, so you're making a statement, but please clarify for me.
A vaccine's effectiveness is not a reference to whether or not it prevents death. It's a reference to other factors, yes?
Yes, a measurement of vaccine effectiveness is reduction in disease onset, but there were also evidence of separately statistics about reduction in death rates.
This is my last question, unless you don't answer. Where in this highlighted portion does it say that it is 90% effective against death? Where is the word death?
In the highlighted portion, I do not see that, but I recall from review of the article when it looks at mortality issues and also the other article, that was the big picture conclusion of the reduction in death rates.
Said that was my last question. It's not
Okay,
there.
so at this time, jurors will have questions, or do any members of the jury have questions? You can just raise your hand. And Kevin, so it looks like we have 4. Okay, so we can hand those up to the bailiff and we'll start circulating them. We'll start with Attorney Frankowiak. Start, getting them out on this side. As these are being circulated, I'm just going to use the time to try to have a conversation with the jurors. So tomorrow we're going to start at 8 o'clock again. When you leave here, if you would like, when you walk back to the jury room. If you'd like to start a little later based on us going late today, just let the bailiff know. And whatever you agree on, I'd like to get that back to me within a couple of minutes because I'll be in here with the attorneys. And if you can agree on a different time, just let him know, and then that'll be the time, and then work it out on you know, going to be arranged in the morning. I think the plan will be to go until 4 tomorrow. I don't want to start at noon. So remember, like what I told you the first day is the latest that I'd be comfortable starting is 9 o'clock. And if that's what you decide, that's great. The attorneys and I would just show up, and we have enough work to do that we could utilize that time. But if you want to start at 8, if you're okay with that, I think that'd be my preference. But I'll kind of put that in your lap. I think the plan is still what I had told you, meaning we're looking at the end of evidence probably on Tuesday, maybe spilling into Wednesday. We've been trying to do a lot of work. We're getting issues resolved so that there's not a lot of time between when the evidence is done and when we start reading the instructions. But I envision we probably have a day of work out here without you before that would happen, 8 to 10 hours. And I'm trying to figure out exactly how to do that with them. We've been trying to chip away, but a lot of it we can't do until it gets to the end of the case. But the idea, when we finish on Tuesday or Wednesday, there might be a couple of hours where we'd have a break, or we'd send you home if we're at noon and just say, take the rest of the day off and then come back the next day, because that'll be when you're deliberating. And I'll keep you informed on that, but we're still looking at that Tuesday, Wednesday timeframe, and hopefully deliberations would be done by Friday. But they can last as long as they want. I'm marking as exhibit number 555, questions from juror number 587. The questions from juror number 2419, exhibit 555. Exhibit 557 are questions from juror 587. And exhibit 558 will be the questions from juror number 262. And the last one is exhibit 559, which are the questions from juror number 386. And the questions are the following, Doctor. If a patient has at least 20% non-infiltrated lungs capacity, could that person survive?
The answer I would offer to that is yes. More likely they would not, but survival depends upon much more than just what percent of the lung is damaged. It depends upon many other factors, such as the degree of blood vessel damage caused by the virus. We talked about how the virus invades into the blood vessels and creates inflammation and clots. It depends upon somebody's pre-existing illnesses and what illnesses that they're battling with and their so-called comorbidities before they're dealing with their COVID. And it also depends upon what treatments they receive for their COVID.
Okay, could a person survive with the lab numbers and lung capacity that Grace had if some other intervention was administered, such as sitting up, keeping head or chest elevated, or other interventions?
No.
Please clarify, are or were other favorable actions by a hospital nurse, doctor, or family available to help Grace in surviving, other than intubation? If yes, what?
What could have been, I think, done otherwise would have been receipt of the additional medicines and treatments that we talked about during her course of her hospitalization. Remdesivir, tocilizumab, and potentially convalescent plasma. Some of the patients that we saw who were on a very rapid downhill course from their COVID, and we were extremely concerned we're going to die. we saw some very impressive rebounds on numerous patients within 24 hours of getting tocilizumab.
What is the time frame of the Delta variant?
Yeah, so the Delta variant was first detected in India in late 2020, and then spread around the world and peaked in the United States in the later half of 2021.
So the time frame in the United States would be what?
I don't know, it depends what you mean by time frame, because at any one point, we're not just dealing with one variant of the virus around. At any one point during the pandemic, we might have had 20 different variants that were contracted in the United States, but there was really, the question is, what's the dominant one and which one was most prevalent, causing the most disease? And so in the States, the period of dominance of the Delta variant was from summer time frame of 2021 through the later part of that year.
So the peak in the United States would be the last half of 2021?
Yes.
Please slow down. That's written on this question from the juror. Stating the technical terminology as Grace's cause of death. So if you could just kind of say it slower.
Yes. So the death certificate, which I agree, was recorded as acute hypoxemic respiratory failure as the first item. And what that refers to is the body not having the ability to get enough oxygen in to sustain life. And that happened in a sudden fashion because of a new illness. There's another related entity of which people have chronic long-term hypoxemic respiratory failure, but Grace had the acute or new onset version of that. And the second item listed on her death certificate was COVID-19 disease.
How quickly does a COVID vaccine become effective?
It varies from person to person, but in a person who does not have a significant pre-existing weakness in their immune system, they'd start to see some benefit within a week of getting a COVID vaccine. And that benefit is in large part in full force after the second week. It varies a little bit because remember, we have multiple different vaccines available in the US, but in general, you get significant effectiveness by the second week.
Define negative pressure room. How is a negative pressure room created?
A negative pressure room is where heating, ventilating, and air conditioning systems in a room suck air out of the room and exhaust the air directly from the room to the outside of the building. And so it's really an HVAC intervention. And the idea is that instead of having more air coming into the room, that then the air goes out through the doorways like we might have in this courtroom, the idea would be that the net flow of air comes in through the doors and windows and enters to a room and out a vent, say in the ceiling or in the wall, and is that that air supply, once it's in the vent, is not recirculated into the other air for the hospital. It's exhausted directly to the outside of the building.
You mentioned a drug. Is it remdesivir?
Remdesivir?
Yeah. So I just write R on my notes when you're talking, but they're forcing me to say it. So, is that drug used as the infusion drug given to patients who have COVID vaccine shots? If not, what was?
Meaning infusion, meaning intravenous administration. Yes, that drug is provided as an intravenous drug, but there are also other medications that are provided and offered intravenously.
So is that been given to somebody who had a COVID vaccine shot?
Yes, whether somebody had a COVID vaccine or not doesn't impact whether they were administered a drug like remdesivir.
Okay.
It's really based upon their status of being admitted to a hospital and having COVID severe enough to require hospitalization.
This next one, I'm just going to read it and then I'm going to change it just so the attorneys know, but it says, is DNI, do not intubate, translate in DNR code? And I think it should be, how does DNI, do not intubate, translate in DNR code?
So do not intubate is a subset, if you will, of DNR. So do not resuscitate order means do not perform chest compressions, do not shock somebody's heart with defibrillators, and do not intubate, and do not provide emergent medication infusions to the patient if their heart stops. So do not intubate means only that. It means you can provide all the care in the world to a patient, but don't put a breathing tube in the throat and put them on a ventilator.
Case of emergency, can intubation be done to help the patient ever with a DNI order?
If a DNI order stands for a patient, they should never be intubated. I mean, can it be done? Yes. Should it be done? No, if there's a DNI order.
And is that because it'd be a violation of the DNI order?
Yes.
Okay. And then the last set of questions from the jurors are the following. Can you give specific reasons why a physician would not have to obtain consent from the patient or their power of attorney for the non-emergent administration of Precedex and lorazepam, especially when the patient or power of attorney asked at the start of care to be informed of all medications?
Yeah, the reason I would offer to that is that consent for those those administrations is covered under the initial consent for hospital services that someone agrees to, and I would leave it at that.
And are you distinguishing between consent and informed consent?
No, there's informed consent, meaning additional documents signed after a thorough discussion of risks versus benefits with additional signatories. That is not something that is done for lorazepam or Precedex.
So your answer to this question is by being admitted into the hospital, that's consent to administer one or both of those medications?
And when when somebody or their representative signs approval for admission and receiving care in a hospital.
Okay. Any other questions from the jurors for this witness? Follow-up questions, Attorney Frankowiak, based on these questions and answers.
Given how sick Grace was at the time of her arrest, is it more likely than not that she would not have survived even had she been intubated?
Oh, yes, I think by the time she went into her arrest, even if she had been intubated, her chances of survival were effectively zero.
Thank you. That's all I have.
Attorney Guzzi,
No questions, Your Honor.
Attorney Boylan.
Given the questions about the questions about remdesivir are still here, we wanted to go through a couple more records on remdesivir.
Okay, and as you're hooking that up, I will receive exhibits 555 through 559, which are the jurors' questions. I also was handed a note from the jurors real quickly, and it seemed like it a unanimous, somehow you passed a note around to vote on the start time tomorrow, and it was unanimous to start at 8. So there's, although there's only 12 that vote, or no, there's 15, yeah. So for 15-0, good. So start time tomorrow will be 8, everybody. That was impressive. I was figuring that somebody had to go to the bathroom, but it was.
My co-counsel is going to be bringing up the screen here, and this is back to the record on remdesivir. And there was some testimony you gave, Dr. Fisk, that you later saw that remdesivir was recommended.
Over on this screen. Yeah, so we're down to one screen. If you want to move over to that screen, if you want to stand over there, if that's easier.
Okay, if I need to, based on their question, I'll do that. Thank you, Judge.
All right, we're gonna do a search for remdesivir in the doc. So there's the first one.
And which document are we looking at?
It's Exhibit 1, but the entire record, I just searched all 1,000 pages. Oh, there it goes. So I searched all 1,000 pages. I just put the search term in. It found, I think, 11 pages with remdesivir mentioned. So there's the first one.
I can't read it, so could you? You have to blow it up. Like,
I'm worried anything I change is going to cause a problem.
is it touch me or not?
There we go. Didn't work for me. Oh, sorry. Direct my search. Hang on 1 second, Your Honor.
Can you blow it up? Do we have a document number page?
Yeah, this is page 17 of Exhibit 1.
So 17 of the medical record. She is not a candidate for remdesivir or convalescent plasma or antibodies. She is on dexamethasone. What page is this?
This is page 19.
The smaller remdesivir is over here. There's a discussion of remdesivir again. It says she does not really qualify for this.
It was 19. Yeah, it's your certified document.
What page is
Can I
this?
just ask, so you're going to go through 11 times. Is there a question for this witness about it?
My question is if in the rest of the 11 records we go through, it indicates that Grace was not a candidate for remdesivir. Your testimony earlier was that you had seen remdesivir mentioned in the medical record. And what you had seen was that Mr. Schara was refusing remdesivir. Is that your testimony?
Yes, I saw that Mr. Schara had stated to some of the treating team that remdesivir was not an option for Ms. Schara.
How many times did you see that?
I don't recall, at least once.
Okay, and if there's 11 other references in the record, in the medical record, by the way, how many total pages is the medical record?
Yeah, this is yeah, what's the number, Mike? 1,137.
In the 1,137 pages of the medical record, if it repeatedly says Grace is not a candidate for remdesivir, is at best that some confusion and informed with the father?
I'm not following your sort of train of thought here, but my understanding is that Grace's father stated to the treating physicians that remdesivir was not an option for treatment of Ms. Schara.
the record says she's not a candidate or qualified for it. So what did it matter?
Well,
Couldn't have helped her if she's not a candidate for it.
Sustained, and I think we have your point.
I'm sorry.
I think we have your point.
Okay, thank you.
You're representing that Exhibit 1 doesn't do it. He thinks it was in there, and someday some other witness can bring it up, or the jury can look at it. Anything else, Attorney Boylan?
One more question, and Doctor, if you are not an expert on the administration of Precedex, a lot of questions you couldn't answer about Precedex, how can you opine that her cause of death was COVID if you don't know what exactly impact Precedex had on her body?
so as I said, I'm familiar with Precedex and see it used, and I'm familiar with its use and its impact on my patients. But in reviewing this case, there was enormous amounts of evidence for COVID infection and progressive COVID disease leading to decline, things that had no relationship to Precedex whatsoever. Precedex doesn't give you lung infiltrates. Precedex does not cause a COVID antigen home COVID test to be positive. And she had many of the symptoms at the time of her arrival to the hospital that were associated with severe COVID. And at that point, we know she had a significant risk of death even when she hit the door and came in the door at the hospital, and she'd never received Precedex. So I think in a case like this, when you have limited use of Precedex in her case, and you have a progressive downhill course of steady decline where death from COVID is identified as likely several days before her death. And as the date of her death got closer, the likelihood of that increased. I think the evidence is quite compelling that this was a COVID-related demise.
Did you say limited use of Precedex?
Yes. And I say limited because it was not used throughout the entirety of her hospitalization.
There might be another juror note, so.
Yes, not a question for this witness. I know you have a question, Attorney Frank. I just want to make sure. No other questions from the jury for this witness, and I'm going to give you the last say. So, you can follow up, Attorney Frank-Koliak, if you have questions.
Just one follow-up, because I just want to clarify our record. Matt, can you put 445 up on the screen, please?
As that's being put up, I'm going to answer the questions that the jurors sort of asked. So when you're deliberating, you will be potentially allowed to review exhibits. That's my decision to make. Just like when I allow you to ask questions, my rule is generally I'm going to give you what you ask for if you need something, because we want you to have what you want, but we're not going to throw at you 600 exhibits and throw them in a stack for you. And then specifically it was, would that include the entire medical record or just marked exhibits from the medical record? And I think it could be any of it, depending on what's asked for or what's needed, and then what I think would be best given the situation we're in. So it's kind of up in the air. So you will have the chance to do it, but I would encourage you that as these exhibits are going in right now, don't tune it out and, pay attention and put it down and kind of take it that this might be the last time you see it, in case it doesn't come into the jury room. Okay.
Doctor, I just have one clarification for you. You were asked a number of questions about notes that involve the word remdesivir. We marked this and we recently looked at this. This document, doctor, it looks like it's date of service 10/7/21. Did you see that? Okay, and you also look at admit date to the hospital was also 10/7/21, right? This was the day she was officially admitted to the hospital.
Correct.
It also indicates that this is an infectious disease consultation up on the top right there. You see that?
Yes.
Okay. An infectious disease doctor would be the one having conversations about medications to be administered for treatment of COVID.
Yes, but it also can be discussions that are held by hospitalists if a patient's on the floor, or critical care physician if they're in the ICU.
Okay, and let's go down to the end here then. And we looked at this a little bit earlier here. This was, just so the record is clear, when we look at number 4 there, no, number 3, I think we're there. When we look at number 3, it says we discussed several different treatment modalities that we have for COVID with regards to remdesivir. She does not really qualify for this, but he informed me he did not want to be on this drug anyways. This statement that you read and that you remember reading in the record was made by Mr. Schara on day 1 of the hospitalization.
Correct.
Okay. The provider, the infectious disease doctor, knew on day 1 that he did not want to use medication, according to the record?
That's right.
Okay, that's all I have. Thank you.
All right, at this time, members of the jury, we're going to be finished for the day. Thank you for sticking around later than the normal time. We appreciate it. Just a reminder not to discuss this case with anyone, including each other, and we'll see you tomorrow morning at 8 o'clock. You may step down and just do the move. Thank you. All right, you may be seated. This is a hearing outside the presence of the jury. And just a couple of things. It's late, so the juror that I noticed maybe had her eyes closed. I didn't notice it the rest of the afternoon. I don't know if anybody noticed anything. Okay. The exhibits, I think it was kind of a mess, despite as insistent as I wanted to be on this, but my understanding is, plaintiff, you're gonna work with to get 82, 83, and 87 marked in hard copy, and those are received. 84, 85, and 86 are received, and those have already been marked. And then Attorney Frankowiak, my understanding is 445 and 446, which each are 2 pages of exhibit, will somehow be marked and received as well, right?
Yes.
Okay, so that'll all get done, and that takes care of exhibits. Anybody have questions on exhibits? My understanding is, Attorney Guzzi, I'm gonna get a brief from you tomorrow on the battery issue. Is that right? Okay, and I'd like to ask if anybody has updates or modifications to your jury instructions or special verdict forms. I'd like to have those on by Friday at noon. Or maybe Friday at the end of the day, or Saturday by noon if you want that much, but I'm gonna be working on them over the weekend. So I've been working on them now, and I'd like your inputs. If you don't give me anything, you haven't argument or anything, but if you want input into what I'm doing, you get those to me as soon as you can.
Your Honor, I mean, just about the briefing, and they're gonna put a briefing tomorrow. Our brief was, rapidly developed.
Yeah.
I want to talk with everybody about what we may want to add to that. How much time would we have to add or get it to you? When do you want to read it?
You do whatever you do. Just keep me posted. Okay, so I'm not gonna decide anything tomorrow when I get their brief. The last thing is, what's the plan for tomorrow? Defense, who are your witnesses?
Dr.
Been left alone.
Okay, and then from there, I'm still waiting for those to be short.
I was told yesterday that we were definitely going to be pulling through 3 different witnesses. I had one waiting all afternoon, and I had to send him home.
The third one that you listed is, who's the third one?
And Sylvia, and the potential third one would be Haynes, who I had on deck for today, but we never got.
Okay. And how do you spell Sylvia?
SYLA.
Not sure if we identified that witness to the jurors. I'm going through, I know I recognize the name, but I'm going through the list that we sent out. And it's not on there, but hopefully that doesn't create any issues. Okay, so those 3 for tomorrow. And then Friday will be a couple more.
Get Dr. Beach, at 8 o'clock. Everyone wants to keep driving us hard. 8 o'clock, and then be at
I believe a nursing expert is also scheduled for Friday as well.
Okay. All right, well, I appreciate everybody's work today. Yes.
As far as Dr. Beach is, I expect her to be probably similar to Dr. Binstock. So, about Thursday, but there might be potential for an early hour to support one.
Okay. I think, I mean, the stuff I'm seeing, I think there'd be a benefit to that, but I'm,
Yeah, I agree.
I mean, it's a long week for them.
We're still, I mean, I think the way it's set up, and I think of the Appleton attorney Frank Boyack, that's starting to sound like we may be able to wrap up our side of the case Monday, Tuesday morning, maybe. I'll be calling. I think that's where we're at. I don't know what to do.
Okay.
I would sounds to me like the latest we would close we went.
Okay, so why don't we maybe talk at the end of the day tomorrow, see what we can get through tomorrow, and then we'll have a better idea on Friday, and at some point, I might mention that to the jurors and see what their response is. It's not gonna make much of a difference at the end. I mean, that's, at the end of the day, it's, if we could get it done by Friday, and it'd be, just overall, so I just seeing some slowing down here with the jurors, and it's hard on all of us. And then we say, okay, you're a juror and you're sitting here all day, it's a long week. And I think sometimes you just gotta step back and appreciate it. And look at them and, yeah, because of high school graduation of somebody, is that right? Okay. Think it through, and I'll wait to hear from everybody tomorrow. Thank you.
We close out yet another interesting day in the Schara trial. I have to say that today was just upsetting. The first witness being a radiologist who basically testified that she died of COVID based on what they saw in the lungs. And then the last doctor, Dr. Fisk, a true COVID cultist. I can't explain it in any other way other than the fact that he is one of the propaganda cultists, even quoting 90% effectiveness in the vaccine. It's kind of just ridiculous. He also stated something extremely interesting, which is informed consent doesn't matter because you gave consent when you entered the hospital, therefore they can give you drugs without any informed consent. Because to him, informed consent is additional paperwork that isn't required. Find it to be very interesting, upsetting. Some of these juror questions towards the end make me question whether this jury is understanding of what is going on, or if they are on the COVID cult team. Not quite sure. I guess we'll see in the next few days. In the meantime, we're going to go raid Robert Gouveia, who's talking about Trump's emergency win and on appeal, and new deportation rules, and the legals charged with felonies. So, Neuro, if you want to hit that and get the raid going, that'd be great. See the rest of you guys tomorrow, right around 8 a.m. You guys have a wonderful night.